Good morning, everyone. We will start our technical session with a lecture for Dr. Ahmed Labib from the Military Medical Academy with PET-CT.
السلام عليكم جميعا، صباح الخير. هنتكلم النهارده ان شاء الله عن موضوع مهم جدا اللي هو Principles of 18 Fluorine FDG PET CT scan technique and indications. How PET works? PET scanning utilize a radioactive molecule that's similar to glucose called 18 fluorodeoxyglucose او 18 FDG. تمام اوكي. 18 fluorine FDG accumulates within malignant cells because their high rate of glucose metabolism and PET and CT scans are done at the same time on the same machine. الفكره المختصره العامه بالنسبه للبيت سي تي ان البيت سي تي بيعتبر زي ميتابوليك ايميجنج، بقدر ان انا احدد الميتابوليك اكتيفيتي، وده بيعتمد اعتماد مهم جدا على ان المالجنانت سيلز بيبقى عليها هاي جلوكوز كونسامشن عشان الاوفر جروث والنيو فاسكولاريزيشن بتحصل فيها. فانا بحقن ماده شبيهه بالجلوكوز تكاد تكون ككيميكال ستراكشر مشابه ليها جدا، بس ده راديو اكتيف تريسر، وببدا ان انا اصور البيشنت كومباينيشن ما بين البيت سي تي والسي تي سكان والبيت سكان. الميزه في البيت سي تي ان انا اقدر منه ان انا احدد الميتابوليك اكتيفيتي حتى لو مورفولوجيكال ستراكشر بالنسبه لنا تكاد تكون نورمال في السي تي، بمعنى ان انا ممكن اعمل بيشنت سي تي سكان يظهر بالنسبه لي ان هو نورمال مورفولوجي مفيش مشكله خالص فيه، بس البيت سي تي بيظهر لي ان هو فيه ابنورمال ميتابوليك اكتيفيتي، وده مهم جدا 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 في الانديكيشن في الايرلي دايجنوزس للمالجنانت ديزيز. وطبعا الراديو اكتيف فارماسيوتيكال يوتيلايز ان ذس اكزام 18 فلورين فلوردوزوكسوجلوكوز، وده فيرست ساينيسيس كان في توك بليس ان 1976 ات ناشونال انستيتيوت اوف هيلث يونيفرسيتي اوف بنسلفانيا. ككيميكال ستراكشر اللي احنا طبعا هنشوفه هو، بس في مشكله ان الداتا مش ماشيه مع الداتا، بس مش ماشيه في ده ككيميكال ستراكشر بنشوفه، بنقدر نحدد اذا كان هنا في اوبن رينج بالنسبه للدي جلوكوز اللي هو الناتشورال موليكيولز بالنسبه لنا، وده هنا كلوزد رينج بالنسبه للراديو اكتيف تريسر اللي انا بستخدمه، فهم تيبيكالي ذا سيم كيميكال ستراكشر. بيت سي تي سكانر، وده ايمج بيورينا ان التو ماشينز this is the gantry containing two gantries PET and CT on the same machine. بيشنت بريبريشن، وده مهم جدا عشان نقدر نوصل لدايجنوزس كويس، ان اهم حاجه بالنسبه لنا الجلوكوز ليفل، ان هو acceptable blood glucose level for PET scan can be achieved by keeping patient nothing per oral about 4 to 6 hours before exam. High glucose levels can make concomitation with FDG uptake and can degrade image quality and accuracy of the results. Glucose level should be less than 150 milligram per deciliter if possible for optimal image quality. Insulin administration will increase FDG uptake in the heart and skeletal muscles and liver. This will degrade the image quality and therefore the ability to detect the lesions. A minimum time interval should be about 1 hour is necessary in between insulin administration and FDG injection. Number two, diet of the patient should be low carbohydrate, high protein or high fat diet before the examination can optimize the uptake and decrease the myocardial level, because لو البيشنت عمل consumption ل high carbohydrate diet, this will raising blood glucose making competition with FDG uptake هيديني كده false negative results. Caffeine and nicotine and alcohol should be avoided for about 24 hours before the exam. Good hydration, oral hydration starting before the scan and the continued hydration after scan is recommended. To be minimize the physiological uptake, muscle uptake, patient should be avoid strenuous muscle exercise because it will causing a hypermetabolic state as the muscles, making high consumption of FDG uptake, making false negative results. Muscle relaxants should be, as the diazepam are helpful in reducing muscle uptake from stress. Laryngeal muscles uptake can minimize by instructing the patient not to talk about 5 minutes before and 20 minutes after injection of radioactive tracer. Sedation for the patient for claustrophobia and anxiety. Patient kept warm and relaxed. Patient position, the patient is lying supine, as the image illustrates the position of the patient. Those in adult patient, 0.2 millicurie per kg intravenously, and the children 100 microcurie per kg. Waiting about from 45 to 60 minutes after radioactive tracer injection, and the patient avoid movements and speech. Normal distribution and variance of FDG uptake. This image is showing the normal tissues that showing normal high uptake of FDG. All these tissues showing high metabolic rate, especially the brain. Another image showing high metabolic, showing normal distribution of FDG uptake. Standardized uptake value. وده طبعا semi quantitative assessment of radioactive tracer uptake to detect malignancy in the exam. Malignant tumors have SUV greater than 2.5 to 3, whereas normal tissues such as liver, lung, and marrow have SUV ranging from 0.5 to 2.5. باختصار الكلام ان طبعا لما الاقي ان انا وانا شغاله بقيس الاس يو في ماكس لقيته more than 3, this is significant for malignant disease. Bit limitations, the false negative results in small lesions less than 1 centimeters, and the false negative results may be seen with hyperglycemia. زي ما قلنا قبل كده ان الهايبرجلايسيميا making competition with uptake of FDG بالنسبه للليجن اللي موجود. False negative results, PET scan result can also occur in bronchoalveolar carcinoma, carcinoid, prostate cancer, renal cell carcinoma, HCC, and the cancer bladder, and these all lesions showing low metabolic rate, so that the uptake, the FDG uptake will be low. FDG may be negative in iodine-avid metastatic thyroid cancer and necrosis within the tumor, because necrotic tissues showing no blood supply, so that the diffusibility بالنسبة للتين-fluorine FDG uptake will be low and making false negative results. False positive results, and this occurs in inflammatory lymph nodes and inflammatory process, especially after the effect of therapy. طبعا كلنا عارفين معظم البيشنت عندهم malignancy لو عمل كيموثيرابي او عمل راديوثيرابي ده ما بيبقى فيه inflammatory process في الاوبرتيف بيد بتاعنا او في السايت الاكسبوجر للراديوثيرابي، وده طبعا بيعمل false positive uptake بالنسبه للFDG uptake. Benefits of PET CT: differentiation of benign from malignant lesions, staging lesions with known cancers, monitoring the effect of therapy on cancer cases and metastasis, detecting tumor recurrence, guiding radiation therapy planning. Indication, the main important indication for PET CT scan in oncological studies and the detection of malignancy. هنتكلم طبعا دلوقتي هنوري حضراتكم بعض الصور الموجوده، ده illustrate الداتا اللي موجوده breast cancer and metastasis. And this is the image. Add CT scan, soft tissue component. This is showing a high uptake. Axillary lymph nodes will be seen here, and this is multiple enlarged axillary lymph nodes في axillary tail. Hepatic deposits, subpectoral, retro lymph nodes, mediastinal lymph nodes, bony tumors or bony metastases, peritoneal deposits, supraclavicular lymph nodes, humeral deposits. Hepatic cancers, hepatic deposits, this is not will be defined at CT scan alone, but PET CT showing a high uptake as this lesion and this lesion. Another image showing a larger size hepatic focal lesion not be well defined here. Pancreatic cancers, soft tissue component showing a high uptake. genitourinary and suprarenal cancers, suprarenal mass lesion, and bilateral renal cell carcinoma. This showing left renal carcinoma and right renal carcinoma with IVC invasion. Urinary bladder carcinoma. intestinal cancers ودي بنشوف فيها هنا في الاندوسكوب showing a hyperemic ulcer, showing a high uptake by FDG indicate malignant transformation في الintestinal mucosa. Splenic cancers also showing a high uptake here. Lung cancers, soft tissue component perihilar at the right side of the lung. Mesothelioma, eccentric soft tissue component showing a high uptake. Another case of mesothelioma. Thyroid cancer, high uptake isotopic scan and PET CT scan. Another left thyroid lobe nodule, malignant transformation showing a high uptake. Gastric cancer, diffuse wall uptake tracer indicate malignant transformation and neoplastic lesions. Another case showing also uptake FDG uptake at gastric wall. Esophageal cancers, this image is showing a larger soft tissue component here. Laryngeal cancers, like this image. Pharyngeal cancers, at the right aspect, not will be defined as the CT alone, and this lesion. Orbit and the maxilla, osteolytic bony lesion at the alveolar maxillary margin showing a high uptake here. Orbital deposits. Bone cancers, large soft tissue component seen is involving lower femoral shaft and with peroosseous parasoft tissue component. Another soft tissue component paraosseous. Lymphoma and post therapy assessment, وده مهم جدا في الفول اب للثيرابي. ده بيشنت كان عنده multiple enlarged para-aortic lymph nodes وبوست كيموثيرابي. في الفول اب طبعا complete relievement للليمف نودز اللي كانت موجوده في الصوره الاولانيه. Thank you.
Thank you, Dr. Ahmed, for this elegant lecture. We will start for another next lecture. Dr. Say.
We will introduce Dr. Muhammad Hafez.
صوت بس صوت.
Dr. Muhammad Hafez. Yes.
بسم الله الرحمن الرحيم. النهارده في one of the important lecture which is the common radiological measurements. ايه اكتر حاجات احنا بنحب ان احنا نقيسها في الراديولوجي regarding السباين and the lower limb. اكتر حاجه معانا بتبقى measurement of the Coop's angle in scoliosis. Scoliosis is one of the most common radiological measurement وازاي نقيس الانجل. احنا في عندنا السكوليوزس ساعات بيبقى دبل كيرف وساعات بيبقى سنجل كيرف. طيب انا النهارده في السكوليوزس قال لك عشان نقدر نعمل ايمجينج is ordered for any patient lateral scoliosis او lumbar spine curve اكتر من 10 degree. يعني ممكن تلاقي فيه اقل من less than 10 degree فده بيبقى benign scoliosis ما يبقاش فيه اي مشكله. لو في سنجل كاسيت بيبقى ذا بيست طبعا، بالذات لو حد طويل شويه بناخده على بوستر انتيريور فيو، والديجري اوف ذا كيرف بيبقى ميجرد واتس وي كولد باي كوبس انجل. 90% من الكيرف او سكوليوزس بيكون towards the right side. بنعمل ايه عندنا؟ ده عندنا ادي اس شيب سكوليوزس. بنشوف اكتر فيرتبرا بتبقى deviated معانا to the side of the scoliosis، وبناخد عليها لاين هو بارلل للفيرتبرال اند بليد، واحد تاني برضه بارلل للفيرتبرال اند بليد، وبعدين بنقيس فيرتيكال لاين على الخط ده وفيرتيكال لاين برضه على الخط ده. الخطين دول مع بعض هيعملوا انترسكشن، هيتقاطعوا مع بعض. لما يتقاطعوا مع بعض ويبقوا انترسكتد الانجل اللي بينهم دي بنقول عليها الكوبس انجل. الكوبس انجل هي دي اللي احنا بنقيسها، ودي اللي بين كل 6 اشهر او كل سنه بيجي العيان يشوف اذا كان في بروجريس للكوبس انجل دي ولا لا. طب ايه البريكوشن اللي انا عشان اخد ده انجل مظبوطه؟ ان العيان يكون ستاندنج. بناخد من اول الثوراسيك 1 فيرتبري لحد ال 5 فيرتبري، بيكون ويل سنترلايزد، وبنعمله على اللونج كاسيت. تاني حاجة الكيرف بروجريشن بتاعنا. لو كان الكيرف من 30 ل 50 ديجري بروجريس ان افريج من 10 ل 15 ديجري اوفر ذا لايف تايم تقريبا. اكتر من 50 at maturity يعني عند الايدج اوف بيبرتي يعني بيبقى الريت تقريبا 1 ديجري بير يير. اقل من 30 at bone maturity يعني يكون الحصى العظمي بقى يعني لحم تماما وبقى فول ماتيور. ده في الغالب unlike ان هو يبروجريس معانا. دايما في الغالب الاقل من 30 دول بيبقوا كيرفات مش هيحصل فيها مشكله ان شاء الله. الريد فلاكس امتى بقى يحتاج MRI في العيان دوت؟ لو الكيرف دوت كان تو ذا ليفت سايد، لو كان مانيفستنج ببين، في نيورولوجيكال مانيفستيشن، في بندنج تيست كده بنعمله بعد ما بنعمل كوبس انجل بناخده في الستاندنج، بنخلي العيان بيبند تو ذا ليفت وبيبند تو ذا رايت، ونشوف هل بيحصل ريدكشن للكيرف ده ولا لا. ولو كان في رابيد بروجريشن في كيرف كان كريتيكال كيرف قبل كده. في عندنا برضه تو ميجرمنت مهمين جدا بنشوفهم مع الفيمورال نيك، اللي هو الفيمورال نيك انجل والنيك شافت انجل. كان زمان قبل الاكس راي كانوا بيتقاس كده بمنقله، العيان بينام على وشه ويشوف بمنقله الفيمور ديفييتد او لفه على بره ازاي. هنا بالسي تي بناخد اكزيال كات عند الني جوينت واكزيال كات عند الهيب جوينت، وبعدين ببوست بروسيسنج بناخد الاسيتابولم، ادي الشادو اوف ذا اسيتابولم والشادو اوف ذا نيك اوف ذا فيمر، وبناخد الفيرست لاين باراليل لللونج او للاكسس اوف ذا نيك، واللاين الثاني باراليل للبوستيريور surface او posterior line of the femoral condyle، ونشوف الانجل اللي بينهم. دي بنقول عليها الانجل اوف انتي فيرجن، يعني النك اوف ذا فيمر روتيتد معانا قد ايه. واحنا بنشوفها لو كانت لفه على بره او لفه على جوه تبقى انتي فيرتد او ريترو فيرتد انجل. التانية معانا اللي هي النيك شافت انجل، ان انا اقيس الانجل ما بين النيك او ذا فيمر and the longitudinal axis of the shaft، ودي بتبقى في البلين اكس راي. at birth الانجل دي تبقى 175 تقريبا 175، at child age بتبقى 125. ايه اللي بيحصل لو الانجل دي قلت بقت مثلا الاتنين مش قد بعض او بقت اقل من 120؟ هيحصل لمب شورتنج، وتلاقي التشايلد جاي بالطفل جاي ماشي على تراتيب صوابعه علشان يعوض الشورتنج اللي حصل ده. الكوكسر فالجا معانا بتبقى الانجل لو اكتر من 130، ودي ممكن تبقى تروما او كونجنيتال ديسلوكيشن بتاع الهيب من السباستيك باراليسيس، بتلاقي الانجل عندنا وتعمل لي لونج لمب في الكوكسر فالجا. انا بقيسها معايا ازاي بقى؟ هنا دي البوينت اللي فيها الكلو الهام جدا، ان انا ما ينفعش اقيسها في الاي بي العادي بتاعنا، هتديني الانجل هتلاقيها غلط. لازم بنقيسها مع الانترنال روتيشن عشان افرد النك اوف ذا فيمر، وباخد لاين هنا من السنتر او ذا نيك لونجيتيودينال لاين، ولاين تاني في النص الشافت، والانجل اللي بينهم ديت هي دي النك تو فيمر انجل. في هنا بقى كلاسيفيكيشن كده مهم جدا معانا، بيقولوا جروس موتور فانكشن كلاسيفيكيشن سيستم according لل FNA اللي هي فيمر نيك انجل اند النك تو شافت انجل بالجريدز اوف ذيس ديفورميتي. طبعا الجدول ده دايما بنحطه قدامنا واحنا بنكومنت على الديفرنت ميجرمنت في الفيمر مع النك، الاند فيرجن والريترو فيرجن انجل مع النك تو شافت انجل. هنيجي بعد كده لحاجه تانية مهمه جدا في الميجرمنت اوف ذا ني. احنا شفنا السباين، شفنا الهيب، ونشوف بقى الني اللي هي جينا فالجا اند جينا فارا. ده نورمالي معايا تبقى التوني كده اللونج لاين بارل لبعضيهم، لو خبطوا ببعض يبقى جينا فالجا، لو بعاد عن بعض يبقى جينا فارا. النورمال معانا او اللي بنقول عليها النوك ني اللي هم بيخبطوا ببعض، بنقيس حاجه اسمها الانتر ماليولار ديستانس اللي هي الديستانس ما بين التو ماليولاي، التو ميديال ماليولاي والني لازقين في بعض. يعني خلي التو ني لازقين في بعض ونقيس الانتر ماليولار ديستانس. المفروض ان هي تبقى يعني لو زادت عن 3 انش او 9 سم معناها ان في عندي جينا فارا. في الاكس راي بقى معانا في حاجه ثانيه مهمه جدا اللي هي الجينا فارا. الجينا فارا بنشوف الميتافيزيال دايافيزيال انجل، ودي بقى اللي هي مهمه قوي ان احنا بنشوف في الاطفال الانجل اللي ما بين الميتافيسيس والدايف. ده الميتافيزيال انجل وده الدايفيزيال انجل، ونقيس الانجل ما بينهم معانا لو اكتر من 18 ديجري. هنا مثلا عندنا in this case في عندنا unilateral plant disease نتج عنه جينا فار. يعني ايه plant disease؟ بيبقى عندنا في avascular necrosis بيحصل معانا او كولابس في الميديال كوندايل او ذا تيبيا، فلما تكولابس معانا هتزود لي الانجل اللي ما بين الابر اند والشافت اكتر من 18 ديجري، فتعمل لي الجينا فار. في الليجامنتس لاكسيتي وفي البلانت ديزيز ذا ميديال تيبيا بلاتو. هنا معانا ادي البلانت ديزيز، هنا حصل انجيوليشن معانا ما بين التيبيا بلاتو هنا اهوت والشافت. هنا في النورمال لاكسيتي بتلاقي الدنيا كيرفد معانا، لكن الانجل ما بين الميتافيسيس والدايافيسيس الاثنين شبه بعض، مفيش عندنا اي كولابس او اباسكال نيكوز حصل في الميديال تيبيال كوندايل. وده لو احنا قارنا الانجل ديت معانا هنا اهو، ادي هنا ما في بلانت ديزيز، هنا ما عندناش بلانت ديزيز. هتلاقي في انجل معانا برضو الني فتحت، لكن هنا هتلاقي الجوينت زي ما هو. يعني الليفل اوف انجوليشن هنا حصل عند مستوى الانجل ما بين الميتافيسيس والدايافيسيس، لكن هنا الانجوليشن عند مستوى الني جوينت نتيجه النورمال لاكسيتي اوف ذا جوينت. برضه ساعات بتحصل الانجوليشن دي معانا نتيجه الكوكسا فارا، بتبقى الانجوليشن دي معانا نتيجه الانجل ما بين النك والفيمر اللي هي نك تو شافت انجل قلت شويه، فبتعمل لي سلايت انجوليشن وتلاقيها الليفل اوف انجوليشن عند النك. برضه ممكن تبقى مور ديستال لو في سودو ارثروزس عند التيبيا، وبتلاقي الانجوليشن بتحصل عند الديستال اند اوف ذا تيبيا. يبقى احنا كده الجينا فارا دي معانا ممكن العادي بتحصل عند الني جوينت، وقلنا اشهر سبب ليها البلوند ديزيز. لو كوكسا فارا هنلاقي الانجوليشن ديت حصلت بره، وفي السودو ارثروزس بتحصل لور داون. فيسيولوجيكالي جينا فارا بتبقى الانجوليشن معانا نورمالي، وديت بتبقى عند الايدج اوف 18-12 وبت كوركت سبونتينيوسلي باي ذا ايج، يعني ليتر اون بتلاقيها يحصل كوركشن، وده ما فيش فيه اي مشكله خالص معانا، اللي هو الفيسيولوجيكال جينا فارا، ما عندناش اي بون ديزيز. اخر حاجه بقى اللي هي التي جي ديستانس، اللي هي التيبيال تيبروستي اند تروكلير جروف ديستانس، ودي من الحاجات اللي هي الجديده اللي بيحبوا يقيسوها، اللي هو الديستانس ما بين التيبيال تيبروستي اللي هي ادي التيبيال تيبروستي معانا في الاكزال كات في السي تي، والتروكلير جروف معانا. بناخد اكزال كات وبناخد اكزال كات هنا في السي تي، وبنحط الصورتين معانا على بعض، وناخد فيرتيكال هنا لاين ما بين عني ادي البوستيريور لاين اوف ذا انتركوندايل اوف ذا فيمر، وناخد فيرتيكال لاين هنا للتروكلير جروف، وفيرتيكال لاين هنا للتيبيال تيبراستي، ونقيس الديستانس اللي ما بينهم هما الاثنين، ودي نقول عليها تي جي ديستانس. برضو this is a post processing معانا. السكانوجرام واللي هو الموست بوبيلر دلوقتي، دايما السكانوجرام لما بناخده بيبقى بنقصد بيه على الاكس راي، على اللونج ستاندنج فيلم. ومن الحاجات الغلط اللي بتتعمل انها بتتعمل على السي تي سكانوجرام، هو يقصد بيها اللونج فيلم دايما. مقاسات كتيرة جدا بتتاخد حسب الريكوست بتاع الدكتور. ممكن هنا من السنتر اوف ذا هيد اوف ذا فيمر لحد السنتر اوف ذا الدوم اوف ذا تيرس عشان نقيس الهول لمب لينز. وبعدين بقى مقاسات تانية كتيرة ممكن تتاخد من اول السنتر هنا لحد الميديال ايبي كوندايل ولحد اللاترال ايبي كوندايل. ممكن ناخد من الجريتر تروكانتر لحد الميديال ايبي كوندايل، من التيبيال تيبروستي لحد الميديال ماريولس، من التيبيال تيبروستي لحد التيبيال بلافوند. التيبيال بلافوند اللي هي الانفير ارتيكولار سيرفيس اوف ذا تيبيا. انجلز برضه ممكن نطلعها كمان، اللي هي الانجل ما بين الشافت وما بين this long line او longitudinal line of the lower limb، ونشوف اذا كان symmetrical on both sides ولا لا. ولاين تاني من اول البيوبيك بون لغايه السنتر اوف ذا تيبيا، ونشوف الانجل ما بين اللونجيتودينال اكسس اوف ذا lower limb and this line. ده بتحصل معانا في حالات مثلا الفراكشرز وفي الكوركشن وانترنال فيكسيشن. ساعات بنلاقي الشافت معاه تبقى ديفيتد بره شويه او ديفيتد جوه شويه، ودي حسب الريكوست اوف ذا دكتور. المهم ان احنا في اللور لمب سكانوجرام دايما وابدا المقصود بيها لونجيتيودينال كاسيت والعيان واقف، وبناخد عليه المقاسات مش السي تي سكانوجرام. شكرا جزيلا، ميرسي جدا على حسن الاستماع، واتمنى تكونوا يعني استفدتوا بالمحاضره ديت. ميرسي.
Now we'll go to the next lecture with Dr. Layla Osama from South Carolina University with the topic CSF flowmetry imaging protocol in different clinical scenarios.
السلام عليكم. أنا ليلى أحمد أسامة، مدرس مساعد طب قناة السويس. هتكلم على السي اس اف فلومتري، ايه الايمجنج بروتوكول اللي هنستخدمه بأنهي في أي كلينيكال برزنتيشن العيان جاي لي فيها. أول حاجة انترودكشن بسيطة كده. السي اس فلو دوت بستخدمه عشان أعمل اسسمنت للتو اند فرو موفمنت للسي اس اف. هو السي اس اف عندي بيتحرك بطريقتين، يا إما ثرو الجي ليمفاتكس أو البلساتايل فلو مع الفاسكولار بالسيشنز في البرين. هو ده دور الفلو ستاديز، إن أنا بعمل اسسمنت للبلساتايل فلو دوت. بستخدم ايه في الفلومتري؟ بستخدم كواليتيتيف وكوانتيتيف اسسمنت ثرو فيس كونتراست ام ار اي. ده بيبقى تايم ريزولف 2 دي فيس كونتراست، بقيس بيه الفلو بتاع السي اس اف، وبعمل فيلوسيتي انكودنج عشان خاطر اقيس الميجرمنتس بتاعتي بعد كده. الاول حاجه، العيان اللي هيجي لي عشان يعمل فلومتري هيبقى حاجه من ثلاثه، يا اما عيان عنده هيدروسافلس. العيان اللي عنده هيدروسافلس دوت هبتدي اصور له اول حاجه اكزيال فلير عشان اتاكد اصلا العيان ده عنده فنتريكلوميجالي ولا لا. اعمل اسسمنت اشوف في عندي ترانس ابندمال بيرميشن. الترانس ابندمال بيرميشن ده بيتشاف كانه بيري فنتريكولار فلير هاي سيجنال انتنسي، ده بيدينوت ان انا عندي اكيوت هيدروسافلس، ف ات نيدز يعني انترفنشن. وتاني حاجه عشان اعمل بلاننج لبقيه السيكونسز اللي بعد كده. الصوره دي صوره اكزيال فلير، طبعا احنا شايفين فيها هيدروسافلس وشايفين ان في بيري فنتريكولار سي اس اف بيرميشن دينوتنج اكيوت هيدروسافلس. بعد كده هبروسيد اصور الميد لاين ساجيتال 3 دي ساس سيكونس. ده بيبقى هيفلي تي 2 ويتد هاي ريزوليوشن سيكونس. الغرض منه ان انا اعمل اسسمنت للاناتومي للاكوداكت اوف سيلفيوس، واعمل اسسمنت للاناتومي بتاع الفلور اوف ذا ثيرد فنتريكل. زي ما احنا شايفين هنا كده على الصوره الاكزيال، باخد كات ساجيتال في الميد لاين بالظبط واصور، هيدي لي صوره ال 3 دي ساس. هنا احنا شايفين دي الاكوداكت اوف سيلفيوس، شايفينها بيتنت وفي السي اس اف فلو ريليتد سيجنال فويد جواها. ده بيديني برضو انديكيشن ان انا عندي الاكوداكت دي كويسه وفي سي اس اف ماشي فيها. وتاني حاجه ببص عليها الفلور اوف ثيرد فنتريكل، لان ساعات العيانين اللي عندهم هيدروسيفالس بيحصل لهم حاجه اسمها spontaneous third ventriculostomy كنورمال ميكانيزم تو overcome this obstruction at the level of aqueduct. بعد كده هبروسيد لصور الفيس كونتراست. في عندي حاجتين في الفيس كونتراست بصورهم، بصور ميد لاين ساجيتال ايمجز وبصور اكزيال ايمجز. الميد لاين ساجيتال دي دورها في الكواليتيتيف اسسمنت للسي اس اف فلو، بيبقى كاردياك جيتد سيكونس، بستخدم يا اما البريفرال بالس اوكسيمتر او بستخدم اي سي جي جيتنج. ولو البيشنت عنده significant arrhythmia الفحص مش هيكمل اصلا، هيعمل انترفرنس مع الكاردياك سايكل سامبلنج ومش هيكمل معايا. زي ما احنا شايفين هنا برضو بستخدم الاكزيال وبخطط عليه في الميد لاين، اخد الصوره الساجيتال. دي صوره الفيس كونتراست، وده مكان السي اس اف فلو ثرو ذا اكودكت اوف سيلفيوس. بقول عليه ان هو نورمال امتى؟ لما بلاقي باي فيزيك فلو، يعني عندي صوره لونها ابيض واسود في الفلو. بعد كده بعمل الدايركت في البارامترز بتاعه الفيز كونتراست، بعمل برضو انكودنج للدايركشن اوف ذا فلو. متفق عليه ان احنا بنعمل الانكودنج دوت كودو كرينيال. معناه ايه؟ معناه ان السي اس اف اللي ماشي من تحت لفوق هيبقى لونه ابيض during الدايستول، لكن السي اس اف اللي ماشي من كرينيال تو كودل هيبقى لونه بلاك during السيستول. ممكن طبعا اعمله عكس كده يعني، بس يعني كل الناس شغاله الكودو كرينيال. بعد كده المفروض ان انا بروسيد للستيب بتاعه الفيلوسيتي انكودنج. هي دي بقى اللي بيبقى فيها الفرق ما بين عيان لعيان. بناء على ايه؟ بناء على ال 3 دي ساس فايندنجز. لو انا بصيت في ال 3 دي ساس ولقيت ان الاكودكت اوف سيلفيوس بيتنت وعندي كمان سي اس اف فلو ريليتد سيجنال فويد، معنى كده ان السي اس اف معدي من هنا وبز هاي فيلوسيتي، فانا هبتدي بالانكودنج بتاعي بالفيلوسيتي مثلا 10 سم بير سكند او حاجه. بعد كده هعمل الاكزيال فيس كونتراست سيكونس، بصور الايمجنج بلين بتاعي بيبقى بيربنديكولار بروكسيمال سيرد اوف اكودكت اوف سيلفيوس، هيديني صوره ساجيتال وده مكان الاكودكت اوف سيلفيوس. هبص فيها، لو انا لقينا ان في اليزنج ارتفاكت، معنى الاليزنج ارتفاكت ده ان ات ذا سيم فوكسل انا شايفه وايت اند بلاك سيجنالز، يبقى انا محتاجه اعلي الفيلوسيتي انكودنج. هعيد تاني نفس السيكونس بفيلوسيتي اعلى، ممكن اعلى لحد 25 او لحد 30 سم بير سكند لحد ما الاليزنج ده يروح. ده فايدته ايه؟ ان انا اصلا صور الاكزل دي اللي بجيب منها الكوانتيتيف داتا، فانا محتاجه استخدم اقرب فيلوسيتي للحقيقه عشان خاطر يطلع لي ارقام مقاربه للوضع اللي عندي يعني. بعد الايمج اكوزيشن هاجي على الصوره الاكزيال، هستخدم كوانتيفيكيشن فلو في الفيتري في الورك ستيشن، هتشوز كيو فلو وهعمل سيركلر روي على الريجن اوف اكودكت اوف سيلفيوس، اسلكت بروباجيت تو اول ايمجز، وبعديها الفلو كيرف هيترسم لي زي ما احنا شايفين هنا. دي الصوره الاكزيال والروي حطيته وسلكتد بروباجيت، هيطلع لي الفلو كيرف. من الكيرف اللي قدامي دوت في كذا حاجه محتاجه، في كذا رقم محتاجه اطلعه. هنا بيبقى مطلع لي الستروك فوليوم والفورورد فلو والباكورد فلو والابسوليوت ستروك فوليوم. البارامترز دي بستخدمها عشان اقيم هل هي هايبر دايناميك سيركيليشن ولا لا. وبرده بطلع البيك سيستوليك فيلوسيتي اللي هي اوطى نقطه في الكيرف بتاع الفلو، علشان برده في الهايبر كيسز اوف هايبر دايناميك سيركيليشن البيك سيستوليك فيلوسيتي بتبقى عاليه. طيب ده لو العيان عنده بيتنت اكودكت اوف سيلفيوس، لكن العيانين الاكودكت اوف سيلفيوس بتاعتهم تبقى ستينوزد او فيها انترنال ويبس او حاجه، انا الايم بتاعي مختلف خالص. انا الايم بتاعي عايز اعرف هل في اي سي اس اف معدي ثرو ذس اكودكت ولا لا، عشان هيأثر على السيرجيكال مانجمنت بلان. بعد كده بخلي الفيلوسيتي بتاعتي ايه، ممكن اخليها 3 سم بير سكند، لان انا عايزه اديتكت اقل حاجه ممكن تكون معديه عندي. بعد كده المفروض ان العيان دوت هيفرق معاه في ايه؟ هيفرق معاه في العمليه. لو العيان دوت الاكودكت اوف سيلفيوس بتاعته معدي فيها اي فلو، يبقى ده مش كومبليت ستينوزس. العيان دوت لو ما فيش اي سي اس اف معدي ثرو ذا اكودكت، معناه ان دوت كومبليت اكودكت ستينوزس. فلو كومبليت اكودكت ستينوزس ده ممكن يبقى عندي كانديديت للثيرد فنتريكيولوستومي، وده سيرجيكال اوبشن بيبقى كويس عشان يعني تو افويد الدروباكس بتاعت الشنت انسرشن. لكن العيان دوت في بلس فايندنج. لو بصينا على الفلور اوف ذا ثيرد فنتريكل هنلاقي ان هي اصلا مش موجوده، ولو بصينا في صور الماجنتيود هنلاقي ان في سي اس اف فلو معدي ثرو ات، فهو اصلا اوريدي العيان عنده سبونتينيوس ثيرد فنتريكيولوستومي. عشان كده مهم جدا ان انا في الحالات دي ابص على الفلور اوف ثيرد فنتريكل عشان نقرر بعد كده العيان هيتعمل له ايه. بعد كده لو في حاله الاكودكت ستينوزس لقينا في سي اس اف فلو معدي، ده معناه ان هو incomplete aqueduct stenosis، فالعيان لو عملت له ثيرد فنتريكيولوستومي مش هيديني النتائج اللي انا مستنياها، فالشنط هيبقى better option بالنسبه له. زي ما احنا شايفين هنا في اكودكت ستينوزس وفي ويب موجوده في الاكودكت، لكن لما عملنا الفيس كونتراست صور الماجنتيود في سي اس اف فلو معدي برضه ثرو ذا اكودكت اوف سيلفيس، فكده العيان ده كانديديت اكتر للشنت اوبريشن. برضو في حالات الاكودكت ستينوزس الكوانتيتيف ميجرمنتس بتفرق معايا في ايه؟ هي مش الارقام مش هتفرق معايا في حاجه، بس الحاجه اللي بتؤيد ان هو اكودكت ستينوزس ان انا لو بصيت على الكيرف بتاعه هلاقي الكيرف شكله ملخبط، يعني طالع ونازل مش نورمال ساينوسويدال كيرف، فده بيؤكد ان هو اكودكت ستينوزس. بعد كده الكلينيكال سيناريو الثاني ان العيان يبقى جاي عيان كياري 1 كيس. عيانين الكياري دول بيبقى عندهم مشكله في التونسيلر هيرنيشن، التونسلز تبقى نازله في الفورامين اوف ماجنم عامله كراودنج وممكن تعمل امبيدنس للسي اس اف فلو ثرو ذا عند السيرفايكومدالري جانكشن. فانا الايم بتاعي ايه؟ ان انا اعمل اسسمنت للسي اس اف فلو ثرو ذا فورامين ماجنم سراوندينج السيرفايكومدالري جانكشن. نورمالي هلاقي باي دايركشنال فلو زي هنا في الصوره دي في السيستول شايفه البلاك فلو في الانتيريور والبوستيريور سي اس اف سبيسز، وفي الدايستول شايفه الوايت فلوز في الانتيريور والبوستيريور سي اس اف سبيسز. اي كومبرومايز لاي فيز من دول او لوس اوف توتال فلو في الفيزز معناه ان العيان دوت برضو احتمال يستفيد من العمليه اللي هي الاوكسيبيتال ديكمبريشن او اودونتيتكتومي ويتحسن معايا. تالت كلينيكال سيناريو ممكن يجي لو عيان اصلا عامل سيرد فنتريكيلوستومي، يعني عيان كان متشخص ان هو عنده هيدروسيفالس واختاروا ان هم يعملوا له سيرد فنتريكيلوستومي. طيب بعد كده انا عايزه اعمل اسسمنت للفنتريكيلوستومي دي هي شغاله وويل فانكشننج ولا لا. برضو ممكن نعمل له سي اس اف فلومتري زي ما احنا شايفين هنا، ده عيان كان عنده هيدروسيفالس عملوا له فنتريكيلوستومي. لو بصينا عند الفلور اوف ذا سيرد فنتريكل هنلاقي فيه سي اس اف فلو ريليتد سيجنال فويد، معناه ان مكان الفنتريكيلوستومي هنا. تمام، هاخد الاكزيال ايمجز بتاعتي هصورها برضو بارالل للفلور اوف ذا ثيرد فنتريكل وهبروسيد. بعد كده الصوره الساجيتال هنا مبينه عندي السي اس اف ريليتد سيجنال اهي موجوده في الساجيتال. وبالنسبه للاكزيال لو بصينا هنا احنا عندنا الاكودكت اوف سيلفيوس ورا دي، بس دي مش الاريا اوف كونسيرن بتاعي، انا عايزه ابص على مكان الفنتريكيلوستومي اللي هو السيجنال اللي موجوده قدام. هرسم الروي عليها برضو وهقيس البارامترز بتاعتي، هدوس بروباجيت وارسم الفلو كيرف، هيطلع لي الفلو كيرف اللي منه هقدر اطلع برضو الستروك فوليوم والبيك سيستوليك فيلوسيتي عشان اعمل اسسمنت اتس جود فانكشننج يعني ولا لا. ثانك يو.
Thank you, Dr. Alaya, for this useful and attractive lecture.
His next lecture is for Dr. Mustafa Al-Hussein, Principal of Cardiac MR Techniques, Military Medical Academy, which is virtual lecture also.
السلام عليكم. Good morning everybody. أنا مصطفى حيدر، أخصائي إشعة تشخيصية بالقوات المسلحة، مستشفى المعادي العسكري. هي الحقيقة محاضرة النهاردة عن ال Basics of Cardiac MRI. المحاضرة أنا قعدت أفكر فيها كتير، يعني إزاي هو موضوع كبير و advanced أو dark zone بالنسبة لناس كتيرة. الناس مش عايزة تقرب منه من radiologist، أو شايفين إن هو موضوع ممكن يكون complicated شوية ومش حابين إن هم او مش متخيلين ازاي بيتعمل. انا شخصيا قعدت فتره طويله قوي نفسي اعرف هو بيتعمل ازاي او بيبقى شغله ازاي. يمكن تجربتي ديت خلتني احس ان ربما ال10 دقائق ما يبقوش كافيين ان احنا نتكلم ديسكشن كامله عن التكنيكس والفول بروتوكولز والحاجات دي. بس خلينا ناخد النهارده اوفر فيو سريع عن هو ايه في فحص الكاردياك MRI وامتى بنحتاج نعمله وفي انهي عيان وازاي بنقدر ان احنا نابروتش البيشنت او الحاجات دي كلها. فعشان نبتدي الموضوع كده احنا محتاجين نجاوب على 3 اسئله: واي وين اند هاو. اول حاجه احنا محتاجين نعرف احنا ليه بنعمل الكاردياك MRI. في اذر موداليتيز زي الايكو كارديوجرافي، زي كاردياك CT، زي الايزوتوبيك سكاننج. الحاجات دي كلها بتقدر ان هي تيفالويت الهارت والجريد فيسلز بصوره واضحه، وحاجات ريدلي اكسسبل يعني ما فيش مشاكل منها. حاجه زي الايكو موجود وبيت سايد تيست ومش مكلف قوي، على عكس حاجه زي الام ار اي اللي هي بتستهلك معانا وقت طويل جدا على الجهاز ومحتاجه بيشنت بريباريشن وكده. فامتى احنا بنحتاج او ايه الادفانتج بتاعت الام ار اي؟ هو الحقيقه الام ار اي الكاردياك ام ار اي ليه كذا ادفانتج، حاجات كتيره جدا، بس خلينا نتكلم على اهم 3 نقط، او انا في تصوري الشخصي هم دول اللي بيخلوه يسرباس اي موداليتي ثانيه موجوده للايفالويشن للكاردياك في الكاردياك كونديشنز او كده. اول حاجه المورفولوجي، وثاني حاجه الفانكشن، وثالث واهم حاجه وهي تقريبا هي ديت المين ستي بتاع الام ار اي، او هي دي تحديدا اللي ما فيش حاجه ثانيه بديل ليها، هي التيشو كاركترايزيشن. ما فيش حاجه ثانيه تقدر تعمل تيشو كاركترايزيشن للمايوكارديوم او الكاردياك ماسز او وات ايفر غير الكاردياك ام ار اي. الاذر تشويس هيبقى حاجات انترفنشنال زي المايوكارديال بايوبسي او الحاجات دي كلها، ولكن دي الحاجه الوحيده النون انفيزيف موداليتي اللي تقدر تعمل لنا تيشو كاركترايزيشن بصوره واضحه جدا. طيب هو مورفولوجي ايه فايده الام ار اي كمورفولوجي؟ احنا مورفولوجي بنتكلم على ستراكشر او مورفولوجي او الاناتومي اللي موجود قدامنا. الهارت فيه كذا فاريانتس كتيره جدا، بالاضافه لان احنا بيبقى عندنا كونجنتال انوماليز واحيانا بتبقى كومبلكس كونجنتال انوماليز بتمنع ان حد زي مثلا وانا بعمل او الدكتور الكارديولوجي هو بيعمل ايكو كارديوجرافي يقدر ان هو ايفالويت الهارت بصوره واضحه. الام ار اي احنا عارفين هو فيري هاي سبيشال ريزوليوشن، بيخلينا قادرين ان احنا نيفالويت الهارت والجريد فيسلز بصوره واضحه جدا، ونشوف الاستراكشرال انوماليز او الاستراكشر بتاع الهارت والجريد فيسلز، وبيدينا فيري هاي كونتراست ريزوليوشن نقدر نفرق ما بين التيشوز وبعضها. بالاضافه لان هو ما فيش البور ايكو ويندو او المشاكل اللي ممكن تواجه الدكتور الكارديولوجي وهو بيشتغل الايكو كارديوجرافي، ما فيش في مشاكل السي تي سواء الايونايزنج راديشن او ان ما فيش كونتراست ما بين الديفرنت تيشوز. يعني احنا عندنا ممكن نلاقي في ديفرنت تيشوز ليهم نفس الدنسيتي في السي تي مثلا، ما نبقاش قادرين نيفالويت او الحاجات دي كلها. فالام ار اي بيدينا بيتر اندرستاندينج للمورفولوجي، وكمان بيبقى في دايناميك ايمجز بتخلينا نقدر نفهم الهيموداينامكس او الدنيا ماشيه ازاي في البيشنت كونديشن اللي قدامنا. النقطه الثانيه الفانكشن. الحقيقه هي الفانكشن كانت يعني طول عمرها وهي الايكو كارديوجرافي هو الجولد ستاندرد او الحاجه الاساسيه الايفالويشن للكاردياك فانكشنز، لكن مع يعني مع الايمرجنج كاردياك ام ار اي والافيلابيلتي اللي بقت واسعه والحاجات دي، بقت كل البيبرز وكل الجايد لاينز بتريكومند مش بس ان احنا الرايت فنتريكولار فانكشنز تبقى هي الام ار اي هو الجولد ستاندرد فيها، لا بقى الرايت والليفت فنتريكولار فانكشنز الكاردياك ام ار اي يعتبر هو الجولد ستاندرد وهو الحاجه الاساسيه. وده بيرجع لان اولا هو مش بيعمل زي الايكو كارديوجرافي او الحاجات دي، هو ما بيعملش اسامبشن او ما بيعملش استيميشن للفانكشنز والفوليومز والحاجات دي، لا بالعكس خالص هو بيعمل اكيوريت كالكوليشن ومفيش انتر اوبزرفر فاريابيليتي. يعني مش انا لو انا شفت الفحص هطلع نفس الفانكشن لو حد غيري شاف نفس الفانكشن، مش هيبقى فيه اختلافات ما بيننا او اراء شخصيه او حاجات على الاكسبيرينس او كده، ما هواش اوبريتور ديبندنت طالما الفحص انا واخده كويس. النقطة الثانية ان هو بيدينا دايناميك سيني ايمجز زي اللي هنشوفها في السلايد اللي جايه، بتخلينا نقدر نعمل ايفالويشن بعينينا اللي هو الحاجة السبجكتيف، انا شايف في الفانكشن الكونتراكتيليتي كويسة ولا لا، شايف في فالفولار ليجنز ولا لا، شايف ستراكشر انومالي معينة او حاجة. ده زي الايكو كارديوجرافي، فمدينا نفس ميزه الايكو كارديوجرافي اللي هو احنا بنعتمد كمان على الاي بولينج او على عينينا ان احنا نيفالويت الهارت كونتراكتيليتي او الحاجات دي كلها. ثالث نقطة ودي نقطة مهمة جدا تقريبا، هو كاردياك ام ار اي برضه سوبيريور جدا فيها، اللي هي حاجة زي الكومبلكس كونجنتال انوماليز اللي فيها كومبلكس شانس. احيانا بيبقى عيان الكونجنتال انوماليز بتاعت الهارت ما بتجيش حاجة واحدة، يعني مش يعني ممكن يبقى حد بيشنت عنده اي اس دي بس او في اس دي بس او بي دي اي او وات ايفر الكونديشن، بس في بيشنتس كتير تلاقي عنده اكتر من شانت في اس دي واي اس دي وبي دي اي، وعنده تي جي اي مثلا ترانسبوزيشن اوف جريت ارتريز. بنبقى محتاجين نعمل ايفالويشن للشانتس ديت، كل شانت فيهم الشير يعني الجزء بتاعها عامله قد ايه شانتنج للبلاد، وهل هو هيمودايناميكلي سيجنيفيكانت ولا لا، وهل الاي اس دي مثلا هو اللي مور سيجنيفيكانت عن في اس دي ولا البي دي اي هي المور سيجنيفيكانت عنهم، مين فيهم اللي محتاج الانترفنشن، الحاجات دي كلها. للاسف هو ما فيش طريقه ثانيه اكيوريت للكالكوليشن ان احنا نقدر نطلع ايتش شانت لوحدها خلاص، لان احنا بنعتمد في الايكو مثلا ان احنا بنشوف الاورتيك فلو مثلا او حاجه زي كده، نشوف الفوليوم اللي طالع قد ايه ونشوف البالمونري اللي طالع قد ايه ونخصم ما بينهم. لكن بالام ار اي احنا بنقدر نطلع كل شنط من دول باكيوريت كالكوليشنز، والبديل ليه بيبقى حاجات انفيزيف عن طريق القسطره او كده، ان احنا نقيس بريشر جريدينتس وحاجات كده، فبتبقى انفيزيف للبيشنتس، خاصه احنا بنتكلم في النقطه ديت على عاده الحاجات الكونجنتال دي بتبقى في نيونيتس وبيدياتريك ايدج جروب، مش حلو قوي ان احنا نعرضهم لحاجات الانترفنشن قد لو قدامنا نون انفيزيف ميثود زي الام ار اي. فهو بيحل مشكله كبيره جدا اللي هي حاجه مشهوره كده، الكيو بي كيو اس والكيو بي اس كيو اس اللي هو السيستميك والبلمونري سيركيوليشن، ودول مختلفين تماما عن الاورتيك فلو والبلمونري فلو. هو الايكو كارديوجرافي بيعتمد في كيو اس على الاورتيك والبلمونري فلو، ومش زي ما ناس كتير هتبقى متصوره، لا البلمونري سيركيوليشن والسيستميك سيركيوليشن دي حاجه ثانيه مختلفه خالص عن الدم اللي ماشي في البلمونري واللي ماشي في الاورطه. مش هنقدر نتكلم عليها، بس هي بتدينا الاكيوريت استيميشن للكيو بي وكيو اس، ونقدر من خلالها نقول الهيمودايناميك سيجنيفيكانس بتاع الشانتس ديت يعني. واخيرا في حاجات زي اللي هي كانت تعتبر ادفانسد بس هي دلوقتي بقت خلاص برضو ويل استابليشد، وبقت حاجات يعني مش نقدر نقول حتى عليها نوفل تكنيك زي الفيتشر تراكنج. ده بيخلينا نقدر نعمل اسسمنت للكاردياك كونتراكتيليتي، وناسس البيشنتس حتى اللي عندهم حاجات زي الهارت فيلير ويز بريزيرفد ايجكشن فراكشن. بيبقى بيشنت عنده هارت فيلير بس الايجكشن فراكشن بتاعه او كونتراكتيليتي بعينينا احنا شايفينها كويسه. عيانين زي الاتش سي ام هايبرتروفيك كارديومايوباثي احنا بنبقى شايفين كونتراكتيليتي كويسه جدا بعينينا، وبالعكس احنا ممكن نبقى شايفين ان هو الفانكشن بتاعته اعلى من المعتاد. بس هي الحقيقه بيبقى هو البيشنت ده مش هو ما عندوش فانكشن اعلى من المعتاد، هو عنده حاجه زي الدايستوليك ديسفانكشن، فمدياني احساس بان هو ما فيش الدايستوليك فيلنج عنده وحش. ما هو مش الكونتراكتيليتي اللي حلوه، هي الفيلنج هو اللي وحش. فانا ببقى شايف ان الفانكشن كويسه جدا على الرغم ان هو البيشنت ده بيعاني من كل السيمتومز والكلينيكال كونديشن بتاع الهارت فيلير. حاجه زي الفيتشر تراكنج قدرت ان هي تخلينا نعمل استرين اناليسيز للماسل للمايكارديوم في 3 مين اكسسيز بتوعه اللي هو الراديال سترين واللونجيتودينال سترين. الحاجات دي كلها نقدر نعمل بيتر اندرستاندنج للكونتراكتيليتي بتاعه المايكارديوم، بس مش مجرد ان احنا نعمل ايفالويشن للفانكشن، لا احنا كمان نقدر ناسس الكونتراكتيليتي عامله ازاي. زي ما احنا شايفين في الصور ديت، يعني دي صور سريعه كده للدايناميك او السيني ايمجز اللي بنعملها اللي هي بتبقى بالانس ستيدي ستيت فري بريسيشن. نقدر من خلالها شايفين في اول صوره هنا ان في مايترال ريجيرج، هي يمكن بس السكرين مش واضحه قوي، بس احنا نقدر نشوف المايترال ريجيرج واضح والاورتيك ريجيرج باينين قوي بعينينا، ونقدر نعمل لهم كمان اكيوريت كالكوليشن مش بس ان احنا نشوفهم بعينينا. هنا برضو مش عارف هو الفيديو مش شغال ليه. طيب هي المفروض دي برضو يعني الفيديو هنا يشتغل السيني ايمجز ديت تخلينا نقدر ان احنا يعني احنا هنا شايفين المايترال ريجيرج برضو اللي راجع هنا، وقد ايه هو ده مودريت تو سيفير، اقدر بعينيا بس من غير حتى ما اقيسه اقول انه مودريت تو سيفير، وكمان زياده عليه ان انا اقدر ايفالويت هو كميته قد ايه. وفي الصوره الاخيره المفروض برضو لو كانت شغاله هيبقى في ترايكاسبيد ريجيرج كان واضح جدا، وان احنا نقدر نيفالويت برضو. طيب النقطة الثالثة وهي أهم نقطة للكاردياك ام ار اي، وهي ديت يعني اللي خليته سوبيريور عن أي موداليتي ثانية، هي تيشو كاركترايزيشن. احنا أغلبنا يعني في الجنرال راديولوجي عارف ان الام ار اي يقدر يكاركترايز ديفرنت ليجنز باستخدام بيزك سيكونسز زي تي 1 تي 2 والفات سات أو الفات ساتوريشن، انفيرجن ريكفري، ان احنا نشوف البرفيوجن أو الكونتراست انهانسمنت بتاع التيشو نفسه علشان نكاركترايز الليجن. فباستخدام الحاجات اللي هي السيكونسز دي، وفي حاجات في ديديكيتد للكاردياك ايمجنج بس، بنقدر ان احنا نجمع البازل بيسز عشان نوصل لاكيوريت دايجنوزز للتيشو. حاجه زي كاردياك ماسز البديل بتاعها ان يتاخد منها بايوبسي، بس انا اقدر بالام ار اي ايفالويت وافرق ما بين حاجه زي الكاردياك ميكزوما مثلا وحاجه زي اللايبوما، حاجه زي الانترافنتريكولار ثرومبس او ان هي تكون او انترا اتريال ثرومبس، وحاجه زي برضو اللايبوما او الميكزوما. حاجات زي ديت احنا بنبقى عايزين نفرق ما بينها ما بين المالجنانت كونديشنز وما بين البناين ليجنز اوف مايكارديوم. كمان في الفايابيلتي اسسمنت احنا كان طول عمره برضو المين ستي بتاع الفايابيلتي، وهو للاسف في بعض اكمل. طيب دلوقتي يعني احنا شايفين هنا الفايابيلتي اسسمنت هو قادر يوضح لنا الفايبروزز. هنا ديت مايكارديال ليفت اتريال ماس باين قوي هي بتتحرك ازاي مع مش عامله مايترال اوبستراكشن، ونقدر نعمل لها تيشو كاركترايزيشن. انا معلش يعني هحاول اتجاوز بس في الحته، يعني ديت برضو صور البرفيوجن ان قدامنا فاسكولار ماس قد ايه هنا، وديت كانت رابدومايوساركوما اوف ذا رايت فنتريكل هيوج ماس، وشايفين ان هي عامله اوبستراكشن للترايكاسبيد فالف. يعني انا هحاول اعدي الحته ديت، نخش بس على النقطه الاخيره وهي احنا بنعمل الكاردياك ام ار اي ازاي، او التكنيك بتاعنا ايه. احنا عندنا في بيزك كاردياك فيوز. البيزك كاردياك فيوز اللي هو 3 تشامبر فيو والشورت اكسس والفور تشامبر والتو تشامبر. احنا بنحول الهارت نفسه كانه هو البادي جسمنا. عندنا صور ليه اكزيال وكرونال وساجيتال. ده علشان نقدر نعمله بنعدي بكذا مرحله. الاول من الاكوزيشن بتاعنا بنبتدي بالصور الاكزيال العاديه خالص، بنطلع منها لاين معدي في الهارت بالمنظر ده، بيدينا التو تشامبر فيو اللي هو الساجيتال بتاع الهارت. وبعديها بنقطع يعني البلاننج بتاعنا بيبقى زي البوكس الاحمر ده كده عشان يدينا الشورت اكسس. وبنقدر من خلال الفيوز دي ان احنا نجيب الكرونال بتاع الهارت اللي هو الفور تشامبر فيو نقدر اللي موجود هناك، ومن خلالهم نقدر نجيب الشورت اكسس برضو. تمام، اللي هي الصوره اللي هناك. ونقدر ان احنا نجيب حاجه زي 3 تشامبر ومبينه لنا الاورتيك اوت فلو، ومبينه لنا لو في حاجات زي الهوكم مثلا او الاس اي ام اللي موجود بيبقى في الهايبرتروفيك وبستراكتيف كارديوميوباثي، نقدر نعمل له ايفالويشن كويس جدا. ده الصوره اللي هي الساجيتال او التو تشامبر فيو اللي بنبين الليفت سايد، الليفت اتريوم والليفت فنتركل، بناخده برده بالتقطيع ديت. انا مش هقدر بس ما فيش وقت ان انا اشرحها او كده. فالتيك هوم مسج بتاعتنا عشان نبقى تكونكلود بس، يعني احنا كنا عايزين ناخد اوفر فيو سريع عن هو ايه الكاردياك ام ار اي وامتى بنعمله وهو ليه سوبيريور. هو سوبيريور زي ما قلنا علشان الثلاث نقط الاساسيين اللي اتكلمنا عليهم، بالاضافه للايمرجنج تكنيكس الجديده والادفانسز اللي بقت موجوده. الكاردياك ام ار اي او كاردياك ايمجنج عموما هو فيري لونج جيرني وفيري ديفيكلت، بس في نفس الوقت هي فيري انترستنج، واللي هيخش فيها مش هيبقى عايز يخرج منها. محتاجه منك اراده ومحتاجه انك انت تبقى ابديتد، لان كل يوم بيبقى فيه جديد فيه، وكل يوم في حاجه تبقى تقدر تعرفها جديده او كده يعني. وانت مش محتاج الكاردياك ام ار اي مش محتاج بس انك تعمل فحص ستاندرد او كده، هو بيبقى تailored upon the patient، بيتفصل تفصيل على كل بيشنت كل كلينيكال سيناريو. وبالتالي انا ببقى محتاج اعرف باثوفيسيولوجي كويس جدا للديزيز، عارف هو البيشنت الكومبلين بتاعته ايه، وعندي الفيزيكس الكافيه اللي تساعدني ان انا امانيبيوليت بالجهاز بتاعي واستخدم التولز اللي موجوده قدامي عشان اطلع بفحص. في ارتفاكتس كتيره جدا بتواجهني، لو انا مش عارف ام ار اي فيزيكس كويس مش هقدر ان انا اكمل الفحص. بالاضافه لان انا لازم ابقى عارف التولز بتاعتي ايه، السيكونسز اللي معايا، وايه الحاجات اللي تخليني اوفركم الارتفاكتس او المشاكل اللي بتواجهني في الفحص ده، علشان اقدر ان انا اعمل اكزام مظبوط او ستادي مظبوطه اي حد.
Thanks, Dr. Mustafa, for this very nice and very attractive lecture. Now we'll go to the next lecture with Dr. Maram Ahmad Gouda from Banha University with the topic of basic steps of virtual bronchoscope using CT workstation.
Radiology, Banha University. First of all, multi-detector CT-generated virtual bronchoscopy represents one of the most recent developments in three-dimensional visualization techniques, which allows a 3D evaluation of the respiratory airways. Advantage of virtual bronchoscopy. In comparison with real bronchoscopy, virtual bronchoscopy has some advantage. It is a non-invasive procedure that can visualize areas inaccessible to the flexible bronchoscopy. In children and in some indication, visual bronchoscopy can replace fiber-optic bronchoscopy when this technique is considered too invasive. Values of virtual bronchoscopy. Visual bronchoscopy is able to evaluate bronchial stenosis and obstruction either due to endoluminal pathology or external compression. Endoluminal pathology by tumor, mucus plug or foreign body, and external compression either by anatomical structure, tumor, or lymph nodes. It's also helpful in preoperative planning of stent placement and post-operative assessment of surgical sutures after lung transplantation, lobectomy, or pneumonectomy. It can also evaluate anatomical malformation and bronchial variation. While the limitations of virtual bronchoscopy include high cost, lack of visual aids beyond simulated endoscopic view, difficulty in performing interactive anatomic exploration, and use of surface rendering instead of volume rendering. Steps of virtual bronchoscopy technique. A protocol for virtual bronchoscopy assessment of a 3D CT pulmonary image would have two main stages. First, pre-processing of image data, which involve extracting objects of interest, defining paths through major airways, and preparing the extracted object for 3D rendering. بمعنى ان انا باخد CT عاديه خالص للعيان في الاول، وباخد فيها الفوليوم ريندرنج عشان اقدر اخد الاكزيال وسيرشتال وكرونال ايمجز، واقدر ساعتها احط الكرسور ويمشي في الايرويز لحد المنطقة اللي أنا عايزاها. تاني حاجة سوري interactive image assessment, which involves the use of graphic-based software tools such as surface rendering views, visual endoscopic views, tube views, oblique section images, global 2D images, and cross-sectional views. بمعنى ان انا بطبق بعد ما خدت الكرسر وحددت الايرويز، ابدا احط سوفت وير معين عشان يقدر يديني الاندوليومينال فيو اللي انا محتاجاه، واقدر ساعتها اديله انستراكشن ان هو يستخدم اللون الرمادي العادي او يستخدم اللون الورد عشان يديني ايحاء ان انا فعلا كاني داخله ببرونكوسكوب وشايفه التشو بلونها الطبيعي. Step 1 procedure planning, chest CT scan with volume rendering زي ما قلنا. Obtaining a 3-dimensional 3D airway tree, extra-luminal and luminal surfaces. Select regions of interest. Autonomic methods define a procedure plan consists of airway navigation routes leading to each row. زي ما شفنا زي الصورة دي كده، اللون الأزرق ده الكرسر اللي أنا طبقته عليه عشان يقدر يخش لحد near terminal airways سواء على left side أو على right side. ودي صورة لما أنا بدأت أخد الاندوليومينال وبدأت أمشي ورا الكرسر، فبدأ يجيب لي البايفوركيشن عند الكراينة، وبدأت أخش ديب أكتر على الرايت وعلى الليفت ولحد ما يجيب لي النير تيرمينال ايرويز. وده صورة من الفيديو اللي أنا بحصل عليه. Step 2 Image Guided Bronchoscopy. The live bronchoscopy video source and current route location depicted a CT-derived virtual bronchoscopy view, plus a display which saves a previously registered video visual bronchoscopy view. Sorry. أنا دلوقتي حالة كانت عندنا في الجامعة. Male patient 30 years old complains of a progressive dyspnea, give history of previously ICU admission 6 years ago with history of intubation. Since then, he had that dyspnea. His clinician referred him to us due to failure of fiber optic bronchoscopy. لما عملنا له السي تي الاول بالام بي ار وخدت السيرجيكال ايمج، فشفت ان في 3 ليفلز من الاستينوزس هنا كده، واحده عند السوفت بالات، وواحده عند الجلوتيك ليفل بسبب posterior بوليب، وواحده تحت انفراجلوتيك. ودي كانت صوره لما طبقت 3 دي وخدت 3 دي لللنج. بدات اطبق البرونكوسكوبي. طبعا انا هنا عرفت ليه السبب، ان الدكتور ما عرفش يعمل له الفيرتشوال الريال برونكوسكوبي، لانه هو داخل من النوز، هو ما عرفش يعدي الاوبستراكشن الفيرست ستينوزس اللي هو يكاد يكون عامل نير توتال اوكلوجن للمنطقه دي، فما عرفش يعدي منها. فانا عن طريق الفيرتشوال برونكوسكوبي بدات اطبق الكرسر من هنا كده من بعد ما عديت الفيرست ستينوزس، وبدات ادخل. فشفت هنا افتر باسنج فيرست ستينوتيك ليفل كان اليومن دايليتد، ويعني مش دايليتد، نورمال كاليبر وعادي. بدات امشي فيه شويه، فبدات اشوف من بعيد ان في حته ستينوتيك انا هعدي عليها. بدات امشي كمان شويه، فلقيت في الحته الستينوتيك باينه اهي، وجنبها البوليب اللي انا كنت شايفاه اصلا هنا كده ظهر لي بالمنظر ده. وبعد كده عديت منطقه البوليب ونزلت شويه، نزلت بقيت عند المنطقه هنا كده. فدلوقتي انا في الكاليبر الواسع وشايفه ان في ستينوتيك ليفل تاني انا هعدي فيه، بس ما فيش حواليه بوليب ولا في اي سوفت تيشو ولا في الفيو. هنا الصوره دي بعد ما انا خلاص انا عديت في نقطه في الستينوتيك ليفل ده، وبدات اعدي اللي هو هنا كده، ان انا عديت الستينوتيك ليفل وبدات اشوف بعدي في التراكيه وشفت الكراينه والبايفوركيشن. وبالتالي لما جيت اعمل ريبورت للعيان ده قلت CT aided virtual bronchoscopy reveals 3 laryngeal stenotic levels post intubation sequelae as follows. The first one at the nasopharynx site that near total occlusion. The second at the glottic region caused by polyp 1 by 1 cm. The third at the subglottic level. Take home message: so a virtual bronchoscopy offers a unique opportunity for exploration and quantitation. It can't replace a real bronchoscopy, but it can be expected that in the near future the technique of virtual bronchoscope will find a place in the daily routine. بس معايا فيديو للحالة نفسها عشان نقدر نشوف، بدل ما هي صور بس كده ممكن نشوف فيديو كمان ليها يبقى أفضل. وده الفيديو بتاع البيشنت نفسه، حبيت ان انا اعرضه. جبت ده 3 دي، ده بعد ما خدنا السي تي العاديه خدت ال 3 دي، و 3 دي موضح طبعا 3 ستينوتيك ليفل اتكلمنا عليهم، والنير توتال اوكلوجن اللي عند الليفل بتاع النيزوفارنكس. طبعا انا هنا لما جه زي ما قلنا ان اللي يخش الفايبر اوبتيك برونكوسكوب ما عرفش يعدي انه البيرس ستينوتيك ليفل ده، عشان كده حولهم. احنا لما جينا هنا طبعا لو كنا رسمنا الكرسور من اول هنا برضه ما كانش هيقدر يعديها، فبدانا نرسم الكرسور من بعد الفيرست ستينوتيك ليفل. فالفيديو ده هيبقى من بعد الفيرست ستينوتيك ليفل. بدانا ننزل تمام. بدات اشوف من بعيد ان انا في ستينوزس، سكند ستينوزس انا هعدي عليه. واما وصلت عنده لقيت ان جنبه البوليب اللي وصفناه قبل كده اللي هو 1 في 1 سنتي، وكاني ماشيه فعلا بالريال برونكوسكوب. هيجي عنده الكرسور هيحصل له ايرور كده وهيفضل يلف حوالين نفسه على ما يقدر يعدي من النقطه الستينوتيك دي زي ما هو واضح، لحد ما قدر يعديها. انا دلوقتي في المنطقه اللي هي النورمال كاليبر بتاعه البوست سكند ستينوتيك ليفل، وشفت حواليه ان انا فعلا هعدي تاني من ثيرد ستينوتيك ليفل، بس مفيش حواليه بوليبز ولا في حواليه اي سوفت تيشو. فبدأ هنا يعدي من الستينوتيك ليفل لحد ما رجع تاني للنورمال كاليبر بتاعه. وشفت من بعيد ان انا داخله على هي التراكير رينجز زي ما هي باينه اهي، وفي هنا النقطه بتاع الكراينا. اقدر اخش ساعتها بقى على الليفت سايد او رايت سايد. بس هو واضح ان انا المشكله عندي كانت في الرينجيال ليفلز، عشان كده اللي باين. دلوقتي انا صورتي وانا راجعه كاني خارجه بالفايبر اوبتيك برونكوسكوب، وحصل برضو الايرور اللي بيحصل عشان اعدي من الستينوتيك ليفل اللي هو عند البوليب لحد ما قدرت اخرج منه. ده البوليب خرجت خالص. تمام، شكرا and thank you.
And now next speaker we have Engineer Muhammad Saleh from the Military Medical Academy, and he will talk to us about one of the most interesting and booming areas in the imaging. It's the artificial intelligence in the medical imaging.
المفروض حضرتك ايميل بس مش مشكله. المفروض اللي هو ايميل اللي رده.
طب سوري يا جماعه، I'm so sorry. هو المفروض السيكونس دلوقتي الدكتوره ايمان فتحي بنها يونيفرسيتي والتوبيك عن the ABC paved way for the MRCP.
انا رحت على
سوري دكتور مهندس محمد، سوري.
هنا الكرسي شغال حسب كيف الاثنين خلاص اوكي هشاور من هنا هيسمع هنا صح كده؟ ماشي اوكي. ماشي اوكي شكرا. السلام عليكم. انا ايمان فتحي مدرسة اشعة في جامعة بنها. هتكلم briefly عن ال MRCP. MRCP is a non-invasive method that's widely used in evaluation of pancreatopbiliary disorders. As opposed to endoscopic cholangiopancreatography, MRCP depicts biliary ducts upstream and downstream from eventual lesion, as well as extraductal diseases when combined with additional T1 and T2 weighted images. These capabilities are some of the most useful characteristics of MRCP. MRCP is indicated in cases of cholestasis and cholestatic syndrome, eventual evaluation of biliary anatomic variations, pre-operative of hepatic resection, biliary post-operative evaluation, diagnosis and evaluation of primary sclerosing cholangitis, unsuccessful ERCP or contraindication, pancreatitis of unknown etiology, biliary enteric anastomosis. Regarding to the advantages of MRCP, it is a non-invasive modality, doesn't use ionizing radiation, less operator dependent than ultrasound and ERCP, allow detection of extraductal diseases when combined with T1 and T2 weighted images. Regarding to the disadvantages of MRCP, it is an expensive technique when compared to ultrasound. It requires patient's cooperation, inability to intervene or take biopsy when compared to ERCP, poorer spatial resolution and definition when compared to ERCP. MRCP is based on heavily T2 weighted sequences. The fluid-filled structures in the abdomen have long T2 relaxation time as compared to the surrounding soft tissue, and this results in increased duct to background contrast. First of all, the patient have to fast for about 4 hours prior to the examination to reduce the gastroduodenal secretions, reduce bowel peristalsis, and to promote distension of the gallbladder. MRCP is performed on 1.5 Tesla or superior MRI system using phased array body coil. We have 2-dimensional images and 3-dimensional images. The 2-dimensional images are threshold that guide for thin slab acquisition for fine details of biliary ducts and pancreatic ducts. The 3D images are respiratory trigger to allow MPR and 3D reformatting. There is a special technique of post-secretin administration acquisition MRCP with IV intravenous administration of secretin that stimulate the pancreatic secretion and allow visualization of the pancreatic ducts. MRCP sequences are heavily T2 weighted images to visualize the biliary ducts, gallbladder, and pancreatic duct. It can be completed with MRI sequences like T1 and T2 weighted images, as well as endovenous paramagnetic contrast administration depending to the imaging findings, which include suspected or confined neoplasm at the pancreas, gallbladder, or biliary ducts, for better evaluation of infections such as cholangitis and abscess, for better evaluation of pancreatitis such as to differentiate edematous from necrotizing, and evaluation of complication, as well as analyzing pathologies not related to the bile ducts. This diagram shows the biliary ducts and pancreatic ducts that will be explained on MRCP image. Here we can see the right hepatic duct, which is divided into anterior and posterior branches. The anterior branch is vertical and the posterior one is horizontal. Then the left hepatic duct, right and left hepatic ducts are joined together to form the common bile duct, common hepatic duct. Then the cystic duct that joins the common hepatic duct and forms the common bile duct. Here the pancreatic duct joins the distal end of the common bile duct to open as the second part of the duodenum via ampulla of water. There is an obstruction pattern related to the biliary tract diseases that differentiate between benign and malignant causes. Regarding to the benign causes, it's usually abrupt, regular and smooth-shaped obstruction. We can see rounded filling defect or meniscal-shaped lumen termination typically in cases of calculi. We can see rounded compression of the adjacent bile duct due to extrinsic inflammatory diseases such as chronic cholecystitis and pancreatitis. Short focal structure or short segmental duct occlusion can be seen in cases of post-operative fibrosis. Regarding to the malignant obstruction, it is usually asymmetric, long and irregular shaped obstruction. We can see concomitant dilatation of biliary and pancreatic ducts if there is distal lesion. In this case, we can see rat tail shaped structure as a distal part of the common bile duct with secondary dilated common bile duct and intrahepatic biliary radicals. Here we can see two rounded focal lesions, rounded focal filling defects at the distal end of the common bile duct with dilated common bile duct. In this case, we have 2D6 lab MRCP that shows the distal end narrowing of the common bile duct associated with dilatation of the common bile duct. At T2 weighted image, we can see peripancreatic fluid and fat trending. These findings are concomitant with acute pancreatitis with secondary obstruction and dilatation of the biliary ducts. In this case, coronal microformatting image shows dilatation of the intrahepatic bile ducts. The right and left hepatic ducts are dilated and discontinuous with the common hepatic duct. We can see the common bile duct and pancreatic duct of normal caliber. At axial T2 weighted image, we can see high signal intensity tumor at the porta hepatis, which causes the secondary dilatation of the intrahepatic biliary radicals. At coronal MRCP microformatting, we can see dilated intra and extrahepatic bile ducts, as well as dilatation of the main pancreatic duct. T2 axial T2 weighted images shows tumor mass in the pancreatic head, which is compatible with adenocarcinoma. Thank you.
طب next speaker مهندس محمد كده خلاص because you are the final one so no mistakes now. زي ما قلنا ال artificial intelligence one of the booming and most interested and futuristic fields في ال medical imaging.
Assalamu alaikum. Our topic will be on the artificial intelligence in medical imaging, and our agenda will talk about the definition of the artificial intelligence, its history, the subset of the machine learning, which is the artificial intelligence, the machine learning, deep learning, the types of the artificial intelligence, and example. Then the artificial intelligence in radiology, is it a threat or opportunity? The role of radiographer, artificial intelligence impact on the medical imaging, and then the conclusion. First of all, we will talk about the definition. What is the artificial intelligence? It's the process of building intelligent machines from huge volume of data. Systems learn from past learning and experience and perform human-like tasks. The beginning for the artificial intelligence. The first question was by Alan Turing in 1950 about can the machine think like human? Alan suggested that the human use available information and the reason to solve a problem and make decision. So why cannot the machine do the same thing and act like human? 5 years later, the proof of concept was initialized and the first artificial intelligence program was presented at Dartmouth Summer Research Project, which was hosted by John McCarthy in 1956, and this was the real start of the artificial intelligence. Later on, during the many development, it was extracted from the artificial intelligence, the machine learning, and the deep learning. First of all, the artificial intelligence was depending on making intelligent machines, programmed learning machines. The development of the artificial intelligence later on was the machine learning, which to learn without being programmed. Later on, it's developed for the deep learning, which is to act like the artificial neural networks, like designed to simulate the human minds on all of its capabilities, like seeing, understanding speech, composing, hearing. فالماشين learning والdeep learning يعتبروا subset من الارتفيشال intelligence. كان التطور الطبيعي للارتفيشال intelligence. As an example for the machine learning, like the online recommendation engine from Facebook, Netflix, Amazon. The more deep learning is a subset of the machine learning and it's more advanced. The concept of the deep learning works with the artificial neural networks, which are designed to simulate the human minds in all capabilities. As an example for the deep learning, let's say the goal to have a neural network recognize photos that contain a dog. There are many types of the artificial intelligence and divided into two categories based on the capabilities or the functionalities. The first one category, based on capabilities, divided to narrow or general or super artificial intelligence. The narrow, it's called the weak artificial intelligence, and only it's very limited and focus only on narrow tasks and cannot perform beyond its limitations, such as Siri, smartphone. A general one, it's called strong artificial intelligence and can understand and learn like a human mind. The super one, it exceeds the human intelligence and perform tasks that better than the human, like solving puzzles, making judgment and making decision on its own. The other category based on the functionalities and divided into 4 types. The reactive machine, it's the primary form of the artificial intelligence that work only with the present data. As an example for this, the IBM machine, which defeated the chess grandmaster Garry Kasparov. The second one, the limited memory, like it has a memory but short-lived memory, like self-driving car. The 2 types, last types, theory of mind, which it's more advanced technology and exists as a concept and can change feelings, behavior, like robot Sophia. The last one was it's the self-awareness. It's only exists hypothetically, and this type only able to understand and evoke emotion, and also it's has its own emotion needs and beliefs of its own. As a brief for the example or the artificial intelligence, our lives, like the smart assistants in the smartphone, the disease mapping, prediction tools, manufacturing and drone robots, the optimized personalized healthcare treatment recommendation, the conversation robot for marketing and customer service, the spam filter on emails, social media monitoring tools, with TV show recommendation from Netflix. We will move to the artificial intelligence mainly in the radiology. Is it a threat or opportunity? Artificial intelligence it's not a threat to radiology, but it's a tremendous opportunity for its improvement, as artificial intelligence can be used as in the application to enhance the producibility of the technical protocols, improve the image quality, decreasing radiation dose, also decrease the MRI scanner time, optimize the stuffing with scanner utilization, thus will reduce the cost, which the main factor now in any field or any business, the cost factor. Also for the higher efficiency provided by the artificial intelligence will allow the radiologists perform a more value-added task, becoming more visible to patients and playing a vital role in the clinical teams. And to focus more in the radiology field. For the radiographer, we'll start with the role of the radiographer. The rules of radiographer perform tasks that the artificial intelligence cannot assist, like the effective communication of the radiographer with the patient itself. It's also interact directly with the patient before, during, and after the imaging procedure, and inform the patient about procedure to be undertaken, examination planning to ensure accurate patient positioning prior to the image acquisition, because inaccurate position will reduce the image quality and increase the patient dose. وده طبعا التاسكات دي او الرولز دي الارتفيشال انتليجنس ما يقدرش ينفذها، فبالتالي ان هو يأفكت على الاكزيستنس بتاع الهيومن في الجزء بتاع الاشعه. Also استكمالا للرول اوف راديوجرافر في الايمج اكوزيشن ان هو لازم بيسلكت imaging protocol based on the patient presentation, clinical question, region of interest. دي برضو من main responsibility of the radiographer. Also for the image processing, a radiographer may also have greater responsibility advising or defining and disclosing the radiation risk associated with the imaging examination. Also there is a growing role with the artificial intelligence, which for the radiographer, as all automated system must have a quality control checks, and this can be done by the qualified radiographer to take regular audit and review of the output and decision of an image evaluation system to assure that it's working properly. The second slide for the artificial intelligence impact on the medical imaging in general. The artificial intelligence could already be used to accomplish tasks with positive immediate impact, such like prioritization of the reporting, automatic selection of the finding deserving faster action, comparison of the current and the previous examination, aggregation of the electronic medical records, automatic recall and rescheduling of patients for finding deserving of an imaging follow-up, followed by also can be used for the immediate use of clinical decision support system for ordering, interpreting, and defining further patient management. Also used for the quality control of technologist performance and tracheal communication between the radiologist and the technologist. Also used for the data mining regarding relevant issue, including radiation dose. It's from all of the above, it seems that the group of human and the artificial intelligent agents working together will reach to the more accurate and better prediction compared to the human or artificial intelligence working individually. And this is promising to achieve higher level of accuracy in the imaging, diagnosis, or even the prognosis. For the last slide, which is the conclusion, artificial intelligence will surely impact the radiology and more quickly than any other medical field, as it will change the radiology practice more than anything. Radiologists can play a leading role in this oncoming change. The radiologists are used to face technological challenges because since the beginning of its history, radiology has been the playfield of technological development. There will be an opportunity for the radiologists and growing role for the radiographer with the artificial intelligence. So now it's time to work for and with the artificial intelligence in radiology. Thank you.
Thank you for this interesting lecture, and we announce for ending of session 1. Thank you.
احنا سيادتكم هنبتدي الجلسه الثانيه على طول الحقيقه، يعني هنبتدي الجلسه الثانيه عشان البروجرام بتاعنا، فهنبتدي دلوقتي على طول ان شاء الله راديشن سيفتي. فسيادتكم يا ريت تشرفوا. ازيك يا ريس؟ ايه اخبارك؟ عامل ايه؟ كله تمام الله يخليك. ازيك طبعا؟ ازيك يا باشا؟ ايه الاخبار؟ الله يخليك. الله يخليك. السكر بقى ما كانش متظبط. هو نور فين؟ نور كان لسه واقف دلوقتي. اهلا وسهلا. ازيك؟ الله يخليك. صورة بعد طبعا. شكرا. معلش يا جماعه نادوا زمايلكم بس عشان هنبتدي على طول، عشان الجلسه هتبتدي على طول دلوقتي. اسماء الجلسه الجديده لو سمحت. اسماء الناس الجلسه الجديده. دكتوره دينا، دكتوره هاني. هو كان في بريك دلوقتي ولا ما كانش فيه؟ ها؟ شغال على طول. بسم الله الرحمن الرحيم. بنرحب بيكم في بداية الجلسة Radiation Safety and Research. نبدأ الجلسة بمحاضرة عن ال Best Use of Imaging Machines يقدمها المهندس سمير عزب Military Medical Academy. Please Engineer سمير.
السلام عليكم. عميد مهندس سمير عزب، 30 سنة اكس راي قوات مسلحة. النهارده هنتكلم على البيست يوز اوف ايمجنج ماشين. انا غرضي الاساسي من المحاضرة ديت اللي انا اوصل لجميع الاستاف اللي شغال في المجال، ان كان مهندس او ان كان تكنيكال او ان كان دكتور، ازاي يستخدم الجهاز بتاعه بكيفية بيمنع الاعطال او يمنع المشاكل. لان الفترة الاخيرة التكنولوجيا عالية جدا في الاجهزة وخصوصا اجهزة الاكس راي، والتكنولوجي اتبنى على حاجتين. رقم واحد ان انا ما اعرضش المريض لجرعه اكتر من الاكس راي. رقم اثنين ان انا احافظ على التيوب عشان الكوست بتاع التيوب. التيبل اوف كونتنت، التايب اوف اكس راي سيستمز، الفلوروسكوبي، الراديوجرافي، الموبايل اكس راي، السي ارمز، الماموجرافي، الدنتال اكس راي، السي تي، اكس راي بيزكس، هاو تو جنريت اكس رايز، الفيرير اوف اكس راي تيوب، الفاكتورز افكتنج اكس راي ايميشن، الفاكتورز افكتنج ايمجنج كواليتي، واخيرا اكس راي مين بارتس. الفلوروسكوبي طبعا كلنا عارفين، وانا مش هضيف معلومه طبعا كلكم اساتذه، ان الغرض الاساسي من الفلوروسكوبي هو رؤيه الاجزاء الداخليه لجسم الانسان. ولكن الملاحظ دايما ان التكنيشن وهو شغال بينسى حاجه مهمه جدا، التاثير بتاع خروج اشعه الفلوروسكوبي. اشعه الفلوروسكوبي من الاشعه الخطره جدا على جسم الانسان، لان هي شغاله على اللو ملي امبير. اللو ملي امبير بيخش الجسم ما بيطلعش، وكذلك اللو كي في. فانا اللي انا عاوز اوصله ان احنا لما نشتغل على فلوروسكوبي اخد بالي ان انا ادي الشوت بتاعي في التايم المظبوط بدون ما استخدم لونج تايم. الحاجه الثانيه بلاحظ ان بعض الفنيين وهو شغال بيدي اكسبوجر بيظبط حاله المريض اندر فلوروسكوبي، والكلام ده غلط، لان كل دي جرعات بتخرج بتوصل للمريض بتاثر عليه. الراديوجرافي، احنا عندنا التكنولوجي اللي حصل في الاكس راي والطفره اللي حصلت بدات من الكونفنشال اكس راي اللي هو اجهزه الاشعه التقليديه اللي هي بالمتعارف عليها. الاجهزه هي الاوكر اللي هي اللو فريكوانسي. دخلنا بعد كده في الهاي فريكوانسي اللي هو التكنولوجي العالي. بدا التطوير يشتغل على ازاي اوصل لاعلى صوره. طب انا عملت الهاي فريكوانسي عشان اشتغل على الشورت تايم، جميل. طب ايه بقى اللي هيطور لي الصوره؟ بدا يغير من التكنيك بتاع التحميض بتاعي. بدل ما كنت بحمض اوتوماتيك بدات اشتغل على السي ار، بدات اشتغل على الدي ار اللي هو الديتكتور. بوصل في الاخر الى اعلى صوره. وزي ما اتفقنا ان الغرض الاساسي حاجتين: عدم تعريض المريض لجرعه كبيره، وفي نفس الوقت السيفتي للتيوب. السيفتي للتيوب دايما بيجي ان انا استخدم معاملات قليله، ان كان كي في، ان كان ملي امبير، ان كان سكند. فبالتالي بدا يصنع الديتكتور اللي هو بيستغل اقل جرعه لاظهار اعلى صوره. طب ده الديتكتور بدا يدخل الديتكتور بقى بيلت ان في الاجهزه الحديثه حاجه اسمها فول ديتكتور. الغرض من الفول ديتكتور هو جهاز كومباكت انتجريتد. يبقى انا الديتكتور نفسه شغاله على مرحلتين. على سبيل المثال انا جبت الجزء بتاع الديتكتور ودخلته في الكونفنشال اكس راي وبدات ان انا اتعامل معاه كجهاز دي ار. في نفس التوقيت شركات بدات تحدث اكتر شويه، بدات تاخد الديتكتور ده يبقى بيلت ان في الجهاز نفسه، ما ينفعش افصل اي جزء فيه. طبعا انا بنصح كل الدكاتره لما يجي يشتري جهاز لو عنده اكتر من جهاز لا مانع ان هو يجيب جهاز فول ديتكتور، ولكن لو ما عندوش الجهاز واحد بس انا انصح ان هو يشتري جهاز كونفنشنال اكس راي معاه ديتكتور، عشان لو حصل ديفكت في ديتكتور اوتوماتيكلي يغير بي سي ار يجيب ديتكتور ثاني ومفيش مشكله في اي حاجه. عندي الموبايل اكس راي، في عندي الموبايل راديوجرافي والموبايل ديجيتال راديوجرافي. طبعا كلنا عارفين ان الغرض الاساسي من الموبايل اكس راي هو الشغل على الاماكن المرضى اللي صعب استحاله ينزلوا الاقسام. فانا بنصح ان دايما لما اتعامل مع جهاز موبايل اكس راي اجيب جهاز ديجيتال راديوجرافي علشان اقدر احدد الصوره واحدد تقييم الصوره قبل ما انزل من الغرفه نفسها علشان ما ارهقش المريض بجرعات زياده. بعد كده دخلنا على السي ارم. انا عندي السي ارم في منه نوعين، السي ار اللي هو الاولد فاشون شويه اللي هو ايمجنج انتنسفاير، السي ار الحديث اللي هو بالفلات باند ديتكتور، والغرض الاساسي زي ما اتفقنا الفلات باند ديتكتور اظهار اقل جرعه اشعه حفاظا على المريض وحفاظا على التيوب نفسها. كل ده بيرجع في الاخر للكواليتي، كل ده انا بحاول اساعد الدكتور ان هو يشخص تشخيص مظبوط. الماموجرافي عندي حضرات جميع اجهزه الماموجرافي بتشتغل من 20 كي في لغايه 25 كي في، عشان بشتغل على السوفت تيشو. الفنيين اللي مش عارفين ممكن يدي معاملات زياده اوتوماتيك، الجرعه اللي بتوصل زياده للبني ادم جزء بيخرج منها وجزء بيبقى داخل جسم الانسان، فده بيأثر. كده السيده جايه عشان تعمل سوفت تيشو عشان تقدر ان هي نقدر نحكم فيه ورم لا قدر الله او حاجه. طب انا النهارده لو انا عرضتها الجرعه زياده انا كده برهقها وبتعبها قبل اصلا ما احدد في ورم ولا ما فيش ورم. فيا ريت الفني وهو شغال يبقى عارف ان الاشعه الماموجرافي شغال على اللو كي في، لان شغال على السوفت تيشو. الدنتال اكس راي دي من النقاط المهمه جدا. اغلب الدكاتره الاكس راي ما عندوش معلومه ان انا لما بتعامل مع الدنتال اكس راي لازم ببقى ورا التيوب، لان الدنتال اكس راي شغال على اللو كي في. اللو كي في البنتريشن عندي قليل، لو انا شغلت على البنتريشن قليل اي جرعه بتخرج جسم الانسان بيمتصها. فاغلب الدكاتره حسب ما بشوف المستشفيات اللي انا بحضرها بلاقي ان الدكتور بيحط صبعه جوه بق المريض عشان يسند الفيلم بحجه ان الجرعه اللي خارجه قليله. طبعا حضرتك ده خطا كبير جدا، لان كده كل جرعه خارجه من الاكس راي تيوب بتاثر على الدكتور وبياخد جرعه. طب انا بعد 20 حاله باخد 20 جرعه، بيجي بعد وقت طويل جدا بيحصل لا قدر الله امراض مش كويسه للدكاتره. فنصيحه حضرات كل ما هو دكتور او فني يبقى عارف ان الدنتال اكس راي من اخطر اجهزه الاشعه المؤثره على جسم الانسان. الفرق بين الدنتال اكس راي والجهاز الكونفنشال اكس راي، انا بشتغل كونفنشال اكس راي بشتغل هاي تكنيك، ممكن ان انا ادي جرعه عاليه اوتوماتيك مفيش تعرض للمريض لان الجرعه بتخرج ان تايم ومفيش مشكله في اي حاجه. لكن انا ممكن اجدي جرعه دنتال اكس راي افوجئ ان كل الجرعه نفسها امتصت في جسم الانسان، ودي بتاثر بالسلب بعد كده. الكمبيوتر توموجرافي طبعا كلنا عارفين اساس السي تي ان هو بيشتغل على مساحه، لان انا باخد الفيلم بعمل عمليه سلايس، بخرج اكتر من سلايس اللي هو احنا وصلنا 256 واكتر. النصيحه اللي انا بوجهها برضو للزملاء الفنيين ان انت لو طلب منك تعمل فحص لفقرتين او ثلاثه بعمل فقرتين او ثلاثه، مش لازم اهدر افلام، مش لازم اعرض المريض لكم من الاشعاعات. في نفس الوقت كل جهاز ليه البروتوكول، يا ريت اطبق البروتوكول اللي في الجهاز، مش جاست اللي انا اطلع صوره وخلاص. الفرق ما بين فني ماهر وفني غير ماهر ان الفني الماهر لما يدي الجرعه هي الجرعه اللي بتخرج بيعملها فاين ادجست. الفن الغير ماهر بيدي اي معاملات كي في عالي ملي امبير عالي وبيعتمد انه معاه مساعدات ان كان ديتكتور او ان كان سي ار، وده خطا كبير جدا لان في الاخر بيعود على تلف الانابيب الاشعه، بيعود على استهلاك معدل انابيب الاشعه ومعدل الاعطال. ده ياخدنا للطريق اللي انا لازم نوصل معلومه ازاي اصلا الاكس راي بتخرج. انا ما اعرف الاكس راي بتخرج ممكن استوعب تماما ان انا ابقى تيك كير وحريص جدا على التيوب بتاعتي. اي اكس راي بتبقى ناتج عن فرق جهد ما بين الانود والكاثود. كم الالكترونات بتخرج من الفيلمنت بناء على الملي امبير اللي بيتسلط عليها، بيخرج بقوه فرق الجهد، بيصطدم في الانود ويحصل عمليه انكسار، بيخرج عليه فوتونات، بيتولد في المرحله دي بالظبط 99% حراره و1% اكس راي. ال 1% اكس راي دي ليه بتعامل معاها وبطلع منها الفيلم. كذلك لازم نكون عارفين ان انا عندي في 2 تيوبس، في فيكسد انود وفي روتيشن انود. الفيكسد انود في الاجهزه الصغيره من الدنتال اكس راي لل 100 مللي، والروتيشن انود في الاجهزه الكبيره ما بعد ال 150 مللي لغايه ال 1000 مللي. طبعا السيفتي او الاقوى في خارج الاشعه اللي هو الجهاز الكبير اللي هو ال 150 ل 1000 مللي. وده شكل لخروج الاشعه في حاله السي تي. طبعا زي ما احنا شايفين كده الاكس راي بيخرج، المقابل للاكس راي ديتكتور، وزي ما قلنا التكنولوجي شغال عمال يزود من السلايس بتاعتي على حساب الديتكتور. كل ده بيساعد ان الدكتور يقدر يدي تشخيص مظبوط، ما يبقاش فيه خطا في اي تشخيص. وده الاكس راي اثناء الاكسبوجر راديوجرافي بتاعي عادي خالص. دي لقطه اكس راي. ده ياخدنا لاسباب تلف انبوبه الاشعه. انا متعمد اكتب السلايد ده بالعربي عشان اوصل اوصل لجميع الفنيين او الموجودين شغالين في المجال يعني ايه انبوبه بتبوظ عندي. انبوبه بتبوظ يعني ربع ثمن الجهاز بيدفع. من اهم او اسباب تلف انبوبه الاشعه اختيار المعاملات العاليه، ان كان كي ان كان ملي امبير، ان كان سكند. رقم 2 برضه من ضمن المشاكل اطاله فتره التحضير. فتره التحضير دي اللي هو الريدي بتاع الجهاز. الفني لازم ياخد باله ان الاجهزه الحديثه متبرمجه على تايم معين، مجرد تدي اكسبوجر انت اوتوماتيك بيديك ريدي اوف اكسبوجر، تدي اكس راي. طب لو انا النهارده اديت روتيشن بس وما كملش الاكس راي، انت كده استهلكت من التيوب. رقم 2 من ضمن الاسباب قدم التيوب، وده امر طبيعي. التيوب الاكس راي العاديه اللي بتشتغل عادي المفروض تتراوح عمرها من 10 ل 12 سنه. لو انا حملت عليها واتلفت قبل التايم ده يبقى انا سوء استخدام من الفني اللي موجود عندي. طب ايه تاني؟ حدوث تاكل، حدوث اركينج ما بين الانود والكاثود نتيجه تاكل بالانود. نظريه خروج الاشعه حضرات بتؤدي الى قوه الالكترونات اللي خارجه بفرق الجهد العالي، بيحصل زي عمليه تنقير في الانود. التنقير ده بيخرج بثرات صغيره على سطح الويندو عندي. بيجي المهندس لما يجي يشتغل بيلاقي ان البثرات دي عامله ويندو، عامله فعلا صوره مرايه، فده بيعرف ساعتها ان التيوب اصبحت تعمل فيلير، تبقى فيلير. طب انا النهارده كفني اشعه او كدكتور في المكان بتاعي ومش عاوز جهازي يعطل، يبقى اخد بالي اول ما اسمع صوت عالي في التيوب ابتدي اتكلم المهندس بتاعي، اعرف ان انا بدات اخش مرحله الفيلير. حدوث اركينج نتيجه شرخ بالبوشنج. شرخ البوشنج ده حضرتك نفسه ده بيبقى قدم موديل او قدم تيوب، بيجي ممكن بعد فتره الاقي ان حصل شرخ داخلي، باجي اسمع الصوت ده بيبان، ده ما بيخليش استهلك تيوب. يبقى انا النهارده لما بكلم مهندس كل اللي بيعمله بيغير البوشنج وابتدي ياخد التيوب يعمل لها الفاكيوم. كده انا وفرت ثمن تيوب ما بتقلش دلوقتي حاليا عن 150 200 الف جنيه، والارقام طبعا كتير حضرتك عارفين حاجه زي كده. تلف الملفات والتنج انود ده بيرجع اساسا لان التبريد بتاع الغرفه مش مناسب. تبريد اي جهاز اكس راي من الماموجرام، الدنتال اكس راي، للسي تي، حتى الام ار اي لو دخلنا فيه من 18 ل 20 درجه حراره مئويه، يبقى ده الكولينج بتاع المكان بيحافظ على اي جزء في مكون الجهاز. الفاكتور افكتنج اكس راي ايميشن.
ممكن بس يعني نسيب لك دقيقه واحده زياده كده معلش، مش عشان بس الوقت، عشان
حاجه مهمه بس كده. الاوت اكس راي از ميجرنج باي، انا عندي ايكواليتي وعندي كوانتيتي وعندي الاكسبوجر تايم. الكواليتي اللي هو الكي في بتاعي، انا عاوز اجيب كواليتي لازم اشتغل على الكي في. الكوانتيتي اللي هي كميه الاشعه اللي خارجه اللي هو الملي امبير. التايم اللي هو الاكسبوجر تايم دوت وقت خروج الكي في والملي امبير. انا الصوره زي اللي انا حطيتها ديت، انا لو اي فني بص على الصوره او ممكن دكتور من بعيد يقول لك ده الصوره اللي على اليمين دي هاي يعني ايه؟ يعني دي الريزولوشن بتاعها عالي. لا، الدكتور لما بيقرب منها بيقول لك لا الصوره دي مش حلوه. طب معنى كده ايه؟ ان انا ما بعتمدش على جوده الصوره من ان هي بلاك خالص. الصوره لازم تاخد الوضع الطبيعي بتاعي، بيبقى الريبس مظبوط، بيبقى اللون نفسه مظبوط، البرايت الابيض ابيض والجراي جراي والاسمر اسمر. يبقى الكلام ده كله لازم يكون الفني عندي عارف فاهم يعني ايه البيم انرجي اند كي في. ذا اكس راي بيم انرجي از انرجي سبيكترم يوتيلايزد ان ذا فورم اوف ان ايمجينج. التيوب كارنت اكسبوجر تايم برودكت الملي امبير سكند. زي ما قلنا المسافه نفسها ما بين التيوب وبين الريسبتور. الفوكال سبوت لازم ابقى عارف استخدم ايه على الفتيله الصغيره وايه على الفتيله الكبيره، ما ينفعش استخدم فقرات فتيله صغيره ولا عكس صحيح. الكولوميتر لازم احدد افتح فتحه الدايفرام نفسها جرعه مكان سبيس مناسب علشان خاطر الجرعه اللي خارجه تيجي فعلا للجزء اللي انا عاوز اصوره. الايمجنج عاوز اعرف انا هحمض ازاي، هستخدم كاسيت، هستخدم سي ار، هستخدم دي ار. طبعا كل حاجه ليها تفاصيل. اخيرا يا حضرات ده مين بارتس لجهاز الاولد فاشون بتاعي. الاكس راي جنريتور، الاكس راي جنريتور بتاع الهاي تنشن، التيوب، الباكستان، التحميض كان مانوال بعد كده بقى اوتوماتيك. نخش على الجزء الثاني. انا عندي الايمجنج فور فيوتشر اللي هو الدي ار الموجود دلوقتي بيشتغل عفوا التيوب بتاعتي هاي فريكوانسي دايما. الايمجنج في الباكستان، الصوره في الباكستان بتظهر كواليتي عاليه جدا عشان عندي في دي ار. كذلك في الباكي تيبل عشان عندي في دي ار. اخيرا حضرات في عنده نوعين من الدي ار، في عندي وايرلس وعندي واير. كل ما هو جهاز فيكسد في الترابيزه بيبقى وايرد، كل ما هو جهاز هشتغل هجيب واير او هجيب دي ار لجهاز خارج الترابيزه هجيبه وايرلس. ما ينفعش اجيب وايرلس واحطه مكان الوايرد ولا عكس صحيح. كل ده ما يبقاش تبقى تكلفه زياده يا حضرات. ومتشكرين جدا على حسن اللقاء.
ده وبصراحه الموضوع very important، واحنا بنشتغل في الاشعه اغلب 90% من الدكاتره مجرد انها تخش وتصور والفنيين وبس، مش عارفين كم من الجرائم بترتكب في حق العيانين وفي حق نفسنا وفي حق ايفن السراوندنج انفايرمنت. كان زمان واحنا صغيرين في الفيرست بار كانوا بيعلمونا البارشال اوكيوبانسي والفول اوكيوبانسي والاوكيشنال اوكيوبانسي، 1/16 1/4، وبعدين فول اوكيوبانسي لما يبقى 1/1 تعرض للاشعه. فكم من حتى ايفن الاشعه قعدت 46 سنه لحد بعد الاكتشاف الاولاني لحد ما بدات تتعرف السايد افكتس بتاعتها. حتى ايفن الامريكان سوسايتي اوف راديشن بروتكشن بتقول الالترا ساوند تيل ناو نوبادي ان يقدر يقول لك في حاجه، لكن في نفس الوقت يعني بنفس اللفظ اكوردنج الامريكان سوسايتي اوف راديشن بروتكشن تقول لك nobody can swear which is going to happen tomorrow. حتى ايفن للاسف كل الناس بتشتغل بتاع الالترا ساوند او يقعد يمشي يفسح البروب ومش عارف ايه اللي ممكن يحصل في الدي ان ايه او حاجه، بتاع الانترفنشن بيخش ويقعد ايه يحرق في العينين. وعشان كده انا يشرفني ان انا introduce بروفيسور نور one of the eminent and honorary ambassador of the Egyptian radiologists. He is a professor of radiology in Frankfurt. He is a very respectable name and very respectable person. ووجه من الوجوه المشرفه لنا جميعا كاطباء اشعه انا بقدمه، يشرفني ان انا اقدمه النهارده. He will talk to us about safety and radiation protection and virtual radiology. اتفضل يا دكتور.
Good morning, my dear colleagues. Thank you, Dr. Bisar, for your introduction, and thank you for the conference committee for my invitation. As intervention radiologist, I'm going to talk about the significance of radiation protection. This is an image of Dr. Andreas Grunzek, who was the first intervention radiologist who did coronary angioplasty, and this was in 1977. This was the angiography machine that he used, and he invented the balloon catheter to do an angioplasty for the left anterior descending segment of the left coronary artery in September 77. Afterwards, there was an extreme development of the in angiography machines. As you can see, this is at the end of 60s, which was rapidly developed to extent that we are now having another concept of intervention radiology into an integrated system. That we having now the hybrid system that in which we can do the interventional procedure, and then without transferring the patient from one suite to another suite, we can do the CT scan, we can do the MRI scan, and determine the success of the intervention without positioning or changing the position of the patients. They will add a value for the safety of the patient, and to decrease the risk of complication, and to guarantee an immediate response of treatment. So interventions can be categorized into interventions with low radiation dose like angioplasty or dialysis shunt angioplasty, fluoroscopy guided joint punctures, or periradicular infiltration. Other interventions could be categorized as high dose radiation exposure risk like PTCDs, coronary angioplasties, TIPS, transjugular intrahepatic portosystemic shunt, or aortic stenting. But don't forget that the radiation or the intervention radiology is a tool to help the patient, but it's not a tool to make a damage. This is a patient who had an ablation of an ectopic focus inside the heart, and after 10 hours fluoroscopy ablation time with radiation dose of 2000 centigrades, he had a severe burn and necrosis of the arm. And you can see this one of the deterministic effects of radiation exposure due to burning effect. This is a case of coronary angioplasty. The patient had diagnostic angioplasty and 2 stents application, and after 6 months the patient developed, as you can see here, an ulcer, penetrating ulcer on the back due to the effect of radiation. So please don't convert your angiographic machine or X-ray machine into a harmful tool. So what are the radiation doses that we use in fluoroscopy. The unit that we use for the radiation is the dose area product, in which the incident dose multiplied by our irradiated area, and the unit is centigrade square centimeter. There is increased risk of deterministic effect, which could which happen after passing a certain determined or value of radiation. And fluoroscopy of over than 40 minutes, this is considered as a threshold above which a deterministic effect will happen. So this is approximately 2 millisievert effective dose. This is how to differentiate the deterministic effect that must happen after exceeding a certain value of radiation, and the stochastic effect, which is a probability that may happen or may not according to the exposure dose. The threshold of and the severity of deterministic effect depends on the dose, and the threshold differs according to the tissues. The skin redness or hair loss are the early deterministic effects, but other prolonged effect includes impairment of the fertility, anemia, or pulmonary fibrosis due to high exposure, and don't forget the value of 40 minutes fluoroscopy. I'm going to show you a movie how to guide about the protection. Of course, the most important is the aprons that we use, a lamp at the door of the angio suite to determine that radiation is going on. During the intervention, it's important to determine the source of radiation. It's now in all machines, it's under coach, because most of the radiation sources are the patient himself, because this will source as a scattering or secondary radiation. As you can see in this diagram, the radiation is coming from below towards the patient to get the information and to make the image on the detector. However, the body of the patient himself will source as a secondary radiation, which will do scattering. And this scattering is the harmful effect for the personnel, the intervention radiologist or the assistant or the nurse in the angio suite. And of course, the technician or the anesthetist in the angio suite. So it's important to keep in mind the radiation protection procedures. The patient should be as high as possible towards the detector. This is a diagram that shows the radiation field. The hot area is around 1 meter around of the source of radiation. As we go outside, this is according to the square meter principle. When we go outside the area, the radiation dose will decrease. When we look to the radiation distribution in the side view, you will find that the radiation is more in the scattering below. So that's why we should keep in mind how to protect ourselves as technicians or radiologists, as well as the for the patient. It's extremely important to wear the dosimeter in order to register the exposure doses. The dosimeter should be applied under the apron in order to measure the amount of radiation exposed to the personnel. And sometimes when the patient when we use another dosimeter over the apron, should be discriminated and with another sign. If the hand comes in exposure, like in cases of beaded CDs, a ring dosimeter could be applied for measurement of the doses. So it's important for to wear the protective aprons. And you can see here the application of the shields that we use, as you can see in this diagram. These are, the protective shields. I will show it in here. So this is a diagram that shows, where's the light, please? Okay. So the radiation, most of the machines now using the undercoach source of radiation, and you can see different lid protective measures that we use beside the intervention radiologist to minimize the exposure. This is extremely important. These are these laminae below and near the source of radiation or the tube. In case of radiation beside the head of the patient in cases of transjugular intrahepatic port systemic shunts or other procedure, it's another protective laminae should be in the side of the head. So how to reduce the radiation dose? Protective aprons. Wearing the protective aprons is obligatory for all staff inside. This is, for example, how the value of using the protective shield of the neck for the thyroid gland. It can reduce the radiation dose to up to less than 1%. This is extremely important. Wearing the protective goggles, this will protect the eye of the intervention radiologist as well as the technician against cataract. The threshold for cataract development is 0.8 gray. And this is the diagram of the goggles that we can use and should be protecting the radiation exposure from the lateral aspect. The setting of the table, as I mentioned, the table should be positioned as high as possible towards the detector in order to decrease the magnification effect, and this will reduce the exposure dose and make the distance between the patient and the tube as far as possible. So another factor is avoid the use of oblique projections, because going oblique, this will result in a radiation of a large volume. This will induce more scattering. Vary the angle during the intervention will reduce the incidence of burning a focal area. Is the low pulse rate below 3.5 to do a discontinuous radiation dose. This is an example. This is a conventional fluoroscopy. You get a radiation dose of 100%. If you use 3 pulses per second, you will get a reduction up to 10% of the radiation exposure. Use the collimation to decrease the volume of radiation. Use of the filters in order to decrease the soft tissue radiation. This is or software that use the virtual positioning to avoid additional dose exposure during changing the position of the patient. Another factor is the use electronic image overlay or last image hold or roadmap to avoid extra series and avoid magnification. This diagram shows how we can reduce the dose. This is 100% conventional fluoroscopy. If you use the pulsed fluoroscopy, you decrease the radiation dose to 25%. And if you use additional filter, you will reduce the dose to 14%. Collimation will reduce the dose to 7%. And by changing the kilovolt and milliampere second values, will reduce the dose to 5%. So don't forget other principles like ALARA principle, as low as reasonably achievable. Use the minimal factors to induce the best image that you are in need for. When you are doing a series of angiography series, try to leave the room and go behind to keep a distance from the patient. This will decrease the radiation dose towards the staff. And of course, always recording the dose and quality control to induce, to control that the radiation exposures and factors are within the normal values. Some factors that we are in need to say that we cannot influence, like the patient. We have sometimes patients that are obese, large size, and this huge body mass index will induce a large exposure dose. This is a study that was showing that the effective dose is higher by obese patients. Other factors like complexity of intervention or during emergency, complex interventions, and in emergency we have a higher radiation dose. Why? The patient comes not prepared, the patient is comatose, not cooperative, so I will do repetition of the series. And the experience of the interventionist, and you can see that this is a study that how the radiation dose is factored by the staff radiologists that are doing central venous catheter insertion in comparison to a resident during the shifts or during on-call. So to conclude, radiation exposure is extremely important issue that we have to keep in mind. Keep in mind the deterministic and the stochastic radiation images, how to change and to reduce the exposure dose, the table position, adjustment of the doses, and technical aids, as well as general considerations. Thank you for your attention.
Thank you very much, Dr. Abdul Rahim, and I think that all of us will echo the radiation protection principles that you've had, but perhaps I'll add to that. If you reduce the radiation dose to the patient, you reduce the radiation dose to the operator. Thank you very much.
Thank you.
Our next speaker is well known to most of you and to all of us. She is the chairperson of the AFRA and Professor of Radiology at the Atomic Energy Authority of Egypt. She is also Director of the Must University. May I introduce Dina Husseini Salama, who's going to speak to us on the comparative study of medical imaging technique, the broad brush approach. Dina.
Thank you very much, Dr. Dennis, for the kind introduction. Dear chairs, dear colleagues, it's my pleasure to introduce the topic of a comparative study of medical imaging techniques in a broad brush approach. And thank you very much, Dr. Hani Hafez, for your kind invitation to this important session. Actually, this is a unique session of radiologists and radiation technologists because we are both responsible to endorse radiation session in the radiology departments. And I'm taking this opportunity to enhance the idea of that we should not be focused on our equipment or on our subspecialty. We need to have a global vision of other equipments, of the pros and cons and implications of medical imaging practice, system availability, and new emerging medical imaging techniques, and whether it is ionizing radiation or non-ionizing radiation. So I will go quickly on the general concept of any medical imaging technique. We have a source of energy, we have the human body, detectors, then mathematical algorithms, and then we interpret the images. And let me start with the maestro of ionizing radiation and the problem of radiation safety. There is a battle always between the speed and those in computed tomography equipment. There are technical advancements, as we have all witnessed: helical, multi-slice, cone beam, and dual source computed tomography, and multiple examinations as cardiac imaging, colonoscopy, gout imaging, and whole organ perfusion. This widened actually the application profile of CT. But today's multi-slice helical third generation is very welcomed by professionals because it provides the in-plane spatial resolution of about 2.5 milli, and the cross-plane spatial resolution up to down to 0.5 milli. All these and the fastness encourage the professionals to purchase the new computed tomography machines. There is increasing awareness of the risks triggered a variety of those reduction techniques like the tube current modulations, dynamic collimators, low voltage, and fast scanning. The effective dose, we can say that it reached below 1 millisievert even in cardiovascular examinations. And at low doses of radiation, which CT scan uses, the risk of developing cancer from it is so small that it cannot be reliably measured. That's what we are saying now. But actually, Harvard is saying another thing. This is a very, very important study with, we can say, the father of radiation protection. He was a former section head at the IAEA in Vienna, and now he works as a head of department. He's called Madan Rehani, if you know him. And MGH Hospital is well known with accurate and discipline in radiation safety practice. He announced this important declaration, depending on a evidence-based study. He studied 2.5 million patients with CT examinations, and we always say we don't exceed 20, 30 millisievert for the patient. With the cumulative doses for these patients, 33,000 patients exceeded the minimum doses, which are 100 millisievert to 200 millisievert. This is moderate doses, which definitely will have a stochastic effects on those patients. And the next year, in 2021, by the end of 2021, he declared in another paper that in a single doses of CT interventions, the patients exceeded the 100 millisievert, and this is in MGH hospital. So can you imagine the status in other countries? So CT-guided interventions may result in a single procedure dose of 100 millisievert. So it is estimated 1% or 2% of cases in the United States in the future will be secondary to the effects of ionizing radiations. They will develop cancer and leukemia. Awareness of the possibility of such high doses, risk and potential for long-term effects, especially in younger patients, has to be put into considerations. So we, as I said, we are responsible on justification and optimization, so always we need to put the pros and cons of each procedure in our minds. Computed tomography, yes, fast, with good spatial resolution, and can be used in trauma, colonography, as I have mentioned, many biopsies, but the cons are exposure to ionizing radiation and no real-time information. Let me move quickly to the magnetic resonance imaging. The strength of the magnetic resonance field used by MRI scanners is approximately 10,000 to 60,000 times the strength of the Earth's magnetic field. They have high contrast, detect the presence of movement, which is very useful in magnetic resonance angiography. But you know, the problem was, yes, it's non-ionizing and preferred by the patients, but the claustrophobia, we have all witnessed patients daily complaining of the claustrophobia, feeling that they are going to their grave. So this is the 2022 equipment that will be in the market soon, with this open gantry and open bed for the patients, integrated radio frequency and very fast technology. Let me take you onto another new technique. It's called T1-RES. T1-RES in MRI is able to manipulate the signals from various brain tissues in a unique way, so as to produce a very significant improvement in tumor visibility. The benefit of the new technique is particularly in small malignant lesions. It's very unique and we'll expect it soon in the market. Again, we are radiologists, technologists. Keep in mind always the pros and cons, non-ionizing radiation, but no real-time information, long scanning time and post-processing till this moment. Children may need sedation. And then I jump to ultrasonography techniques. New innovations in ultrasound have been seen in the market, up to 5D, shear wave elastography, wireless transducers, and pocket ultrasonography, fusion with laparoscopic, and etc. You know, ABIS ultrasound, it's used in dense breasts and overcome the problems. And let me share with you, it's an important society meeting, and we have problems. We have political problems with the referring physicians. They are now using the ultrasound in the regional guided regional anesthesia, and you see the authors are all anesthesiologists. So this is a problem. Why? Because we should do this ourselves and master it, and don't let others take our profession from us. Again, the pros and cons for ultrasound is well known for all of you, but let me jump to the ABIS technique. Still now they cannot assess the axilla well and the vascularization, and it depends much on the poor positioning and external pressure we do, so it's operator dependent. Another groundbreaking new imaging technique, it's the HIP-CT, hierarchical phase contrast tomography, is an X-ray technique that allows whole organs to be imaged down to 1 micron or 100 times resolution of the conventional scan. Let me tell you the story. It's a technological upgrade at the European Synchrotron research facility, and actually it will make a leap in our imaging and the biological makeup. Another new technique, it's the optical imaging. It's the use of light as an investigational imaging technique for medical applications. It's non-ionizing radiation, and it's used in principle for brain, breast cancer, bone health, but the problem is low spatial resolution till this moment, sensitive to water, blood concentration, oxygenations. So they are working now to improve this optical imaging technique to a better to be a better technique. What about the infrared thermography? It's an infrared camera technology which records heat and movement rather than static images. It's used alone, but actually preferred to be in conjunction with X-ray, mammography, and other imaging techniques, mainly for breast cancer in inflammatory diseases, and they are working also to improve, because it's still this moment limited as a primary standalone breast cancer diagnostic modality. Terahertz imaging, terahertz uses radiation that falls in between microwave and infrared, sorry. It's in the spectrum of electromagnetic spectrum. Terahertz travels in a line of sight, and it is non-ionizing radiation. Till now I could say it's experimental and mainly on tumors and tooth crown. The pros are the cons are having lower resolution, slow processing, and incoherent source performance. We always have to look on image quality, system availability, safety to judge which modality is the best and gives benefit for this patient. And thank you very much for your attention, and stay safe.
Thanks, Professor Dina, for her excellent and updated talk as usual. Professor Dina is the leader, of course, that's the leader of radiation safety in Egypt and one of the leaders in the world. So we are happy to become with us today.
I'm honored to be with all of
you. Thank you. Next speaker is also one of the leader of the radiation safety in the world, Professor Dennis Remedios, Northwick Park Hospital, London, UK. He is one of the leaders of radiation safety, the editor of clinical imaging guidelines and best use of radiation radiology in UK. Please, Dr. Dennis.
Thank you, Dr. Hani, for the kind introduction, and I'm grateful to the Egyptian Society of Radiology and Nuclear Medicine for the kind invitation to come and speak with you today. I have got two talks, and I'm going to share with you some of the experiences, first of all, in the UK and Europe. Then secondly, I'm going to try and offer you some practical tips on how to make it work in your own departments. We in the United Kingdom have spent a lot of time on audit, because we think audit's a great way to improve practice. Last year we conducted the UK national audit. We called it the IRMA audit, which is our regulation for radiation protection. And we did this particularly to improve professional practice. Rather than tread on the toes of our inspectors, we address just those professional issues in radiation protection rather than the compliance issues that our inspectors are very good at ensuring happen with great regularity. We did this through a questionnaire that was developed through a multidisciplinary group. We felt it was important to involve all the professional groups that deal with radiation safety, and that would be not just radiologists, but radiographers, the technologists, and the medical physicists. We made sure that responses were anonymized and that patient data was kept confidential. And the questionnaires that we used were distributed to the radiologist audit leads, but shared locally with colleagues in radiography and medical physics. The idea that we work as a team in radiation safety should also be mirrored by the way in which we monitor the work that we do. The collaborating organisations, and they were the Royal College of the Radiologists, the British Institute of Radiology, the Society of Radiographers, and the Institute of Physicists and Engineers in Medicine, all endorsed this project, this audit, and promoted it through their organisations. It is truly multidisciplinary. We had 3 limbs to this audit, with standards set in each of the limbs. The limb dealing with justification looked at referral guideline availability, and in Europe there is a mandatory need for referral guidelines to be made available to referring clinicians, and that standard was set at 100%. If it's mandatory by law, then it has to be 100%. We particularly addressed CT and MRI, and we looked for the evidence of justification, and that justification we felt had to be there in 95% of cases. That standard was taken from an audit that we had done previously in 2014, when record keeping was still on paper. Fortunately, now it is all electronic. And finally, we looked at the outcome, if you like, the appropriateness of the imaging that was performed. We felt that the imaging that was performed should conform with referral guidelines in 90% or better. The reason why this is not 100% is that not all patients are the same, not all clinical scenarios are the same, and that we know that 10 to 20% of cases will lie outside of referral guidance. Regarding optimization, we looked particularly at diagnostic reference levels, and that's taken as the 75th centile of a dose survey. In CT, of course, typically it's CTDI or dose length product. We looked at the availability of local diagnostic reference levels, which is once again part of the mandatory part of compliance with our ionization radiation regulations, and because this is mandatory, availability has to be 100%. We looked at the way in which local DRLs are developed and reviewed, and we looked at how this was done in several key areas, the common areas, brain, and we used stroke as a clinical indication, chest particularly for cancer, chest, abdomen, and pelvis for staging for cancer, angiography. You heard lots about the clinical side of transcatheter angiography. This is CT angiography, PEs, abdominal pelvic scans, colonography, and urography, urograms. We set the standard at 75% of DRLs locally should be within the national DRL, and that goes back to the fact that 75%, the centile, is used for the national diagnostic reference level. And the third limb of the audit was regarding education and learning, and it revolved around training, the methods used, record keeping, the scope of entitlement, and the technologists of the radio office here would be very familiar with the scope of entitlement, keeping within scope and documentation of the scope, all important. We felt it was important to identify the time for training and continuing professional development, lifelong learning. Supervision of trainees is common to all of us who take part in education in the university departments and the training departments. And we learn through significant events, through near misses, and through significant events leading to radiation unnecessary exposure. Well, what are the findings? Regarding justification, first of all, and we had a response from the majority of departments that were surveyed, this was very similar to the previous audit that we did in 2014. If you consider this was done during the peak of the COVID pandemic, we did very well to get so many people to find time in their busy, busy clinical lives to take part in quality and safety audit. Guidelines were available, sadly, only in 71% of departments. There were some areas of very good practice. We have 4 nations in the United Kingdom. In Wales and in Northern Ireland, there was 100% compliance with that because there was national distribution of guidelines there. In Scotland, there was national distribution of guidelines, but it doesn't come through to everyone. It does quite well. In England, where there is not national distribution, and you see here already, there is a special cause for variation. Regarding the evidence of justification, we showed that in 100%. We are now all electronic, and so that there is, of course, a 100% record of who justifies and how it is done. And in the appropriateness of the way in which CT and MRI is performed, and this is retrospective judgment, this was shown in 98% of cases, up from 93% in 2014, and well within the standard of 90%. We use now box and whisker plots to project this, and the idea that this is non-parametric is brought out through these box and whisker plots, and you can see it has very much got a tail that comes down. We can identify those centres, and there are very few centres that lie outside the control limits. The control limits, for those of you who like statistics, are set at 1.5 interquartile ranges, and that will take into consideration the normal variation that we would expect to see, and that we can focus on these outliers to provide remediation improvement. With optimization, once again, we did quite well. We found that local DRLs were present in 99% of departments, and that local DRLs were pretty much within the national DRL. But we did find that there was a variety of ways in calculating national DRLs, and this is a methodology issue that we had to address. We showed that there was quite a large spread amongst local DRLs, and that's because of this variety in which they are calculated and produced locally. Regarding the learning part of the work, there was pretty good compliance with the way in which documentation of learning and the time allocated to CPD was given. And there was good correlation between individuals' feedback and departmental responses, the top-down approach. So where could we improve? And the improvements probably apply to you as well as to us. And I think it's important to feed this back to departments, particularly those outlier departments, the ones that you saw as separate circles on that chart. And we give a checklist of the special causes for variation, which are usually in the way in which data are collected. We encourage good practices, and we feed back those good practices, such as referral guidelines available through a national distribution and often through a Ministry of Health or a Ministry of Safety. We look for ways where we can provide more uniform methodology for calculation, particularly for local DRLs. And we encourage good practices for learning and education, and particularly in allowing and encouraging continual professional development, attending meetings such as this. Well, what are the challenges that we found in terms of providing compliance? For the optimization DRLs, it was particularly human resource. We are always short of manpower, and I think that's probably the same for you as it is for us in Europe. Financial, lack of money. Once again, probably the same for you. Training is something that we're hoping to address rather more, and we're sort of getting there. Software, lack of software, and I was very pleased to see that talk in the last session on AI in Egypt, and I think that this is one area in which there will be strides, advances, and perhaps at next year's meeting we will probably have some software solutions that address many of the shortcomings. The awareness of the benefits that can be produced. The awareness comes through meetings like this, where those of you sitting in this room, and perhaps you are already those who are aware, but there may be some who will go back to their department and say, actually, listen, we do need radiation safety and quality to be main issues. Improving justification, the initiatives that were advocated were very similar to what was advocated back in our 2014 study. Education is a good thing. Medical students, junior doctors, feedback through the reports and through meetings, MDT, multidisciplinary meetings, is very useful. But the one area which has changed, and I can perhaps say that the one good thing that's come off the COVID pandemic, is that we are far more interested in online facilities, online learning facilities, which has now got universal appeal. In Europe, of course, audit is a big thing. They have a big project going on now with the European Commission through the European Society of Radiology called Quadrant, and it focuses on audit of quality and safety. And it looks at compliance with the Basic Standards Directive. They use similar audit processes to the one that we used at the Royal College in the UK. It looks at particular areas why audit is not practiced as much as it should do, and how to improve implementation. We're looking at solutions. We're finding ways in which we can make solutions to implementing very important regulations, regulations that improve safety. Integration into everyday care and programs, and we look particularly to see collaboration between healthcare workers, radiologists, technologists, physicists. Very, very important. If you want something to work, you must get all the professionals together to do it as one. If you want governance, you must have all concerned, all stakeholders together on this one. The other project that they're doing focuses just on CT and its justification of CT procedures. Once again, it's to collect information, first of all, common methodology for auditing. Once again, that harps back to what we found in the UK. Common methodology is important, uniformity. Pilot studies are important to start off, and ways in which we can make recommendations for future actions across the European Union. Well, those are perhaps some of those ideas that have come across both in the United Kingdom and more generally in Europe. And your take-home points perhaps from this is that clinical audit differs from regulatory compliance in that we look at aspirational professional standards rather than mandatory standards for compliance, and we like to go higher and better. Collaboration is important between professionals, between departments, and it leads to a stronger governance, clinical responsibility. We showed that justification can be demonstrated in all that we do, and that the investigations that we perform, the procedures that we perform are appropriate, and that we can exceed the standards that have been set, and perhaps we can set new standards in our quest for better and higher, or lower dose. DRLs, once again, available. People are actually listening. Referral guidelines could be better, but even as I speak to you now, the UK government has addressed this. Audit is a powerful tool at encouraging better practices and compliance. The Department of Health is now providing clinical decision support for guidelines, for referral guidelines throughout England, in addition to Wales, Northern Ireland and Scotland. So that is a good point, that is a good practice. And finally, the work that's being done in Europe is for safer practices, as we hope we will be able to encourage here in Egypt, in the Arab associations, and in those here from the International Society. Thank you for your attention.
Thank you, Dr. Dennis, for his excellent talk. The next talk for Dr. Dennis also is a very sensitive talk, and I think will be very beneficial for all of us. It's the practical tips for returning and or rejecting inappropriate requests. That's a vital issue, and hope we will get a benefit from Dr. Dennis' experience at these subjects. Please, Dr. Dennis.
Thank you very much once again, Dr. Hani, and it's once again a pleasure to share with you some of the tips that we have used ourselves in the United Kingdom. I am going to try and address areas in which you can use practically in your departments to improve quality and safety, and particularly with regard to justification. There are several points in the steps that we take towards performing an investigation and its report that we can use to integrate with the chance to provide advice, to provide safety and quality. Well, before the request is actually made, before the requisition is made, there is that chance for learning and education and advice. This learning takes place at all levels, in the medical schools, in the years of residency, and indeed through the clinical meetings that occur. At the time that a request is being made, that is probably one of the best times to make an intervention, and that intervention is done through referral guidelines, which can be made at the point of care in real time and in a few clicks through clinical decision support. This clinical decision support is best done through a computerized system, although posters can also be used very, very effectively and cheaply to do this at the point of care in emergency departments and perhaps in family practitioners' surgeries. After a request has been made, there is just another opportunity through the justification process, vetting we call it in the United Kingdom, where we look at the justification and also the protocoling of the examination, usually by a radiologist, but in some cases it is by a radiographer technologist. And this leads to the authorization, the identification that justification has been carried out. Now, at this stage, we are able, in the United Kingdom, to return a request, to cancel a request. We don't do it too often, but we do it if it's duplicated, and there's a very good reason for that. There's no point doing it twice. Sometimes it's not so easy to find that because it's done at another institution. And you can see already that you need to know where previous investigations have been done. When more clinical information is needed, and this is a common reason for unjustified examinations, where the clinician with the referring medical practitioner hasn't given you enough information to justify the examination. Where sometimes an alternative test gives you the answer without radiation, ultrasound and MRI may give you the same answer as CT, and this is sometimes the advice that is best given for the clinician requesting that test. And occasionally, particularly in general practice, a specialist clinical review will do far more than an investigation. Following the examination, the educational opportunity still exists when the report is written, or at a clinical radiological meeting, an MDT meeting, when the reason for perhaps not having done that examination or doing a better examination would have been in the patient's interest, clinician's interest too. So what strategies can we suggest? Well, the first one, of course, is imaging referral guidelines, which we've talked about. And at this stage, I can share with you that the Royal College has very kindly, with Dr. Hani's help here, made available to all of you at the conference the Royal College's referral guidelines through the iRefer website. If you Google iRefer, the username that you can put in there is ESRNM, and the password is quite simply RCR iRefer, and this will be available for you until Sunday. So do have a look, and it's on a multi-user license, so all of you in this room can have a look. Feedback for improvement, and it's that cycle that is so important to give you the improvement on a regular basis and a sustainable basis. And for monitoring, we have used clinical audit, as you've heard about in the previous talk. Well, imaging referral guidelines you probably are all familiar with, and they are based on three very, very simple principles. Clinical effectiveness comes top. The best tests first. The effective dose, of course, you want the lower dose procedures if they are equivalent, but sometimes CT is still the best test, and that is the one that you should do first, not the X-ray, the lumbar spine, but the MRI, not the X-ray of the chest, but the chest CT when you're looking for lung cancer. Cost effectiveness is also important, but you can see that as not even the secondary reason, but the tertiary reason, because we in imaging must answer the clinical question that is posed first, answer it safely second, and thirdly, look to make sure that we have a sustainable healthcare system. By doing so, we will have some opportunity to have uniformity of practice amongst clinicians, amongst radiologists, and throughout the country. The top 10 tips is something that we published on before and is downloadable from the website. I've given you that there. It's on the ESRE poster website, and so you can download the poster. And these are evidence-based areas: headache, head injury, low back pain, abdominal pain, ureteric colic, chest pain, suspected pulmonary embolism, neck pain, first onset of psychosis, and screening for lung cancer. These are common to all countries. The information was taken from all the Choosing Wisely programs across the world, as well as through the HITS on referral guidelines websites. Those of you who have been fortunate enough to use computerized clinical decision support, this gives you that information at your fingertips in real time at the point of care. And the request for CT of a head for headache is then changed to MRI brain. Although both of them will give you the information, the MRI brain, of course, carries no radiation dose, and that is preferred. And that's a very quick way to tell your clinician, actually, this is the information that is available, this is the evidence base that is available worldwide, and if you are agreeable, then this is what you should do. It doesn't stop you from doing the CT, but what it does is it gives you that hint. It nudges you gently towards the best test first. Then you have the chance of vetting and justification, and I take this from one of the posters from the IAEA, the 10 Pearls, and they tell us these are the questions to ask yourself, the so-called Socratic Questions the WHO has encouraged us to ask ourselves as referrers. Has this test been done already? Don't repeat a test too soon if it's not necessary to do so. Is this test needed? And the test may not actually affect the patient's management or be of benefit to the patient. So don't do a test unless it's going to give benefit to the patient. Do I need the test now? Sometimes doing a test that's too early and something that is going to get better, my back pain will be better within a few weeks. So do I need to get that examination? Do I need to get that MRI? Probably not. Is this the best test? And we've touched on this before, and the best test first is something that the referral guidelines are very good at giving you. And has enough information been given to justify the examination? Sometimes saying back pain is not enough, but back pain with red flag signs, such that the back pain radiates down the leg in the L5 distribution. The back pain is associated with bowel and bladder problems, therefore you may be thinking of coronary equina syndrome, will suddenly make you think, yes, this should be done. The UK Royal College of Radiologists gives a little bit more guiding, perhaps on the technical side for vetting, and it's for those who are fortunate to have electronic systems where vetting can be done 1 or 2 mouse clicks. And that encourages you to do something and to do it properly if it can be done quickly. And that's what technology is there for. It is to help us. Technology is our friend. Communication is important, and communication back to the referrer if a request is returned, cancelled, rejected, is very important for learning. Learning for the clinician, perhaps learning back both ways, that the information that is required for justification must be there at the outset. Comprehensive information that is needed when vetting is, of course, the imaging history. Has he had this test before? Has he had a similar test before? And that those images and reports ideally should be available to you in a PACS system. I know in Egypt you are very well forward with your PACS systems. You have a spine, I think, in many hospitals. And other results, other diagnostics, and you're already getting the idea that these diagnostics should feed into the bigger picture. And one of my colleagues presented to you about AI, artificial intelligence, and putting all these diagnostics together in one AI framework may be the way to the future. Having clinic letters and further information, and of course referral guidelines at your fingertips at the time of vetting will help give you that information. the work that you put into justification should be recognized by your departments as important clinical work, which we now recognize in the UK as making up our job plan. When we feed back the reason for doing or not doing a test, it's important to give education, and education is good for everyone. And the so-called red flag features are important. Sometimes it's nice to be able to give them back verbatim, and we include them in the referral guidelines, and it's quite easy just to cut and paste and send them back. Some of the comments: imaging is not useful for isolated headache without abnormal neurological features, and these are the abnormal neurological features. And this helps understand why an investigation is not going to be useful to the patient. Audit we've dealt with in the last talk, and there are many ways to display the audits, and graphical displays sometimes work better than just numbers or sentences. Identifying outliers outside control limits is the way that we choose to do this. This is a funnel plot, and the outliers are outside 3 standard deviations, and are clearly those who have particular reasons for being different, for not complying. Do referral guidelines work and help you? Well, the work that has been done shows that referrals fall by about 13 to 20%, that educational reminders do help. We talked about how we can put on a report at the bottom that this study would have been more useful if it was MRI rather than CT, or that it's not really necessary to do MRI with uncomplicated headache. And that with clinical decision support tools, there is evidence to show improvement by up to 20%. This is our own experience in clinical decision support in the emergency department. Inappropriate requests fell from about 15% down to about 6%, almost at the flick of the switch of turning it on within about a month or two. And it's that information at the point of care and real time which makes all the difference. Do you think that there is any value in clinical decision support or referral guidelines? Well, this is a small study that we did with clinical decision support. Retrospective justification showed that in 95% of cases, virtually all of them, that those that gave clinical decision support justification were also justified if you did it manually. If you didn't have clinical decision support, about 20% of them didn't. So that's actually quite a difference in unjustified or potentially unjustified exams. If you had to do an extra 20% of exams or even an extra 15% of exams, there is a huge stress on your economy. Well, what are the take-home points? Imaging referral guidelines and clinical decision support is very useful to back up your decisions for doing or not doing a test, the justification process. When you are performing justification, and this should be done by someone who is trained and has time to do so, it would help if you had technology to support you. And don't forget, we have given you temporary access here so you can look at how we get support. When you return a request, return it with a reason. People like to know why, but more importantly, they like to have the education that goes with it. What extra clinical information would be useful? What are the red flag signs that would make back pain something that would be worthy of investigation? Headache, those are the 2 big ones that we deal with. Or what alternative test? MR rather than CT for brain scans. Or indeed, if a specialist clinical review will be far better for the patient to implement treatment sooner rather than have to wait several weeks for the imaging investigation, which will make no difference anyway. Feeding back what you do is very important because people learn through feedback. And of course, I finish off by saying that when you're looking to see how well you're doing, use clinical audit with metrics. Metrics is a science. Everything else we do is an art. Thank you for your attention.
Thank you very much, Dr. Dennis. It was very valuable 2 presentations. We learned a lot from you. You are leading the implementation and of justification, referral guidelines, clinical audit in Europe. You really thank you very much for traveling, for giving us your experience. And now you know that we finish with the dessert. And I have a sweet thing to present to you. She's a professor in radiology in UK. She's the president of the World Federation of Pediatric Imaging and the chair of Outreach Committee of the European Society of Pediatric Imaging. She's a dear friend of me and most of you, and a friend of our society. I would like to welcome Professor Joanna Brown. Thank you very much. You have the floor.
Great. Hello, everyone. I've never been a sweet person or called sweet person before, so I really, really love this introduction. And it's a really great pleasure to be here and be part of this radiation protection session. And I will start my talk, and because today I would like to discuss with you the new recommendations in abdominal imaging in children. It's not really in children, we stress it in children, but it's also very valid in the adults. And I would like to talk about the abdominal shielding. So we talked in the previous lectures how important is abdominal shielding for us, radiologists and technologists, when we do the procedure. But what's happening with our patients? And before I go any further, I would like to ask, how many of you are using the shielding when you do the abdominal X-ray or the CT in children? Is anyone using it in the practice? Not many. So I don't know if you are using it or not telling me about this. Right, I work in the department that we have a very big group of technologists. We work very, very close with them. And we have the whole spectrum of the radiographers, technologists who are very, very experienced with 40, 50 years experience, and very new ones who are just finished university. And I found it that everyone is doing in a different way. Some people use the abdominal shielding in children and some don't. This is because they feel that how to protect the best patient in the best way in their department. So even in Europe and in UK, where we have a very well-established guidelines, the people still use it in a different way. So in my short presentation, I would like to go with you and look at the scientific evidence, the current regulation and the guidelines, and the change. Is the change in the abdominal shielding necessary or not? And our role as a radiologist and technologist in changing the practice. So we all know that the radiation risk in imaging is there, and it's related to the using the X-rays and the CTs. And you have effective dose with a lifetime risk of the fatal cancer. And we all know this status. And what we also know that this is a document published, as I would like to tell you, in 1982 by the International Committee on Radiation Protection. And what this document said, that the gonads on the individuals with reproductive potential should be protected if the primary beam is within or closer to the organs. And shielding does not exclude important diagnostic information. So this is the information and the document that we all been brought up on it. And this document looks through the different presentation and show us that the abdominal imaging in abdominal imaging, we can reduce the absorbed dose to the testis up to 95% and 50% reduction in absorbed dose to the ovaries. In skull imaging, we can reduce 50 to 70% reduction to the eyes if we use shieldings. But this is what I wanted to point it out, that this is the research based on the paper published in 1982, which is quite a long time ago. Then we have another publication in 2013 about the radiological protection in pediatric diagnostic and interventional radiology, and another publication on the radiation protection and safety done in 2018. But as you all know, why we talk in the children, especially in children about the radiation protection, because they are much more sensitive to the radiation in the adults. But we also need to remember about the adults population. So we have ways how we can optimize the radiation exposure and minimize the radiation risk. And you can see here in one part of in the mid of the list that shielding of gonads, breast and the thyroid, we should be using it as it's possible. But this, as I said, it was before.
It was 20, 30, 40 years before. But now our practice, and this is what we do in the real life, is changing. So you can see on the pictures here the old-fashioned X-ray, when the X-ray and the radiation dose was incredibly high, but we don't have it anymore. We have the new machines. So we just need to adapt our practice to this, what we are doing. And why change? It's a lot of articles, a lot of research published, and checking if it's really necessary to use the guidelines and to use shielding. From 2012 to 2018, many groups, many teams are doing through the research. So really, just to remind us that the main source of the radiation dose to the internal organs outside the primary beam is a scattered radiation. And the scattered radiation really outnumber primary X-ray during the abdominal imaging, and shielding cannot really reduce the scattered radiation, as you can see here on the pictures and from the physics perspective. And the shields reduce equivalent doses of superficial organs more effectively than doses to the internal organs. So yes, we can prevent the skin and protect it, but not the internal organs. And this is a really nice publication which has been done in 2019 and published in Insight of the Imaging. And the authors look through the radiation doses through the years, how it's developed and how it's changed with changing of the equipment. And you can see a big decrease in the radiation dose between 1985 and 2015. And look the effective dose to the organs and the weighing factor. When we were using the previous older equipment in 1977, the effective radiation dose was 25, 20 in 1980, but it's only 0.08 in 2007. So we need to remember about the developments with increasing and improving techniques. We also need to remember that previously we really believed that the gonads on the hereditary effects on the gonads from the radiation protection. But this really have not been demonstrated in the recent research. And we need to also remember that we all think about the gonads, but we have other organs within the body that they have a higher level of radioactive sensitivities and they are not shielded. So when you look here, all of the organs included above the gonads in the table, so bone marrow, breast, colon, lung, stomach, they are all more sensitive to the radiation dose than gonads. So when we use the shielding in abdominal imaging, we need to remember about the correct placement, good size and the shape of the patient, movement. This can move and be displaced during the procedure, and also anxiety of the pediatric patient if we put something big and heavy on them. Also, obscure the overlying anatomy and examine organs, incomplete covering of the organs, and necessity to improve and repeat the examination. And this is one of the research that has been published in 2009, so quite a long time ago. And the authors examined over 300 girls who underwent MRI, and they look at the position of the ovaries within the pelvis. Is it really in this place when we cover? And what they found, lateral position in most of the ovaries, in most of the children. So the medial shielding, what we use in the current practice, is not covering the ovaries because they are not there. So what should we do? Should we change it to the lateral covering of the ovaries, as you do here? Should we do the full covering of the pelvis? But if we do the full covering, how will we see the important information? So this is another study published 3 years later, using and looking on over again 300 patients from birth to 60 years, and again assessing the position of the ovaries on MRI of the pelvis. And again, you can see here that when the child and the woman is growing, the position of the ovaries is really changing in the body. So here it shows also the other study, how the position of the ovaries is changing with the full bladder and not the full bladder. And you can see when the bladder is empty, the position of the ovaries is completely different of the position when the bladder is full. So again, something that we need to remember when we use the gonadal shielding. So the embryological descent of the ovaries doesn't stop at birth. It will continue into the childhood and to the teenage year, and the high risk of the obscuring clinical markings will happen if we want to cover the whole pelvis. So even the accurate placement of the shielding will not necessarily provide the cover of the ovaries, because they are positioned in such various places in the pelvis in females. So this is review of the pelvic radiographs, another article from 2012. Over 500 pelvic radiographs has been reviewed, and look what we found, that 91% of the radiograph for girls had the incorrect position of the shielding, and 66% of x-rays for boys. And this was multi-center study. We all know how busy is in the clinical practice. We can put the shielding on the bodies, the children move, the shielding is moving. Look at another, this is another big study from 2012, and which puts all of the information about 10 articles showing the number of the radiographs working with shielding and the percentage of incorrectly positioned. And look at the difference. The difference between incorrect position between the different centers was between 26% and 78%. So again, very big differences. So it's a really significant argument to stop the shielding using in the pelvic radiographies in children, especially that we are using more and more sophisticated and complex equipment. So if we use the modern equipment and if we properly optimize the image protocols, this will be a better radiation protection than using old-fashioned shieldings. Also, our digital detectors are more sensitive, and the imaging post-processing software can reduce very significantly dose to the patient. So the risk reduction for gays and boys by using the imaging shielding will be marginal. And this is one of the really good research published in Pediatric Radiology in 2018. This is a good one because it was a prospective project. It was done on the phantoms. And you can see here that by using the different imaging, they look at the change in dose area product and the absorbed organ dose. And look at the research and the results here. So when you use the automatic exposure control, this terminates the exposure, and when target the dose is received by the sensor. So when you use the shielding in the abdominal imaging, it's confusing the automatic exposure controls, and in the end producing increase in the patient dose. So this was this prospective study. I would really suggest that you will look into it if you are still using the shielding in the anatomy. And look at the decrease and the increase in the dose, increase in 65% in the 5-year-old and up to 147 in adult phantoms. This wasn't done obviously on the patient, but on the phantoms, but the increase in dose is substantial. And also, we need to remember about the other organs, because if we use the shielding, and we are lucky to cover the organs, by using the automatic exposure control, the other organs that are more sensitive to radiation will receive the higher dose. And look at the doses to the colon, they increase by 21 to 51%, and to the stomach between 17 and 100%. So by protecting one organ, we are increasing significantly risk to the other organs. So in conclusion, the authors say that the female gonadal shielding used in combination with the automatic exposure control are likely to increase the overall radiation risk and really shouldn't be longer used because we are using and causing more problems to the patients. So the question, should we change in practice? Should we stop using the gonadal shielding? And this is several articles that I put it up for you here that is showing further research and showing we really should be stop using it. So the current regulation that we are having available is the publication from 2007, 2012, 2013, and 1982, which still recommends using the gonadal shielding. But remember, this is the publication that is going to be changed soon because this has been published on the older research. So change in practice, American started. So this is the American Association of Physicists in Medicine, and they look through all of the evidence, and in 2019, they stopped using the gonadal shieldings in the United States because they found that it's causing more harm than protection. Who follows? The German Commission on Radiological Protection follows, and this was the first publication done by the German Society in 2018, again on use on radiation protection, and it's recommended by the Commission that it shouldn't be using. UK, we've been the next country in Europe, and our British Institute of Radiology published a guidelines in 2020 on using shielding on patients for diagnostic radiology applications, and you can find these guidelines here with this website. What is really good about this guideline? Sorry, I exceeded. My next one will be shorter. The guidelines the publication is quite long, but you will have all of the relevant information and articles included in this publication. So if you want to talk to your managers, if you want to talk to your patients, if you want to talk to your colleagues, you will have all of the information which is there. And the European Consensus on Patient Contact Shielding, which has been approved last year, and you can see how many different societies that are included in the radiation protection work together, and they produce the European Consensus, and you can see here the recommendation that the abdominal shielding is not longer required because it's not longer recommended in pediatric and adult imaging. So abdominal shielding, should be using it. I think that each of us really needs to look through the new recommendations and stop it. But I said you probably will cause and will find exactly the same problems. In my department is the big division. Some people still use it because they've been taught that way and they've been using it through the whole life, and some people are using it, stop using it. So it's really for each of you as an individual person, you need to make a decision, is it good for your patient or not? But all of the research and recommendations are visible on the line. So the shield, probably yes, and thank you for your attention.
Thank you very much, dear Dr. Joanna. Really, you tackled a very important point, and I think we will all get back with the different impression and views towards the use of automatic exposure control and shielding. You were brave enough to hit a debatable issue, and you cannot imagine when we sit who defend the use of shielding with those who doesn't appreciate these high doses caused by shielding. But the information, as you said, will drive us to a new world of new regulations with the new ICRP 2022. Thank you so much, and we are eager to listen to your second presentation. Please go ahead.
Thank you. I'm really sorry I exceeded my time for the first one, but it's such a controversial topic at this moment, and it's really, really difficult to make the change. It's difficult to make a change in any department. So this will be just a very short, just really reminder to you about the communication of the radiation risks, and especially in pediatric imaging. Why is it important? Because it's the largest ionizing radiation in the healthcare, is the largest contribution to the exposure of the general population. And as you see here, we are doing millions and billions of different X-rays, CTs, and the other examination in our radiology department. And especially in pediatrics, we are really increasing the use of the X-rays and the use of CTs for any information. Very often pediatricians will just send us the patient with the smallest or more subtle clinical symptoms and say, please do CT. CT will show us everything. But we just need to remember about the radiation risk. And the most important is that we need to communicate it to all of the involve people. And we need to remember that the radiation benefit risk dialogue is the ethical duty, but also is the requirement for all of the medical professionals. And this has been described as the requirement in the basic safety standards, as you can see it on these images. And we really need to think about the balanced approach. Is it the benefit or is it the risk? Which is the most important? And until now, we've been discussing it between us as a medical professionals, but we need to go farther away. We need to involve the clinicians who are requesting the clinical examination, but we also need to involve the parents and the general population. It's really, really difficult because all of us are so busy in our clinical work, but the communication of the radiation risk is incredibly important. And from the balanced dialogue, we need to support all of the information so the patient not only give us a consent, but also they will be taking part in the informed decision-making in the pediatric and general healthcare. And as I said, we are the center of this process. So all of the healthcare providers performing radiological procedure. So radiologists, technologists, medical physicists, we are responsible for this part of the imaging and the radiation protection. And we need to influence and we need to work closely together with everyone who requests the clinical examination, but also with patient families in population. So through the many, many years, doctors were trusted, respected, and the patients and everyone just followed the advice without any additional information. And no one really complained about this. And this is a good that patients trust us because we have enough knowledge and experience to lead them, but we need to treat them as a partners. So instead of the paternalistic approach saying we will do this one, let's do the patient-centered approach and explain to them why we are going to do it. So we need to remember about the effectiveness of the benefit-risk dialogue and look at the different individual factors that they can influence our patients. So the patient knowledge, the patient attitudes of the benefits, about the previous experiences that patient can have from the imaging department, about the vulnerability, about the anxiety, about the discrimination of the patient. So very complex issue. And also we need to think about the risk perception with a personal influences on the individual risk perception as a social factors, belief system, and the previous expenses. So the perception of the risk and radiation, it's really important to do it with our patient. Also, what is changing, now everything is available online. So most of my patients, if they are coming for any investigation, the parents will Google everything. They will find all of the information. So we can't say and dismiss them because they won't trust us. We need to show them that we are professionals who have a lot of knowledge, can explain to them, and they can also ensure them that this investigation is right. So this is the one aspect. The other aspect, we can use the social media for our advantage because we can give them and all of the patients the right information before they will come and see us in the clinics. So more people go online for her information than for anything else in the maybe apart from the shopping on the website. And the social media can really help us, cannot replace our personal dialogue with the patient, but we can use it as a supportive tools. And really, patients and families should be a part of the benefit-risk discussion so they can understand all of the information and they can use it, what decision they would like to make. And if they are not informed in the proper way, especially the parents, they may refuse a procedure or they might demand the procedure. Like many parents going to the A&E and saying, could I have a CT because my child is not well? But they need to know that the information is important. So dialogue with patients and the families, it's incredibly important, but also interprofessional dialogue. We need to remember this because if we work and if we educate our GPs, our family doctors, our pediatricians, our work will be much, much less because the patients and the parents will come prepared to our busy clinics. And it's really important not only to go and talk about the consent when the patient agrees to do the examination, but also to provide enough information and the information on the right level, necessary information, so the patient will be involved in the decision-making process, not just giving a simple consent. And in our life, we are busy. We talk to the patients, but we need to look, as I said, through the websites, through the available resources, and to look at the toolkits, how we can communicate with the patients. And you can see on my slides that I have a WHO logo, because WHO is doing an amazing amount of work to help us to communicate with the patient. And this is a tool to support. It's a really good publication, Communicating Radiation Risk in Pediatric Imaging. It has been translated into the 7 languages, and Arabic is one of the languages available. This is the publication which is open and available online for everyone. And what I really like about this publication, that we have different chapters. First, we have a scientific background. So as a busy people, we don't need to go into the Medline or anywhere to look at the articles, because someone else did it for us. It's already there, all of the recent publication and the research. Then we have a concept and principles on the radiation protection, and also we have a chapter of the risk-benefit dialogue. So everything is ready for you. So how to expert the perceived risk, how to talk to the public about this, what pathway we can use it. We have many practical tips in this publication, how to use the communication tools with patient, how to access and how to explain to the patient the risk which is involved in the radiation in children, pregnant women, to the future generation. You have all of the information onto this website. You also have a chapter about the message mapping and the examples of the questions that the patient can ask you, or all the other clinician may ask you with the question. So what medical imaging procedure use ionizing radiation? Patients may not know, not knowing about this. What procedure are the most valuable in, and have the higher risk of the radiation? Or why are you recommending this radiological examination? How great is the risk? So this is all of the questions that your patients will be asking, and the answer is included. So creating the dialogue about the radiation risk is incredibly important, and we all know that we need to center really and have in our focus the patients, parents, and the caregivers, but all of the other groups will be involved in our work and the profession. But as I said in the beginning, the medical physicists, technologists, and radiologists, we are the most important. So use everything which is available online. Apart from the bigger publication that will be more for us and other healthcare professionals, we have a lot of posters and leaflets that I use it in my clinical practice for parents before they will come to the examination. So this is like a 1/4 paper printed both sides. And this is a question, what do we need to know for the X-ray examination in children? We have it printed in our department, it's lying in the waiting room, and the parents can see it when they wait for examination. Very often, recently, we are sending the appointment for the X-ray by emails, and we are attaching this PDF format, so the parents can lead the examination and read all of the information before. The other, so this is one of the leaflets is about X-ray examinations in children. Then we have also information about CT. What do I need to know about the CT in children? Again, this is created for parents. About the nuclear medicine in pediatric imaging, and also about the X-ray guarded intervention in children. So this is all produced and it's freely available, done by WHO. So I will just encourage you, please use it, because it will make yours, and it's making my life much, much easier going through the stages. And this is another project that we are doing with the WHO over the last years. Before COVID, we were doing courses on the radiation risk and the communication. they've been settled in the different countries, but now, as it was COVID last year, together WHO with the Geneva Learning Foundation started a course on the benefit-risk dialogue in pediatric imaging, and this is a really multinational course. We have people from over 100 countries joining into the course, and it's really nice because it's the building this great family and the group of people who are going to be champions and look at the radiation risk in the different countries. And we also have people, radiologists, pediatricians, and technologists from Egypt who are part of this program. So effective radiation risk communication, it's really, really important. Use all of the tools that are available and try to make it in your busy practice. And why it's important? Because our patients are important and we can communicate and tell them and provide a better service. So that's all from my presentation, and I hope you found it useful and helpful. Thank you.
Thanks, dear Joanna, for her excellent and practical presentation, and hope we are going for more communication and more cooperation with you. Many thanks.
Great, thank you very much.
Now, the last presentation and the last Egyptian suite, Professor Nahed. Professor Nahed Mustafa is the ex-president, ex-vice president of Suez Canal University and one of the leaders of research and research ethics in Egypt. During this conference, we are only one research topic, but after that we are looking forward to more presentations and a session for research. Please, Dr. Nahed.
Good afternoon, everyone. Thank you so much for your kind invitation. It's my honor to be with you today to discuss an important issue about research misconduct. We suffer a lot being a vice president for the research affair. We suffered a lot about research misconduct. First, I have a question. Do any one of our colleagues involved in research misconduct? So I will repeat my question by the end of this session. What we will be covered during a few minutes, it will be about what's meant by research and what's meant by research misconduct, and we will try to identify the causes and the consequence of research misconduct and explore some real example from around the world. What is research? What do you think? What is research? Is there any reply? If we look to the meaning of the word, it consists of two parts, re and search. Re, that's say to do it again and over again. So many people will build their research on our research. And the meaning of research to examine carefully and closely. But if we look to the scientific definition of research, it is a systematic investigation to reach to a generalizable knowledge. Here we have two keywords, systematic and generalized. What's meant by systematic? Let's say we have a scientific problem or we have a hypothesis and we try to answer these questions. So we suggest an inclusion and exclusion criteria. We determine our sample, we collected the data and then analyze to reach a conclusion and to reach to the answer of our questions. And what's meant by generalized? Generalized to whom? Remember that in our research, we are working on a sample. We are working on a sample of diabetics, of MS, of myocardial infarction. But the result of our research will be generalized to other diabetic patients. This is, for example, So the first generalization is to the population from which we have our sample. The second generalization is in our field of study, because if you are working as a radiologist and you have a prestigious research, many people will do again and build on their studies upon your study. So, as a research community, we have an obligation to our community, because we are doing our research on our population and our so we need to have reliable and valid result from this research. Otherwise, we will use our population as a guinea pig, and they will be a vulnerable population, because you put on your white coat even in the clinical setting or in the research setting. So we have to remember that and avoid therapeutic misconception. And we have obligation to ourselves to promote our career and to help others in our career. And we have an obligation to our colleagues, because they will use our result and build on that. The second definition, what is research misconduct? There is a debate in the definition of research misconduct. The American expression, according to the Code of Federal Regulation, it is FFP: fabrication, falsification, and plagiarism. In what? During the proposal, when we prepare our research proposal or grant proposal, during implementation of our research, during reviewing of our research, and during reporting of our research. This is the American definition. What the difference between fabrication, falsification, and the plagiarism? Fabrication, simply do it from scratch. There is no research, and they fabricate it from scratch. However, falsification, you do a research, but you manipulate the result of your research, or you change in the material and the method to reach the answer of your desired questions, not the real questions. The plagiarism, simply, it is a stealing. I steal the other idea. I steal the other word. So it is exactly, it is the stealing of the words or the idea of other without mentioning that it belongs to them. So it's a violation of the intellectual properties of others. However, there are different types of research misconducts other than fabrication, falsification, and the plagiarism. What do you think of this picture? What's your impression? Someone omit some results. Why? Because the actual result doesn't match the answer that the research team wants. So he started to omit some result. Being said that, our research should be valid and reliable, because it will answer the study questions, which will be generalized, and it will be replicated, as we said above. For the data falsification, here are some examples that say adding values, dropping the outlier without explaining that, do statistical analysis in inappropriate method, ignoring some result or modifying agent. Real examples, which is published in 2004, the number A is the original image. What is the difference between the original image A on the left and on the right? What happened? What happened? What is the difference between this image and that? This is the original image, and this is the published image. What is the difference? they deleted a band on the third column. And for the case B, this is the original image, and this is the published one. What is the difference between them? They add a band in the column 3. So they manipulate, they did research, exactly, but they manipulate the image, and this is a type of falsification of data in research. Important publication from the International Journal of Clinical Oncology in 2016. They mentioned some important worldwide example of research misconduct that happened in the clinical trial of the breast cancer. Can you imagine? If violate the valid and reliable data of the clinical trial of the breast cancer, you notice that on the left there is falsification of eligible criteria, fabrication on a single institute, fabrication, falsification, fabrication, falsification. This is what happened. But what are the consequences? Look at the right side. What happened to the researcher or the research team? Barred from research funding, dismissed, prison, dismissed, resigned, 11 paper retracted, 9 paper retracted. So actually, research misconduct lead to scientific scandal. This is one who steal the other idea. And I insist plagiarism is some sort of stealing. We will do exercise with each other, and I need to hear your opinion. This is the original text. Ali et al. 2016 stated that to better understand the risk and the preventive factors for drug abuse in Egypt, quantitative and qualitative data have to be collected. And this is the reference. One of the students, of the postgrad student, take this segment and write the following. It's important to study the risk and the preventive factor for drug abuse in Egypt through a mixed approach of quantitative and qualitative research. Is it a case of plagiarism? Who say the answer, yes or no? And why? I need to hear the junior researcher. Is it plagiarism or not? No reply? It is a case of plagiarism for two reasons. He tried to rephrase the segment with the same sequence and the same words. The second crime, there is no citation. Each piece of information without citation, let's say it's my word. And this is the violation of the intellectual property of the original publisher. The second student stated that quantitative and qualitative data should be collected to better understand the risk and the preventive factor for drug abuse in Egypt. Is it a case of plagiarism? Yes or no? This is a mosaic plagiarism. ذهب أحمد إلى الحديقة، أحمد يذهب إلى الحديقة. This is called mosaic type of plagiarism, and the second violation, there is no citation, as if it is the author words. The third one stated that to better understand, he repeated word in word of the original text. For sure, it is called the direct type of plagiarism. The fourth one, or the fourth student stated that risk and the preventive factor play a crucial role in assessing the amplitude of drug abuse problem in Egypt. The phenomena may be explored through a mixed approach of quantitative and qualitative research. And he mentioned the author and write the reference. This is the proper type. Okay, one only. Okay. 5 or 1? 15 minutes. Okay. So this is not a case of plagiarism because there is paraphrasing and keeping the same idea and write the citation and write the reference. So this is not a case of plagiarism as the other previous cases. As we said, plagiarism is the violation of the intellectual property. Only in the published paper? No. This can be applied to the manuscript, to the grant application, to the clinical research, to the student paper, to the work either published or not, to the written work, even in the images, or using the videos, or a piece of music in educational video, we should cite and we should mention what is the original author or publisher of this segment. Be careful from what is called the privileged information. I will speak it in Arabic. المعلومة اللي بتقع في حجري وأنا بستخدمها في البحث بتاعي. يعني suggest that you, for example, you are an editor or peer reviewer and you postpone this reviewing until picking up this part of information and used in your publication. This is called the privileged information. When we write a year has 365 days, should we cite that? No, we shouldn't cite because it is called a common knowledge. Another type of misconduct, and this is the European style. For example, it's not only fabrication, falsification, or plagiarism, it's also as negligence, unreported conflict of interest, violation of the authorship. So the misconduct cover many aspects in our research team. I asked you in the first, do you involve it in research misconduct? And you said no. I think no one answered, so the answer is no. Briefly, what is the preference from the published paper? In Egypt, we published this paper in 2017 about the misconduct. And we noticed that 74.5 reported having knowledge of misconduct, and nearly 30% is involved in fabrication or falsification. In India, another survey, 53 say that plagiarism, falsification, and the violation of the authorship. In Nigeria, 68.9 of the researchers involved in misconduct. In the United States, a survey suggested that there is underestimation of the misconduct and there is high prevalence, you show the number of the misconduct among the research. In the United Kingdom, in the British Medical Journal, in 2012, one of the surveys stated that 1 in 7 UK-based scientists or doctor has witnessed colleagues involved in research misconduct. In conclusion, one of the scandal, please be careful about yourself and about your reputation and about the reputation of your institute. Because when our names are illustrated online and with the term retracted because of plagiarism, retracted because fabrication, retracted because double authorship or ghost of authorship. So this is a scientific conduct. I try to tell some stories, but it will be available in my lecture. This is a real stories from around, all around the world. And in conclusion, I would like to say that to avoid the misconduct, we need the responsible conduct of research training. We need appropriate policies and the process, promoting the culture of research integrity, and the consequence should be made to all researchers. The take-home message, Scientific misconduct is the trap of the scientific career. It's plagiarism, fabrication, falsification, and the other form of misconduct. Thank you so much. And this is some example of the research.
العظيم ده. بس حضرتك قولي لنا الحل ايه؟ الحل الاجيال الصغيره اترضعت على الحاجات دي. الاجيال الصغيره مثلا في التعليم، لما جه وزير التعليم عمل مقاله ومش مقاله، بصينا لقينا تبص تلاقي الولاد الاهالي واخدين ورايحين طوابير عند مدرسين قاعدين هم اللي ايه يفبركوا برضه تعلموا الولاد بالصور. دي مشكله كبيره جدا. في ناس دلوقتي بتكتب متخصصه كتابه رسائل، دي مشكله كبيره وحضرتك 100% بتساعد. فالحل ايه بقى؟ اتفضل. يعني مشكله فعلا. يعني حضرتك يعني حطيتي يعني زي ما بتقولي نكهه الجرح زي ما بيقولوا، او حطيت ايدك على حاجه خطيره.
اشكر حضرتك. ممكن اعلي صوتي؟ بشكر حضرتك جدا على الكومنت. انا عندي عقيده كواحده اشتغلت في الاداره لفتره طويله، قبل ما تحاسبني حاضر يعني هقول عربي بس بسرعه للولاد وبعدين اترجمها للانجليش. قبل ما تحاسبني علمني، دي القاعده رقم 1. ايه اللي حصل في 2016 لما كنا في المجلس الاعلى للجامعات؟ فرضنا ان لازم يبقى في تريننج على الريسيرش انتجريتي اند ريسيرش ميسكوندكت. دي الحاجه الاولانيه. الحاجه الثانيه ان كان حضراتكم تفتكروا في 2015 طلع ترتيب مصر في الفايوليشن اوف ذا انتلكتشوال بروبرتي وفي البلاجيريزم، كنا من الدول المتقدمه للغايه في السرقات العلميه. ولو تفتكروا حضراتكم طلع الوزير وقال دي فضيحه مصريه ومش عارفه ايه. انا ساعتها قلت في المجلس الاعلى للجامعات قبل ما تحاسبني علمني. 1. الحاجه الثانيه ان عملنا البوليسي اللي هي ماشيه لحد دلوقتي في الجامعات المصريه. عملنا الوثيقه بتاعه الامانه العلميه، وحتى هو حضرتك الستامب مكتوب عليها جت من جامعه قناه السويس يعني. وقلنا ان لازم ما حاسبش الناس مره واحده، يعني لازم اسمح بمارجن بالبلاجيريزم. فحددنا المارجن ب 25%. شرط لازم يكون زيرو في الريزلت. ليه؟ عشان ما ناخدش جداول او ما ناخدش ايمج نعملها. الحاجه الثالثه اللي عملناها يا فندم ان اتحنا ان السوفت وير بتاعه البلاجيريزم تشيك، فترتب عليها برضو ان كل رسائل حضراتكم او كل البيبرز اللي بتترقوا بيها قبل ما بتقدموا بيعمل معاها البلاجيريزم تشيك على السوفت وير. هيؤسفني بقى اقول لحضرتك حاجه، وهقول لحضرتك بقى حاجه يعني، ودي للاسف الشديد حصلت معايا من الكليات الطبيه. يبدو ان العيال في الطب بيبقى مخها عامل ازاي. ضحكوا على السوفت وير، ضحكوا على السوفت وير. شالوا كلمه مثلا كل حرف او بقوا يحطوا بدلها زيرو، كل اي او ال يحط بدلها 1، فلخبطوا اولادنا، لخبطوا السوفت وير.
ودي قلتها كتير قوي، حتى كمان مره قلتها هنا في تلفزيون القناه بتاعكم. قلت البدايه من الصغر، من البدايه من احنا المشكله مش في الهاي ادوكيشن، المشكله انهم اصلا رضعوا ايه من الاول. فيا ريت نبدا برضه من يعني الكلام اللي حضرتك بتقولي ده جميل جدا، وكلام يعني حطيت ايدك على الجرح فعلا يعني، وكلام يا ريت يعني ده هو ده اللي يقدمنا. لو احنا مشينا كده هو ده اللي يخلي عندنا بحث علمي صحيح. بس يا ريت نبدا من
يعني. دكتور ناهد انا مش دكتورة ناهد I cannot thank you. دكتورة ناهد I cannot thank you enough. دكتورة ناهد I cannot thank you enough. You are investing your time. I heard the last period in training the young researchers online and on site. So thank you very much. I enjoyed your presentation. And to add to the point that the policies has to be there, I have to tell you, because this is an opportunity from this ethics and radiation safety session, to say that Egypt in 2022 have two very, very important international publications worldwide with the International Commission of Radiological Protection. This is you know, the major commission that puts the radiation safety guidelines, and Egypt is participating among 9 members in this publication, so it is very useful. So, and please, I advise you to go through it. And the other thing is ethics. We have a new document with the WHO. It's called Policies in Ethics in Radiation Protection, because this is the place where we should say that, and Egypt is participating among 7 countries. So please go through them. In 2022, they will be released. Thank you very much, and we would like to close the session. Thank you.
شكرا. وبس هنشوف بس دلوقتي المفروض هيبقى اعتقد البريك عشان الغداء، بس هنتاكد بس المطعم هيكون جاهز ولا لا. نعم يا فندم. لا بس هعرف بس الاول، بس ابتدوا ولا لا. نستارت الماسكوسكيتال على طول دلوقتي، وان شاء الله البريك بعد الماسكوسكيتال على طول ان شاء الله. ان شاء الله. اتفضل.
محمد اشرف موجود؟ حضرتك دكتور. اوكي. اتفضل يا بيه. طيب. هم ما كتبوش اسامي يا بيه. طيب يا جماعه عشان الوقت احنا متاخرين ساعه اوريدي. لو سمحتوا نلتزم باماكننا عشان نبتدي.
دكتور سلمها.
اوكي. This is the musculoskeletal session. Okay. Okay, our first presentation will be conducted by Dr. Muhammad Ashraf from Al-Azhar University with the title Meniscal Imaging, MRI versus Ultrasound. لو سمحتوا يا جماعة الصوت عشان هنبتدي. رجاء نلتزم الأساتذة بالوقت عشان احنا عندنا ساعة تأخير.
إن شاء الله.
اوكي اتفضل يا دكتور محمد.
بسم الله الرحمن الرحيم. First of all, I would like to express my deep thanks to the organizing committee, to the scientific committee, to the moderators of the session, and to the audience for giving me the chance to be here with you today. It is me, Muhammad Ashraf from Al-Azhar University. Today I'm going to talk about meniscal imaging, MRI versus ultrasound. In today's topic, we are going to talk about meniscal importance, meniscal anatomy, and the imaging of meniscal pathological changes and pathological mimic changes. The word meniscus is derived from Old Greek word which is meniskos. Meniskos means crescent. The meniskos was a metal bronze fixed on top of some Greek statues. The menisci are fibrocartilaginous structures that used to deepening the tibiofemoral articulation. Menisci act as shock absorber. It serves as cushions to reduce the stress on the joint. It has an important role in the stabilization of the joint by limiting the extreme flexion and extension. Also, it plays an important role in synovial fluid dynamic circulation. Each knee joint has medial and lateral menisci. Each meniscus has anterior root, posterior root, anterior horn, posterior horn, and body. In cross section, the meniscus appears as triangular in shape. The main differences in anatomical shape between medial and lateral menisci, the medial meniscus is semicircular in shape, while the lateral meniscus is incomplete circle in shape. The medial meniscus is larger than the lateral meniscus. A medial meniscus posterior horn is larger than anterior horn, while both horns are of same size in the lateral meniscus. The medial meniscus covers about 60% of the corresponding tibial plateau, while it is 80% in the corresponding tibial plateau in lateral meniscus. This is an MRI image, sagittal plane in the lateral meniscus. This is the anterior horn and this is the posterior horn. This is MRI image of the medial meniscus. This is the anterior horn and this is the posterior horn. And this coronal image of MRI of the menisci. This is the lateral meniscus and that is the medial meniscus. This is an ultrasound image of the medial meniscus. The meniscus is that triangular shape isocoque structure, and this is the medial collateral ligament. This is the lateral meniscus by ultrasound, and this is above the iliotibial tract. Each meniscus has superior articular surface known as femoral surface, inferior articular surface known as tibial surface, inner free edge, and the periphery. The main differences between meniscal and lateral in attachment, that the medial meniscus anterior horn is attached anterior to the tibial attachment of the anterior cruciate ligament, and the medial aspect of the medial meniscus is attached to the related medial collateral ligament, and the posterior horn of the medial meniscus is attached between the insertion of the posterior cruciate ligament and the posterior horn of the lateral meniscus. In the lateral meniscus, anterior and posterior horns are attached anterior and posterior to the attachment of anterior cruciate ligament. The lateral meniscus is not connected to the lateral collateral ligament, and the lateral meniscus is not attached to the capsule of the knee joint in relation to its posterior horn. The menisci are attached to the femur via meniscofemoral ligaments that connecting the femur to the posterior horn of the lateral meniscus. They are seen in the sagittal image of the MRI surrounding the posterior cruciate ligament. The posterior one is known as Rysberg ligament, and the anterior one is known as ligament of Humphrey. There are also the transverse meniscal ligament, which is connecting both anterior horns of both menisci. It is seen here in the sagittal image. Also, we have popliteomeniscus fascicles. They are connecting the posterior horn of the lateral meniscus to the popliteus tendon. The importance of the popliteomeniscal fascicles is that it is sometimes reported as pathology in the posterior horn of the lateral meniscus. We should know that it is normal attachment and normal fascicles seen in the normal anatomy. The menisci derive its blood supply from the genicular artery. It is divided into 3 zones. The peripheral zone is known as red zone, and the inner zone is known as white zone. And the intermediate zone is red-white zone. The peripheral zone is vascular. The inner zone is not vascular and derive its supplies from the synovial fluid. The menisci takes its nerve supply by the posterior articular branch of tibial nerve and terminal obturator and femoral nerve branches. This is the medial meniscus in sagittal MRI images from outer to inner. This is the anterior horn, this is the body, and this is the posterior horn. And this is the ligament of Humphrey, anterior to the posterior cruciate ligament. Here, this is the lateral, this is sagittal images showing the lateral meniscus. This is the transverse ligament connecting the anterior horns of both menisci. This is the posterior horn, this is the anterior horn, and this is the body. We are going to discuss the imaging of discoid meniscus, which is known as normal variant, degeneration in meniscus, the tear, respiratory grip, fluence, and meniscal and parameniscal cysts, the meniscocapsular separation, and meniscal ossicles. Discoid meniscus is normal variant seen in about 3 to 5% of MRI examinations, usually seen in the lateral meniscus. Discoid meniscus is diagnosed in the coronal image of the MRI when the transverse diameter of the body of the meniscus exceeds 15 millimeter, and is diagnosed when the body of meniscus is seen in 3 consequent sagittal images. Usually in tear and degeneration, the medial meniscus is more vulnerable to injury due to its intimate attachment to the medial collateral ligament, while the lateral meniscus is not connected to its overlying lateral collateral ligament. The degeneration in menisci is usually due to gradual wear and tear in the meniscus. It is commonly associated with osteoarthritis. It is seen in MRI and classified into grades. Grade 1 is seen as small focal hyperintense area within the horn of the meniscus. Grade 2 is divided into A, B, and C. In A, it is linear abnormal high signal. It's seen not connected to any of the surfaces of the meniscus. In grade 2B, it is seen connected only to one surface. In grade C, it is seen as triangular shape area within the meniscus. Some authors say that in the grade 2C, in the arthroscope, mostly seen as tear. While grade 3 is torn meniscus, it's connected to surfaces. The tear is divided into simple and complex tear. The simple tear is horizontal, vertical, and radial. the complex tear, the flap tear, the bucket handle tear, parrot peak tear, meniscocapsular separation, and meniscal extrusion. This is the horizontal tear. The horizontal tear usually come after degeneration of the meniscus and osteoarthritis. This is the horizontal tear seen in posterior horn of the medial meniscus as a linear high abnormal signal reaching the articular surface. In ultrasound, it is seen as echogenic line reaching the articular surface. This is the vertical tear in the meniscus. Usually, it is associated with trauma. This is the vertical tear in the posterior horn of medial meniscus connecting the superior and inferior articular surfaces. And this is the tear in the ultrasound is seen as echogenic line reaching the articular surface. As we see, there is no major differences between the oblique tear and the vertical tear in ultrasound images. And this is the radial tear. Radial tear can be seen in sagittal, axial, and coronal images as by absence of part of the meniscus. Also, there is a sign known as ghost meniscus. It's called ghost meniscus because some part of the meniscus is missed. And this is the flap tear. Here is the abnormal signal in the posterior horn of the meniscus. And this is the flap torn here seen in the coronal image. And this is the torn flap seen by ultrasound as heterogeneous area within the meniscus. And this is the bucket handle tear. This is the torn part of the meniscus, usually seen in medial meniscus, but sometimes also seen in lateral meniscus. There is a very famous sign seen in the sagittal image of MRI known as double BCL sign. This is the posterior cruciate ligament, and this is the flap torn from the medial meniscus. It is seen here anterior to the posterior cruciate ligament, giving the double BCL sign. Here in coronal image, this is the lateral meniscus, this is the medial meniscus. As we say, the medial meniscus is larger than lateral meniscus, but in this image, we can see that medial meniscus is smaller than lateral meniscus, and this is the torn flap. This missed part from the meniscus is seen in the ultrasound images. This is known as parrot peak tear, and here it's seen in axial, sagittal, and the coronal image. Meniscocapsular separation is seen with there is separation between the lateral aspect of the meniscus and the overlying part of the knee capsule. Here we can see fluid signal seen between the knee capsule and the related meniscus. It's also seen here in ultrasound by presence of fluid signal or fluid echogenicity, hypoechoic area of fluid between the meniscus and the overlying capsule. Risper grip. Some authors say that Risper grip is type of the vertical tear of the meniscus, but it is seen reaching the root of the Risper ligament. This is, in this image, this is the posterior cruciate ligament, and this is the Risper grip seen posterior to the posterior cruciate ligament. In the above image, the ligament is in color, blue color, and the meniscus is in pink color. We can see that the tear, vertical tear here is reaching the root of the meniscus. This should not be misinterpreted by other pathology. Meniscal extrusion is defined that the lateral part of the meniscus is protruded beyond the femorotibial surface. In this image, coronal MRI, it is diagnosed. This is the meniscus, and it is seen extending beyond the femorotibial articulation, and it is seen displacing the overlying collateral ligament. In ultrasound image, we can see this is the part of the meniscus extruded. This is the tibia, and this is the femur. Meniscal fluids seen as wavy part in the meniscus. In the past, it was defined that it's only finding seen also only in arthroscope, but currently it can be seen also in MRI as wavy part or tooth, opposing tooth seen in the lateral image, in the sagittal image. Sorry. The meniscal ossicle, it is uncommon finding, but incidental and important. It is sometimes misinterpreted as loose body seen within the joint space. But here in the X-ray, we can see the meniscal ossicle, and the MRI here, this is the meniscal ossicle. It's well corticated and well defined, and this is anatomical part. The meniscal cysts occur when synovial fluid become encysted secondary to meniscal tear. It is seen in the parameniscal space and known as parameniscal cysts. It is easily diagnosed in relation lateral to the meniscus. This is seen in the coronal image of the MRI, and this is cyst seen lateral to the meniscus in the ultrasound image. In 1990, there was the first research done in Germany for the ultrasound of the knee and said that ultrasound is limited to cysts and bursitis. But recently, most researchers related to the knee ultrasound say that sensitivity and specificity of ultrasound are increasing when compared with MRI results. To conclude, Mrcp play an important role in knee stabilization and the stress reduction of the knee joint. The medial meniscus is more vulnerable to trauma due to its intimate attachment to the overlying collateral ligament. MRI is more sensitive technique for detection of meniscal pathological changes. Ultrasound is a promising technique, and its sensitivity and specificity are increasing in recent studies. Thank you.
بنشكر الدكتور محمد اشرف على النايس برزنتيشن. دلوقتي النكست سبيكر استاذ دكتور حسام منصور جامعه الزقازيق والايميجينج اوف انتيريور ني بين.
حسام حضرتك ما سجلتش؟ لا نزلتها؟ لا في النص بين تو سيشنز. لا بحب استخدم كده. بسم الله الرحمن الرحيم. بشكر هيئة المؤتمر على الدعوة الكريمة، بشكركم على حضوركم. والنهارده احنا في السيشن بتاعة الماسكروسكيلت اللي حابين نتكلم عن الني، فكل الموضوعات يعني ان شاء الله تكمل بعضها. الجزء بتاع الانتيريور ني بين احنا يعني واخدينه يعني او انا يعني هحاول اتناوله بكلينيكال باك جراوند كويس، علشان خاطر يعني هو البيشنت بيبقى جاي لي بين، انا عايز اعرف المشكله اللي ممكن تكون ديت في الانتيريور كومبارتمنت سببها ايه. فبنحاول ان احنا نعمل تقسيمه بسيطه نحطها في دماغنا ازاي نقدر نفكر لما تجيلنا حاله انتيريور ني بين. من اول ما نشوف ان في البريباتيلر سوفت تيشو ممكن نلاقي بريباتيلر برزايتس، ممكن الكوادريسيبس فات باد يكون فيها ايديما يحصل لها امبنجمنت، ممكن الانفراباتيلر فات باد وفي هوفا يحصل لها الهوفا ديزيز اللوكولايزد نودولار سينوفايتس او بيجمنتد فوليو نودولار سينوفايتس او انترا ارتيكولار كوندروما او انفرا باتيلر بلايكا او كل انواع البلايكا هنقولها ان شاء الله. الاكستنسور ميكانيزم ليجنز اللي هي بتشمل ليجنز في الباتيلر تندون والكوادريسيبس تندون واي ليجنز انترا تندنس في الباتيلر تندون، او الاوستوكوندروزيس اللي ممكن يحصل في حالات الاوسجود شلاتر. الباتيلو فيمورال جوينت ده من ضمن الحاجات اللي لازم ناخد بالنا منها انها بتبقى سبب من اسباب البين، سواء في حالات الترانزيانت باتيلر ديسلوكيشن او اللاترال بريشر سندروم طبعا. ولو الباتيلا اتسلف فيها ليجن سواء زي البايبرتايت او المالتيبرتايت او الباتيلر فراكشرز. لما نيجي نتكلم على كل جزء من دوت، اول حاجه هنتكلم عليها بعد يعني التقسيمه دي ما تبقى في دماغنا، هنشوف ايه البريباتيلر برزايتس. طبعا بتبان لي عندي طبعا في اللاترال راديوجراف انا ممكن الاقي بريباتيلر سوفت تيشو شادو بروميننت قدام الباتيلا، طبعا مش طبيعي ان انا اشوفه. لما بشوف المنظر دوت بشوف الام ار بتاعه سواء بروتون دينستي بلاقي فلويد سيجنال موجود هنا، وهاي سيجنال بيبقى واضح اكتر في البي دي فاتسات. هنا دي حالة تانية لما أنا أجي أعمل هلاقي فيها مالتيليكولار فلويد انسايد ذا بريباتيلر ريجون، وممكن السونار يفرق معايا إن أنا ممكن أشخصها بكل سهولة. لو عيان جاي بيشاور على المنطقة ديت أعملها هلاقي فيه زي كوليكشن، وفي الباور دوبلر هلاقي فيه انكريزد كلر فلو. الكوادريسيبس فات باد إديما اللي هو ممكن يحصل امبنجمنت للجزء بتاع الكوادريسيبس فات. الجزء دوت بيحصل ان انا متعود ان انا اشوف هنا فات. طيب انا في البروتون دينستي شايف حاجه هاي سيجنال، اتاكد بايه؟ اعمل بروتون دينستي فات سات، وطبعا في التي 2 فات سات هلاقي ان السوبرا باتيلر فات ده مش كلير، حاصل فيه ايديما، حاصل فيه هيتروجينيتي، فده معناه ان في كوادريسيبس فات ايديما تاكسبلين البين اللي في الانتيريور اسبيكت. لو دخلت على الجزء بتاع الانفراباتيلر فات اوف باد اوف هوفا، في حاجه لوحدها اسمها الهوفا ديزيز واللوكالايزد نودولار سينوفايتس والبيجمنتد اللي احنا لسه قايلينهم. اول حاجه الهوفا ديزيز دي هتبقى في الجزئيه اللي تحت ايه الباتيلا على طول. لما الاقي الجزء دوت في البروتون دينستي في فلويد سيجنال، انا مش هبقى قادر اتاكد دوت الطبيعي ان انا الاقي هنا فات سيجنال. لكن لو لقيت هيتروجينيتي وهاي سيجنال ظهرالي في البروتون دينستي، ده معناه ان في هوفاس ديزيز اللي هي الامبنجمنت للهوفا باد اوف فات. من ضمن الحاجات اللي بتسبب الالم اللوكالايزد نودولار ساينوفايتس، واللوكالايزد نودولار ساينوفايتس دي حاجه بيناين وبتحصل في الانتيريور ني كومبارتمنت، ان انا الاقي جزء من الساينوفيوم في بروليفريشن وثيكنينج. هلاقيه برضو في البي دي في سوفت تيشو سويلنج او لوكالايزد ثيكنينج في الساينوفيوم، وهلاقي في البي دي فات سات هيدروجينس هاي سيجنال ارياز، وطبعا في التي 2 فات سات وفي الاكزل بالذات هقدر اعمل لوكاليزيشن اكتر. وبرضه من ضمن الديفرنشال دايجنوزيس ان انا اقول ان اللوس بوديز، معروف ان اللوس بوديز اكتر بتيجي في البوستيريور، ولكن هي ممكن تبقى ديتاتشد اوستيفايد تيجي لي في اي حته، فمن ضمنها انها ممكن تيجي لي في الانتيريور كومبارتمنت، وتبقى من ضمن اسباب الني بين، خاصه لو كانت كبيره وبدات تبقى اوستيفايد او كالسيفايد، ممكن الاقي بون مارو سيجنال جواها، ولما بتبقى مالتيبل ونيميروس بنسميها ساينوفيال اوستيوكوندروماتوزيس. البيجمنتد فيليونودر ساينوفايتس من احد الاسباب بتاعه الانتيريور ني بين، طبعا احنا عارفين انها دايما بتوصل لنا في حاله ان ممكن يكون الني كلها بقت الساينوفيوم حصل له التشينجز ديت، ولكن التشالنج بيبقى اكتر لما بتبقى ستيل لوكالايزد، ما بقتش لسه واخده كل اجزاء الساينوفيوم. فلما بنلاقي المنظر دوت بنلاقي زي ممكن نتخيل الاول انها ممكن لوكالايزد ساينوفايتس او نودولار ساينوفايتس، ولكن اللي بيخلينا نتاكد حاجتين: اللوس بوديز بتاعتها بتبقى لو سيجنال في كل السيكونسز. طيب ما هو ممكن الكالسيفيكيشن يبقى فيه نفس الحكايه، طيب هنتاكد ازاي؟ انا برضو لقيت اللوس بوديز هنا لو سيجنال، انا ممكن ادي كونتراست ان انا لما الاقي الجزء دوت في لوكالايزد نودولار ثيكنينج والاقي فيه هاي لو سيجنال ارياز، لما اعمل بوست كونتراست هلاقي برضو الهيموسيدرين ديبوزيشن ده حاصل جوه ليجن هو حواليه في كونتراست، عشان اقدر برضو اعرفها، لان زي ما اتفقنا ان عشان انا اكتشف البيجمنتد فيليونودر ساينوفايتس وهي لسه في الانتيريور ني بس مش بنشوفها كتير. برضو حاجات يعني ممكن يعني ايه نتفق عليها او لا، اللي هي انترا ارتيكولار كوندروما، ان انا الاقي في جزء تحت الانفرا باتيلر بادو فات كده تحت الباتيلا في جزء كالسيفايد، نقول ده لوس بودي، لا مش لوس بودي. لما اجي اعمل الام ار اي هلاقي ان هو كالسيفايد وزن ذا انتيريور اسبكت تحت الباتيلا، ولو عملت سونار هلاقي سوفت تيشو ليجن وجواه كالسيفيكيشن، وطبعا الديفرنت سيكونسز بتبينها خاصه البي دي فات سات والتي 2 فات سات. البلايكا سندروم دي بتوع الكلينيشنز وزملائنا الكلينيشنز بيهتموا بيها لما نقول ان العيان دوت عملنا له مثلا ام ار اي وهو جاي لنا بانتيريور ني بين ومش لاقيين سبب، فبرضه لازم نبقى عارفين كلمه بلايكا دي يعني ايه. هي بتبقى ليفلتس من الساينوفيوم بيحصل لها ثيكنينج، ولما بتبقى حسب اللوكاليزيشن اللي بيحصل هي في منها انواع او اماكن، في اللي هي السوبرا باتيلر وفي الميديال وفي الانفرا او اللاترال. طبعا اكتر حاجه اللي هي حوالي 90% اللي هي تبقى سوبرا باتيلر، وهي اسهل ان احنا نشوفها طبعا لو فيها افيوجن، هتبان لي زي ليفلت كده من الثيكند ساينوفيوم، ولكن بتبقى زي باند رفيعه كده. يعني احنا ممكن نشوفها ما نبقاش مركزين او نقول في افيوجن بس وما نكتبهاش، بس الكلينيشن بيهتموا بيها لان هم بيقولوا ان هي بتبقى احد الاسباب اللي هم ممكن يفسر لهم ان في بين ومش لاقيين لا منسكال كوز ولا لاقيين اي حاجه ثانيه. برضو الانفرا باتيلر ممكن الاقي حاجه كده ماشيه جنب باراليل للاي سي ال. طبعا ممكن الاقي جزء تاني ميديال بلايكا سندروم اللي هي النسبه الاقل، وطبعا اقل حاجه ممكن نشوفها خالص اللي هي الرير اللي هي الانفرا باتيلر. والانفرا باتيلر دي يعني مختلف عليها، ممكن نتفق على حاله زي كده او لا، ولكن هي كل الموضوع لما تيجي تدور في حاله الني وما تلاقيش حاجه او تلاقي ديت، ما تحاولش ان انت تنجلكت، عشان خاطر الكلينيشنز بيهتموا بيها في حالات كتير من اللي تفسر الانتيريور ني بين. طبعا الاكستنسور ميكانيزم عارفين ان هو طبعا مينلي باتيلر تندون والكوادريسيبس تندون اللي بيحصل فيهم تشينجز، سواء لو في تندونوزس او تيرز، وممكن يكون في الباتيلر تندون نفسه في جاوت، او ممكن يكون في اوسجوت شلاتر في الانسيرشن بتاع الباتيلر تندون. التندونوزس طبعا دوت هيظهر لي كاني انا شايف الباتيلر تندون وهو ثيكند، وفي البروتون دينستي طبعا بيميزني قوي ان انا الاقي فيه ابنورمال سيجنال. وطبعا اللي ياكد الكلام بتاعنا ان انا اعمل بي دي فات سات هلاقي ان في هاي سيجنال واضحه مع الثيكننج اللي باين في الباتيلر تندون، بس مش واصل ان هو يبقى عامل جاب كامل عشان اقول عليها انها ممكن تبقى تندون تير. لكن في حاله زي كده انا ممكن الاقي ان في جاب، وان في باتيلا التا الباتيلا طلعت لفوق، وان الجاب ده كبير وفيلد بفلويد، ولو عملت الترا ساوند هلاقي التو اندس باينين لي كده، فطبعا ده كومبليت تير في الباتيلر تندون. من ضمن الموضوع برضو زي ما بنقول باتيلر تندون الكوادريسبس تندون ممكن يحصل له تندينوباثي برضو بنفس الموضوع، ان انا الاقيه ثيكند وفي ابنورمال سيجنالز، واتاكد في السيجنالز دي بالبي دي فاتسات وسواء في الساجيتال او الاكزيال. ولو وصلنا لمرحله انها تبقى كومبليت تير ممكن يا اما يبقى في سمول تير زي كده او لارج تير واضح جدا الجاب اللي قدامنا. برضو من ضمن الحاجات اللي بتحصل جوه الباتيلر تندون ان يحصل جاود ديبوزيشن. الجاود ديبوزيشن ده ان انا هشوفه هتاكد من اكتر من طريقه، ان انا هلاقي التوفاي دي داخلالي جوه الباتيلر تندون نفسه، ممكن اشوفها برضو بالالترا ساوند، بس هتاكد ان هي دي ماشيالي مع الباتيلر تندون نفسه، مش مثلا في الانفرا باتيلر بادوفات او في اي حته ثانيه، بحيث ان انا اشخصها. وطبعا لازم يبقى في كلينيكال كرايتيريا ثانيه ولاب تاكد لي الكلام ده. الاوزجوت شلاتر برضو من ضمن الحاجات بتاعه الانتيريور ني بين عشان خاطر الفريجمنتيشن اللي بتحصل دي في اليانج ادلتس، وطبعا ديت بتبقى فيه تراكشن حاصل على الجزء ده بيحصل له فراجمنتيشن. طيب برضو ممكن اشوفه واتاكد والاقي ايه الابنورمال سيجنال، والاقي الابنورمال بوني بروجيكشنز اللي حاصله هنا، وواضح قوي في التي 2 فات سات في الاكزيال، وباين جدا الفراجمنتيشن سواء في البروتون دينستي العادي او في البي دي فات سات. لو اتكلمت عن الباتيلر مار الاينمنت ده من ضمن الحاجات المهمه اللي هي يا اما ترانزينت باتيلر ديسلوكيشن او اكسسيف لاترال بريشر سندروم. الترانزينت باتيلر ديسلوكيشن دي حاجه بتحصل ان زي امبنجمنت كده من الباتيلا، نتيجه ان هي بتبقى فيها حاجه مخليه الحركه بتاعتها زياده عن الطبيعي، فالبيشنت دوت بيحصل له زي امبنجمنت من الباتيلا في الميديال اسبكت بتاعها، نتيجه ان الميديال ريتيناكولم بيحصل له ثيكننج وانفلاميشن، واللاترال ريتيناكولم بيبقى سكند وجامد، فده بيخلي الباتيلا تطلع كده وتيجي تاني وتحصل لها امبنجنت مع اللاترال فيمورال كوندايل. طبعا من ضمن المانجمنت بتاعها ان هو يشيل الميديال ريتيناكولم اللي حصل له الرياكشن ده، بيعمل له ريليس عشان خاطر البين ده يروح. اللاترال بريشن سندروم العكس بقى، ان انا الاقي اللاترال ريتيناكولم هو اللي ثيكند والباتيلا كل شويه عماله تتحرك وتحصل لها امبنجمنت للكوندايل بتاع الفيمر، وطبعا نتيجه كده هيحصل هايلاين كارتليج انجري، هيحصل اوستيوارثريتيك تشينجز، ولو الحاله دي نجلكتد واتثابت هيحصل سكندري اوستيوارثرايتس، ممكن العيان ما يستفيدش من اي مانجمنت يتعمل. يعني دي حاله انا جايبها من، طبعا مش انا اللي عاملها، كانت في الاول ممكن تتلحق، يعني لسه يا دوب في شويه سيكننج واضح في اللاترال ريتيناكولم، ولسه في تشينجز حاصله في الهايلاين كارتليج نتيجه الحركه اللي بتحصل ليها، ولكن لما بقت اكسسيف كومبريشن بيحصل لوس اوف هايلاين كارتليج وسكندري اوستيوارثريتيك تشينجز، وادي البون مارو اديما تشينجز. من ضمن الايشوز اللي ممكن نهتم بيها برضو الكوندروماليشيا باتيلا. الكوندروماليشيا باتيلا ده طبعا هو عباره عن ديجنريشن بيحصل في الهايلاين كارتريج اللي في الباتيلا هنا، طبعا نتيجه كده بيحصل فريكشن. طبعا هي جريدز، ممكن من اول يدوب كراك لو واصل عندكم يعني الصوره واضحه، كراك بسيط كده نقول جريد 1، او ان انا الاقي جريد 2 الاقي فيه السريشن وفي فرينج هنا كده irregularities، ممكن الاقي ديفكتات كبيره شويه ورياكتيف بون تشينجز بدات تظهر في جريد 3، ولو جريد 4 هلاقي البون تشينجز بقت اكتر، واب تو ان انا ممكن الوس الهايلاين كارتريج كله. هنا ممكن الاقي جريد 1 صوره واضحه اكتر للكراكس اللي موجوده هنا، وبنشوفها برضو في الساجيتال بوضوح. لكن لو انا سبت، يعني لو الحاله بقت ادفانسد هلاقي البون نفسه كمان بقى افكتد، والهايلاين كارتريج بقى هيتروجينس، او البون بقى هيتروجينس سيجنال انتنسيتيز. وبرضه بنحاول ناكد ان الهايلاين كارتريج اسسمنت يعني بنهتم بالسيكونس اللي هو الماجنتيزيشن ترانسفير. يعني انا عايز اكد ان احنا لو عارفين ان احنا بنعمل حاله هايلاين كارتريج انجري نحاول نعمل لها السيكونس بتاع الماجنتيزيشن ترانسفير. اخر حاجه هنتكلم عليها الباتيلر ابتنوماتيز نفسها. هي الباتيلا يكون فيها بايبرتايد باتيلا، ممكن يكون فيها انها مقسومه. طيب اعرفها ازاي انها مش فراكشر مثلا؟ طبعا البايبرتايد بتبقى مقسومه وتحس ان في كأن في جوينت، في سكليروزس في الجنبين. طيب نعمل MRI هنلاقي زي امبنجمنت حاصل للاجزاء ديت. لو في ساعتها اعرف ان ده سبب البين. هي طول ما هي بايبرتايت عاديه مفيش مشكله. اول ما يحصل ان الجزئين دول يحصل سودو ارثروزس هنلاقي نارو كأن في جوينت سبيس وبقى نارود، وبقى في بون مارو تشينجز على البوث سايدز بتاع الجوينت بتاع السودو ارثروزس دوت، وبيبقى واضح في اكتر من فيو زي ما احنا شايفين. المالتي بارتايت هي نفس الفكره، وبنشوفها في الاكس راي انها مالتيبل بيسز في للباتيلا نفسها. وبشوف نفس الكلام امتى توصل لمرحله البين، انها تكون عملت سودو ارثروزس وبينفول كونديشن. طبعا باتيلر فراكشر طبعا احنا عارفين ان الترانسفيرس فراكشر بيبقى اكتر، طبعا بيبقى زي اليوسنت لاين، ما يبقاش زي فكره البايبرتايت، لان ممكن واحد يبقى لسه يعني جونيور ستاف يتلخبط فيها. فدي امثله لاكثر من شكل للباتيلر فراكشرز، والفراجمنتس وهي منفصله عن بعضها سواء كومينيوتد أو لكن هنلاحظ فيهم كلهم ان دايما الفراكشر بيبقى ليوسنت لاين. ممكن ناكد بالسي تي ونشوف الفراكشر سايت واضح جدا، او نوضح حاجه زي الايه الهيموارثروزس والتشينجز اللي بتحصل للجزء القداماني دوت. انا طبعا حبيت ان انا اقول يعني المحاضره في اقل وقت ممكن، او ظبطت الميعاد قعدت اتدرب عليها عشان ما نعملش زي المره اللي فاتت، وحاولت ان احنا نتكلم اوف كلينيكال بوينت اوف فيو. انا عملت ريفيجن للمحاضره بتاعتي دي مع حد من زمايلي اساتذه العظام عشان احاول ان انا اربط الكلينيكال ايميجنج بالشغل بتاعنا. متشكر جدا.
Our next speaker, Dr. Ahmed Rida, Suez Canal University, talk about evaluation of posterolateral corner injuries of the knee.
MRI evaluation of posterolateral corner injuries of the knee. أنا أحمد رضا مدرس أشعة في جامعة قناة السويس. The posterolateral corner is called the dark side of the knee. It has a complex and variable anatomy, interrelated static and dynamic stabilization. Many structures are out of plane on standard MRI sequences. It often bridesmaid to ACL and BCL injuries, so we don't give much attention to this kind of injuries. As we said, it has a complex anatomy. The energy happened due to high energy forces like in sport, in traffic accidents, in falls and dislocations. The mechanism either direct or indirect, in varus, hyperextension, external rotation, usually combined injury rather than isolated injuries. The most common known injury is the second fracture, which is easily appreciated here in X-ray rather than in MRI. Missed injuries usually put more stress in ACL graft, so result in more incidents of graft failure, as Labrad stated in 1999. Also, it have more load on patellofemoral joint, which accelerates osteoarthritis, like Skyhar stated in 1993. Also, it associated with common peroneal nerve injury in 30% of cases, instability in knee extension, and difficulty with going upstairs. The anatomy, we said it's complex. We have main structures like lateral collateral ligament complex, the popliteus tendon and muscle, and the capsule supporting structures. We will mention them later. First, the lateral collateral ligament complex. It has iliotibial band, the fibular collateral ligament, or the main lateral collateral ligament, and biceps femoris tendon. Again, with anatomy. Here's the lateral collateral ligament in green, then the biceps femoris and popliteus muscle and the tendon, the popliteofibular ligament, the fibullofibular ligament, the arcuate ligament. So the main function of the lateral collateral space is to prevent the external rotation, varus angulation, posterior translation. It also provides secondary stabilizer for internal rotation in ACL deficient knees. عشان كده احنا قلنا مهم في الموضوع الناس اللي عندهم ACL graft failure ممكن يسبب ACL graft failure لان هو بيعمل stabilization اكتر. Again with anatomy بس المره دي مع صور MRI. The far lateral images بنشوف في الساجيتال images البايسبس فيمورس واللاترال كولاترال ليجامنت وبيكون ليهم باني اير ابييرنس. بعد كده البوبليتياس ماسل اند تندون، والبوبليتياس هي الويندو تو ذا بوسترولاترال كورنر. وهنا برضو بنشوف البوبليتو فيبولار ليجامنت اللي هو بياتاتش للبوبليتياس تندون. and the popliteomeniskial fascicles ودول ماسكين في البوستيريور هورن او في اللاترال في البوستيريور لاترال منسكس. والاركوت ليجامنت، والاركوت ليجامنت ده بيكون ديب للجينيكولوت بلاد فيزلز عكس الفابيلو فيبولار ليجامنت وده بيكون سوبرفيشال للجينيكولوت بلاد فيزلز. البوبليتياس تندون بنفولو الكورس بتاعه انترا اند اكسترا ارتيكولار عشان نلوكيت اذر ستراكشرز لايك الفابيلو فيبولار، بوبليتيو فيبولار والاركوت ليجامنتس، كل دول بنشوفهم مع الكورس بتاع البوبليتياس تندون. البوبليتيو فيبولار ليجامنت بنشوفه في الساجيتال والكورونال MRI بارتيكولارلي لما بيكون في فيوجن. هو موجود في 90 ل 100% من الدايسكتد نيز، انما عشان نشوفه في الMRI بيكون فاريبل، مش دايما بنشوف الMRI. هنتكلم على شويه انواع من الانجريز. اول حاجه هنتكلم عنه اللاترال كولاترال ليجامنت تير. علشان نشوف تير اول حاجه بتاخد عينينا الاديمه. اول ما بنشوف اديمه بنبتدي نشوف الكورس بتاع اللاترال كولاترال ليجامنت، بنلاقيه ويفي، بنلاقي فيه ديسكونتينيوتي في الفايبرز. زي هنا لو شفنا هنا في اديمه كبيره قوي، الاديمه ديت لو ما حصلهاش كوريكشن ايرلي ممكن تسيب سكار بعد كده. البروكسيمال انجريز في اللاترال كولاترال ليجمنت بتكون دايما اسوشيتد او كتير اسوشيتد مع البوبليتياس تندون افالجن. اما الديستال انجريز في اللاترال كولاترال ليجمنت بتكون اسوشيتد مع البايسبس فيمورس افالجن. لايك ان ذيس كيس في بايسبس فيمورس افالجن وكمان في ريتراكشن اسوشيتد مع الديستال لاترال كولاترال ليجمنت انجري. نوع تاني من الانجريز اللي بتحصل في البوسترولاترال كورنر الاركوت ساين. الاركوت ساين كان الاول اتوصفت على انها سمول بارت اوف ذا بروكسيمال فيبولا او البروكسيمال فيبولا اللي هو الفيبولار ستايلويد بروسيس. ده مكان الاتاتشمنت بتاع الفابيلو فيبولار والاركوت ليجامنتس او البوبليتيو فيبولار. اما النيو ساين الاركوت ساين اتوصفت ان هي اخده جزء اكبر من البروكسيمال فيبولا. ولي إيتال in 2003 say it's all good, either the small sign or the large sign. The small sign or the original sign we see here small flake-like bony avulsion من البروكسيمال فيبولا، واخد معاه برضو انجري للبوبليتيو فيبولار ليجامنت والفيبولو فيبولار والاركوت ليجامنت، وده بيكون اسوشيتد دايما مع البي سي ال انجري. اما الفار لاترال ستراكشرز زي البايسبس فيمورس واللاترال كولاترال ليجامنت ما بيكونش فيهم انجري، بيكونوا يوجوالي انتكت. الكومن يوز ساين اللي هي النيو ساين اللي هي اخده جزء اكبر من البروكسيمال فيبولا، بيبقى اخده الفيبولار هيد كلها تقريبا وبتكون ريتراكتد بروكسيمالي زي اللي انا شايفه هنا في الاكس راي وكمان في الMRI، وبيكون معاها دايما مور سيريس انجريز بتاخد اللاترال كولاترال ليجمنت، بتاخد البايسبس فيمورس، كمان بيكون معاها اسوشيتد انجريز في الاي سي ال في البي سي ال في البوبليتياس تندون. Don't be fooled with biceps tear retraction. مش لازم يكون في retraction عشان اقول في biceps femoris injury. يعني هنا مثلا التندون بتاع البايسبس ما فيهوش retraction خالص، ولما ابص على الانسيرشن بتاعه بلاقيه ان هو almost totally stripped from the fibular head. يبقى هنا في avulsion fraction في البايسبس تندون ومش لازم يكون في retraction. البوبليتياس ماسل اند تندون لو بصينا في الحاله ديت ده نوع تاني من الانجري. لو بصينا على البوبليتاس ماسل هنلاقيها فيها significant edema. هنبص ان في انجري كمان في المايوتندينيوس جونكشن. لو فولو الكورس بتاعها مور لحد الانسيرشن بتاعها في اللاترال فيبولار كوندايل هنلاقي في افالجن فراكشن في التندون انسيرشن بتاع البوبليتاس تندون. زي ما قلنا ان هي ويندو للبوسترولاترال كورنر، بنلوكيت الاذر ستراكشرز اول ما بنشوف في اديما او في افالجن انجري في البوبليتياس تندون، بنشوف الاذر ستراكشر زي البوبليتيو فيبولار زي الاركوت وغيرهم. من ال other supporting structures اللي هي المينيسكال بوبليتيال فاسيكلز، وزي ما قلنا ان هي ما بين البوستيريور lateral meniscus والبوبليتياس تندون، هم بيبقوا minor stabilizer superior وانفيريور لللاترال meniscus. زي الحاله ديت في associated injury في الانفيريور menisco popliteal fascicles ومعاها برضو بوبليتياس injury، بس برضو في الحاله ديت احنا شايفين ان في injury في المينيسكس في البوستير هورن لاترال meniscus. برضو هنا في البوبليتيوفوبيولار ليجامنت تير، ده برضو كايند او نوع تاني من البوسترولاترال انجريز. ولما بنشوفه دايما بنبص على الاديمه ونشوف التير بتاع البوبليتياس تندون، لازم نبص على البروكسيمال فيبيولا لان ساعات بيكون معاها بروكسيمال فيبيولار فراكشرز، زي هنا في الفيبيولار هيد فيها بروكسيمال فراكشر. الفراكشر ده اللي احنا قلنا عليه قبل كده اللي هو الاركوت ساين. نوع تاني من الانجريز في البوسترولاترال كورنر، البيشنت دوت واضح ان فيه سيجنيفيكانت اديما واللاترال كولاترال ليجامنت مقطوع، بس البيشنت دوت عنده اولترد سنسيشن في الدورسم بتاع الفود ويك دورس فليكشن في الانكل. لما بصينا على الصور بتاعته في الاكزيال ايمجز دوت الكومن بيرونيان نيرف بينقسم بعد كده لسوبرفيشال وديب، والكومن بيرونيان نيرف شايفين ان هو ستريتشد بنفولو الكورس بتاعه دوت. الاناتومي بتاعه واضح ان هو فيري كلوز تو ذا بوسترولاترال كورنر وكمان للفيبيولار هيد، ده الكورس بتاع الكومن بيرونيال نيرف. وجوده في المكان دوت بيزود احتماليه ان ممكن يكون في ستريتشنج انجري، ممكن يكون في اديمه حواليه. زي هنا في فيبيولار فراكشر او بروكسيمال فيبيولار فراكشر عند النك بتاعه الفيبيولا، شايفين جنبها على طول الكومن بيرونيال نيرف، والكومن بيرونيال نيرف سراوندد باي سيجنيفيكانت اديمه. سيجوند فراكشر زي ما قلنا قبل كده ان هو من اشهر انواع الفراكشرز بتحصل هنا او الانجريز اللي احنا عارفينها في البوسترولاترال كورنر اللي بتكون اسوشيتد طبعا مع الاي سي ال تير. هنا لو بصينا هنلاقي في ستريبنج لبوني سيجمنت من اللاترال تيبيال بلاتو، ولو بصينا عليها في الاكس راي بتبان معانا. فبيلر فراكشر ده اخر كايند اوف او تايب اوف انجريز بتحصل في البوسترولاترال كورنر هنتكلم عنها. دوت انا ما اعرفش السيجنيفيكانس بتاعته، بس واضح ان في فراكشر في الفابيلا هنا. الكيسز بقى هنتكلم شويه كيسز بسيطه. اول كيس فوتبول بلاير وسب اكيوت اي سي ال تير، في هنا بوبليتيوفيبولار ليجامنت تير، وطبعا اول حاجه بصينا ليها الاديمه. كيس نمبر 2 في اي سي ال تير واضح جدا لما نبص على اللاترال بوستيرولاترال كورنر في ميد سبستانس اور ويفي كورس اوف ذا لاترال كولاترال ليجامنت وفي ديسكونتينيوتي، فده فول سيكنس تير، ده جريد 3 تير. كيس نمبر 3 في posterior cruciate ligament injury associated with distal lateral collateral ligament tear و significant edema. لما مشينا معاها برضو في البوبليتيوفيبولار تير. كيس نمبر 4 بوبليتياس ماسل significant edema وإديما at the posterior lateral corner. لما مشينا معاها أكتر بصينا لقينا في البوبليتياس تندون في تير واللاترال كولاترال ليجمنت وكمان الإليوتيبيال باند شكلها مقطوع. لو مشينا مع العيان ده برضو من الانجري اللي حاصله في بروزز في الميديال فيمورال كوندايل وكمان الميديال كولاترال ليجمنت. كيس نمبر 5 فوتبول بلاير وفي هنا انجري للبوبليتيال فوسا وكمان في سكار. لما عملنا الام ار اي ساجيتال ام ار اي في سيجنيفيكانت ايديما وفي ايرفوساي. البوسترولاترال كورنر هنا ما فيهوش اديما سيجنيفيكانت، بس نير السايد بتاع اللاسيريشن او السيرجيكال لاسيريشن شايفين اديما حوالين الكومن بيرونيان نيرف. لما بصينا عليها في الساجيتال لقينا الكومن بيرونيان نيرف دوت لقيناه ستريتشد قوي، وفي السيرجري بصينا عليه برضو لقينا الستريتشنج انجري اللي احنا قلنا عليها وحصل فيه سيننج، فده بيكونفيرم الدايجنوز بتاعنا ان في كومن بيرونيان نيرف انجري. هنا كيس نمبر 6 فول سيكنس تير في الاي سي ال وفي اديما في البوسترولاترال كورنر. بنبص برضو على الكومن بيرونيان نيرف بنلاقي حواليه اديما، فده بياكد ان في انجري في الكومن بيرونيان نيرف. طبعا الايرلي دايجنوزز بيمبروف الكلينيكال اوت كام بتاع السيرجري ده، والسيرجري عملناها في اول 3 اسابيع. الارثروسكوبي بقى لما بنيجي نعمله ما بيجيبش كل التايبس بتاع اللاترال كولاترال كورنر انجريز. also it may worsen الكابسولار دامج في الاكيوت فيز لان بيكون فيه فلويد اكسترافازيشن. في جريدنج كتيره معموله، هو يمكن اشهر واحد فيهم اللي هو الكلينيكال جريدنج على حسب الفيروس اوبننج اقل من 5 مللي من 5 ل 10 اكتر من 10 مللي ده جريد 3. جريد 3 بيحتاج اكيوت ريبير، اما جريد 1 و 2 ممكن يتعمل له كونزرفاتيف مانجمنت. التيك هوم بوينت احنا بنبص على اول حاجه على الميكانيزم اوف انجري. لما بيكون في كروشيت نيرف انجري بيكون في ايديما في البوسترولاترال كورنر. بنلوك فور انتجريتي اوف مين ستراكشرز. اهم ستراكشرز او مين ستراكشرز عندنا الاليوتيبيال باند، اللاترال كولاترال ليجامنت، البوبليتياس، البايسبس فيمورس. لوك فور انتجريتي اوف كابسولار سبورتنج ستراكشرز زي البوبليتيو فيبولار ليجامنت، المينيسكو بوبليتيال فاسيكلز، الاركويت. طبعا الاديمه لوحدها ما بتشخص بوسترولاترال كورنر انجري، لان ممكن يحصل اديمه في البوسترولاترال كورنر مع البايفوت شيفت ميكانيزم. المين ستراكشر ديسربشن لازم نقولها بالتفصيل، اما الكابسولار ستراكشرز هنقول المهم فيهم. شكرا.
Thank you, Dr. Ahmed, for this nice presentation. And we will shift to the other next presentation, Dr. Hazem Abouzeid from Asyut University. He will present for us the other side of the knee problem, the posteromedial knee coronary injury. Dr. Hazem.
السلام عليكم ورحمة الله وبركاته. أحب طبعا أشكر اللجنة المنظمة واللجنة العلمية للجمعية. أشكر زملائي المتحدثين السابقين، وطبعا التوبيك بتاع الني انجريز 5 أو 6 سيشنز مش هيبقوا كافيين، لكن الدكتور خالد حاول إن هو يغطي hidden areas في التروماتيك ني انجري. الجزء اللي هتكلم عنه اللي هو posteromedial knee corner injury. It's a frequently overlooked injury، وهنقول هو overlooked ويعني relatively recently discovered its significance. البوسترولاترال injury، البوسترولاترال corner injury كان واخد المين اتنشن في الني انجري، وكان الميديال انجري mainly attributed to tibial collateral ligament injury او medial collateral ligament injury. later الكلينيشنز لقوا ان في difference في البروجنوزس between individual patients with medial collateral ligament injury. This draw attention to the posteromedial knee corner mechanism. Posteromedial corner of the knee is an important anatomic structure that is often overlooked. It is often overlooked because other injuries may dominate the clinical picture and may mask injuries to the posteromedial corner. Most common cause of mechanism of injury is sport injuries. Anatomy of the posteromedial corner. احنا الميديال كومبارتمنت بتاع الني بنقسمها ل 3 parts: anterior, middle and posterior. الميديال كولاترال ليجامنت هو اللي بيديفاين الانتيريور كومبارتمنت، الانتيريور ثيرد من البوستيريور ثيرد او من البوسترو ميديال كورنر. البوسترو ميديال كورنر بيتكون من 5 main structures. It is highlighted by the white line. These are the structures of the posteromedial corner of the knee. The arrow shows the semimembranous tendon. Semimembranous tendon is a key structure in the posteromedial corner of the knee and is an important structure to search for its injury. Posteromedial corner has 5 major components: the semimembranous tendon and its expansions, the oblique popliteal ligament, the posterior oblique ligament, the posteromedial joint capsule, and the posterior horn of the medial meniscus. This MRI, axial fat suppression MRI at the level of the meniscus, show the structures of the posteromedial compartment. As we see, this is the superficial part of the medial collateral ligament in blue, the deep part of the medial collateral ligament. The red highlights the posterior oblique ligament, which is considered as a continuation of the superficial part of the medial collateral ligament. The gray line shows the posteromedial joint capsule. The white line shows the posterior oblique popliteal ligament, OPL, and the yellow highlights the different divisions of the semimembranosus tendon, the descending arm, the capsular arm, and the anterior arm. In these coronal images, we see the arrows showing the medial collateral ligament. More posteriorly, as we go posteriorly, we see the posterior oblique ligament, which is a continuation of the superficial part of the medial collateral ligament. Passing more posterior, we can see the posterior oblique ligament and its meniscal attachment. We see here the semimembranosus tendon, anterior arm. Passing more posterior, we see the posterior oblique ligament and the semimembranosus tendon. In sagittal images from medial to lateral, we see the anterior arm of the semimembranosus tendon and its descending arm, the posterior oblique ligament in close relation to the posterior horn of the medial meniscus, and near the popliteal fossa we see the oblique popliteal ligament. Another MRI showing the oblique popliteal ligament. In coronal image, we see the oblique popliteal ligament as a transverse or obliquely oriented band posterior to the joint. The medial meniscus, the posterior horn of the medial meniscus, and the meniscotibial attachment, which is a key structure in the stability of the posterior medial joint compartment, and the posterior horn of the medial and its medial attachment and its intercondylar attachment or root attachment. Here we see the semimembranosus tendon and its meniscal arm. The posteromedial corner is a musculoligamentous unit of central importance to the dynamic stability of the medial knee. احنا عندنا الني ليها dynamic stabilizer وليها static stabilizer. الديناميك stabilizer اللي هم during flexion and extension help to stabilize the knee to prevent overextension or overflexion. The semimembranosus muscle acts as a dynamic restraint to the valgus of the knee when the knee is extended. It assists the break stop function of the medial meniscus, where the meniscal horn acts as a secondary restraint to the anterior tibial translation. الدياجرام ده عشان نشوف البريك ستوب ميكانيزم بتاع البوستيريور هورن اوف ذا ميديال منسكس. زي ما احنا شايفين ده المنسكال ارم بتاع السيميمبرنوزاس تندون helps to stabilize the posterior horn of medial meniscus to prevent over movement of the tibia or tibial translation. When this attachment is lost, tibial translation can occur. Injury of the posterior medial corner or medial side knee injury. احنا قلنا ان what draw attention to posterior medial compartment or posterior medial corner injury is the difference between individual patients with medial collateral ligament injury. في medial collateral ligament injury can pass conservatively, and other patients will develop what we called anteromedial rotatory instability or AMRI of the knee. العيان بيشتكي من giving way without other causative injury. لما الحالات دي بقت studied على يعني اول study كانت معموله في اوائل التسعينات كانت على البوستيرو لاترال كورنر found ان البوستر ميديال كورنر انجري هي اللي ريسبونسبل عن الانتروميديال روتاتوري انستابيليتي. عشان كده العيان اللي فيه ميديال تيبيال كولاترال ليجامنت انجري كان be managed conservatively, but when it is associated with other injury of the posterior medial corner, it is unlikely to respond to conservative treatment. Types of posterior medial corner injury زي ما قلنا الستراكشرز المين الانجريز ممكن تبقى في اي حاجه من دول. يعني ممكن البوستيرو اوبليك ليجامنت يبقى فيه انجري، ممكن المنسكو كابسولار انجري او الماسكولو تندينوس انجري في السيمي برونوزس انسيرشن. اكزامبلز للبوستيرو اوبليك ليجامنت انجريز. البوستيرو اوبليك ليجامنت انجريز ما لهمش فورمال كلاسيفيكيشن، لكن ممكن نعتبر الكلاسيفيكيشن بتاع الميديال كولاترال ليجامنت لان هو البوستيرو اوبليك ليجامنت بارت من الميديال كولاترال ليجامنت. ممكن نعتبر الكلاسيفيكيشن سيستم بتاع الميديال كولاترال ليجامنت applies for posterior oblique ligament injury. Type 1 injury بنشوف الليجامنت intact but edema of the surrounding soft tissues in fat suppression images indicating microscopic or grade 1 tear. When it is associated with abnormal increased signal intensity within the ligament, this indicates grade 2 injury, and it is also associated with edema of the surrounding soft tissue but no disruption of the continuity of the ligaments. In grade 3 tear, complete disruption of the posterior oblique ligament that is replaced by fluid indicates grade 3 injury. Meniscocapsular injuries, MRI can demonstrate the injury of the femoral and tibial meniscal attachment and disruption or thickening of the ligaments with or without associated marrow edema at the ligament insertion. Examples of meniscocapsular injuries. In this coronal proton density weighted MRI, we see the femoral attachment. The meniscofemoral ligament is intact while the meniscotibial ligament is disrupted here. Another example, the curved arrow shows the abnormal thickening of the posterior medial joint capsule associated with edema signal. Again, in sagittal image we see fluid interposed between the posterior horn of the medial meniscus and the joint capsule and the joint effusion, which indicates meniscocapsular injury. Musculotendinous injury. Injuries of the semimembranosus insertion can involve any of the arms of the semimembranosus tendon. The most important arms to search for are the capsular arm, the anterior arm, the descending arm are the main three arms to search for. Damage to the semimembranosus insertion is occurring in up to 70% of posterior medial knee injuries. It may be associated with fracture line in the medial tibial condyle, as we see here. In this axial image, complete absence of the semimembranosus tendon at its expected site indicates complete tear of the semimembranosus tendon. In this sagittal fat suppressed proton density weighted images, we see abnormal signal of the anterior arm and of the descending arm of the tibial insertions of the semimembranosus tendon. In this sagittal image, abnormal edema and thickening of the posterior joint capsule indicates capsular injury and also meniscocapsular separation. In this sagittal image, complete absence of the anterior arm of the semimembranosus tendon indicates complete tear. Take-home messages on MR reading: the posterior medial corner should be marked with the posterior oblique ligament, the oblique popliteal ligament, posterior medial capsule, posterior horn, medial meniscus, and distal semimembranous tendon. لازم الفايف structures دول يبقوا stressed upon, especially if other injury is evident, particularly for medial compartment, medial collateral ligament. زي ما قلنا الميديال collateral ligament if isolated can pass conservatively, but if it is associated with other injuries of the posterior medial corner, it should be treated surgically. When posterior medial corner injury occurs as a concomitant injury, it frequently leads to anteromedial rotatory instability. Thus, it is of therapeutic and prognostic relevance for the patient. Thank you.
يعني you need a closed machine at least 1.5 or 3 Tesla.
1.5 is sufficient. Most important, utilization of fast suppression sequences and 3D sequences if isotropic can help to obtain isotropic images in the 3 plane in one acquisition. And it also helps to different, يعني لو أنا شاك مثلا عندي 3D image أقدر أconfirm الانجري in the 3 planes in one sequence.
These are the structures you used to call the posterior joint capsule, but we are splitting now into, which are actually focal areas of capsular thickening. Some of them are intra-articular, except the posterior popliteal tendon هو extra capsular.
Extra capsular.
Yes. Thank you.
شكرا.
شكرا دكتور حازم على المحاضرة الجميلة، وبنشكرك على حضور مجامعة أسيوط. طبعا متشكرك جدا على المسافة. نيكست سبيكر صديقي العزيز دكتور سامح خضير، بون مارو تشينجز ان بينفول ني MR ايفالويشن.
بسم الله الرحمن الرحيم. Thank you, Chairman and presence. And I would like to thank the Egyptian Society of Radiology for kind invitation. Today I would like to talk about bone marrow changes in painful knee and MRI evaluation. With its ability to visualize bone, cartilage, and soft tissue, MRI is a method of choice for assessment of acute and chronic joint disorders. Bone marrow edema-like signal alternation exhibits typical signal characteristic on MRI and are common. MRI is ideal tool to assess this pathology as bone marrow cannot be visualized by X-ray or ultrasound. Other imaging modalities reflecting bone metabolism will show only increase in tracer but will not help in differential diagnosis as they are not specific. On MRI, subchondral bone marrow signal alternations are characterized by ill-defined low signal intensity compared with the unaffected bone marrow on T1 weighted, while are high signal on T2 proton density and stere weighted images, and presents as high signals. Subchondral bone marrow signal alternation may be observed in conjunction with trauma, chronic cartilage damage, osteoarthritis, as an idiopathic entity as or as a concomitant feature or other pathologies such as osteonecrosis, inflammation, or tumor. The term bone marrow edema was first introduced to the radiological community. Histologically, non-characteristic abnormalities are found in areas of edema-like signal changes in these disorders. These include bone marrow necrosis, bone marrow fibrosis, trabecular abnormalities, but very little bone edema. Thus, the term bone marrow edema is not appropriate. In recent years, the more general term used is bone marrow lesion has become standard usage. Classification of bone marrow lesions according to the cause into ischemic, mechanical, reactive has been suggested. However, As the pathophysiology is at best poorly understood for many of the lesions, it is believed such differentiation might be misleading, especially for osteochondritis dissecans, spontaneous osteonecrosis of the knee, and idiopathic transient bone marrow lesion syndrome. Possible combination of ischemic and microtraumatic etiology are current theories. For these reasons, classification into traumatic and non-traumatic is more easier and more better also. Traumatic bone marrow lesions include bone marrow contusion or bruises, subchondral impaction could be associated with, osteochondral fracture, insufficiency stress fracture, repetitive overuse microfracture. While non-traumatic bone marrow lesions include avascular necrosis or infarction, osteochondritis dissecans, spontaneous osteonecrosis of the knee, or known as SONG, osteoarthritis, idiopathic transient bone marrow edema syndrome, also in case of inflammatory tumor and post-surgical. On analysis of bone marrow lesions on MRI, the radiologist must consider some points to differentiate these bone marrow lesions, as the management of these bone marrow lesion will be different according to the case. So, on analysis, the radiologist must consider patient demographic, included the age and sex, clinical presentation, either the pain is acute or chronic, history of trauma is very important, and MR features, which include the location and the extent of the bone marrow lesions, the presence of fracture line, subchondral bone plate and its integrity, also the cartilage and its integrity, and associated other ligamentous or meniscal injuries. According to the bone marrow contusion, regarding to the age and sex, no age prominence or incidence. However, the younger or young patients are more active and more liable for trauma. So they are present in younger patients. Also, the present with acute pain, history of trauma must be present, and MR features of bone marrow contusion, we considered it as a footprint or pathognomonic for some ligamentous and meniscal tear. So, as is in case, we see bone marrow lesions according to location, it present as the medial femoral condyle. Also, bone marrow lesion here present as high signal in the posterolateral aspect of the tibia. This is pathognomonic contusion in ACL tear. We also must be looking for the presence of fracture line, no fracture line. Also checking for the subchondral bone plate. The subchondral bone plate has normal thickness. Also the integrity of cartilage is normal, and associated ligamentous or meniscal tear, as we said that this lesions is typical for ACL tear. In other case with ACL tear, we see here another sign, which is subchondral plate impaction at the lateral femoral condyle, which is making a sulcus sign. This sulcus sign is pathognomonic for ACL tear. Other case of bone marrow lesion, which is considered bone marrow contusion or bruises. Here the bone marrow lesions is present as the lateral femoral condyle at the anterior aspect of the lateral tibia. So it is considered to be due to trauma of hyperextension and associated posterior cruciate ligament tear is highly considered. When we check the subchondral plate, we will see impaction of the subchondral plate and the cartilage is intact. This is another case of bone marrow contusion. Also occurs in transient patellar dislocation. Typical location of bone marrow lesions are present at the anterior of the lateral femoral condyle and also at the medial facet of the patella. This is a footprint for transient patellar dislocation, which occurs usually in adolescent and young patients. This is another case of bone marrow contusion associated with ACL tear, typically present at the lateral femoral condyle and posterior lateral aspect of the tibia, associated with subchondral fracture line. The subchondral plate is intact, also the cartilage is normal. Also another example for bone marrow contusion present as high signal associated with subchondral fracture line present as low signal intensity while the subchondral plate is intact as well as the articular cartilage is intact. This is another example for bone marrow contusion associated with subchondral fracture. Also the subchondral plate here is impacted, including also the cartilage which is formed finally osteochondral fracture associated with posterior cruciate ligament tear. In cases of insufficiency stress fracture, age is usually in all patients more than 50 years, presented by chronic pain, usually haven't no history of trauma, but usually have history of osteoporosis. In MRI features, it's usually located at the weight-bearing area at the medial femoral condyle, present as has high signals associated with subchondral fracture line. However, the subchondral plate here is normal as well as the articular cartilage is intact with normal thickness. In repetitive overuse microfractures, this usually occurs in young adult making sports and overuse, as especially in runners, in marathons. The clinical presentation usually chronic pain, not acute, no history of trauma. MR features usually occurs at the site of repetitive microfracture. So we see here abnormal high signal of bone marrow in subchondral situation. We note also the subchondral plate is normal as well as the chondral thickness is normal with no associated ligamentous or meniscal injuries. Regarding to the non-traumatic bone marrow lesions, the first entity is avascular necrosis. Avascular necrosis usually occurs in young and middle age. This patient usually has some history of alcoholism, history of bone or history of blood diseases that may, as sickle cell anemia, that may lead to microembolism. The clinical presentation present with acute pain, no history of trauma. In MRI, we will find abnormal area, high signal area of high signals with two line or double line sign. This line, hyposignal line, presents the line separating the vital bone marrow from non-vital bone marrow, while the high signal, another line, is the granulation line. We can observe here also the line is reaching to the articular surface or chondral plate, but the subchondral plate here is intact. Also the articular cartilage also is intact. In osteochondritis dissecans, this occurs usually in young and middle age, presented with chronic pain, which will be worse more and more when the condition be chronic. No history of trauma. When assessing by MRI, we will find abnormal high signal of bone marrow with a line reaching to the articular surface. The subchondral plate is discontinued, as well as including discontinuity of the articular cartilage. This osteochondritis dissecans. We can differentiate here between the avascular necrosis and osteochondritis dissecans, as they are similar. But here the line reaching to the articular surface, we observe here the subchondral line is intact, as well as the articular cartilage. But here the line reaching to the articular surface with disruption of the subchondral plate, as well as disruption of the articular cartilage. In cases of spontaneous osteonecrosis of the knee, the age is important and also sex, as it usually occurs in female patients older than 50 years, presented with acute onset of pain, especially at night, no history of trauma at all, and in MRI, it is typical as the weight-bearing area, so abnormal signals including the medial femoral condyle. We notice also the subchondral plate is abnormally thickened due to subchondral bone impaction, which increase the thickness of the low signal line beneath the articular cartilage. Another case of spontaneous osteonecrosis of the knee, abnormal high signals with thickened subchondral plate, and this is the subsequent prognosis of the spontaneous osteonecrosis of the knee, leading to osteochondral defect. Osteoarthritis, we notice the change in the bone marrow at the weight-bearing area, occurs in both sides on the femur and tibia, has no characteristic features. The subchondral plate is intact with presence of chondral defect in osteoarthritis, and other features of osteoarthritis is peripheral osteophytes. In idiopathic transient bone marrow edema, it looks like the sunk or spontaneous osteonecrosis of the knee. However, the subchondral line appears to be normal, and its prognosis is good than the sunk or spontaneous osteonecrosis of the knee. Lastly, on analysis of analysis of bone marrow lesions, radiologist must consider the patient demographic, clinical presentation, history of trauma, and MR feature of the bone marrow lesion according to its location, extent, presence of fracture line, subchondral bone plate, integrity of the cartilage, and associated ligaments and meniscal injuries. Thank you and have a nice day.
My God. ده عشان حضرتك تبقى منور اكتر عشان بس التصوير بس. طيب
انا هقدم نفسي. انا خالد مطراوي، استاذ اشعه في معهد البحوث الطبيه جامعه اسكندريه.
ما ينفعش يا دكتور خالد، ما ينفعش كده. بنشكر الدكتور سامح على المحاضره القيمه بتاعت بومارو، وانه البطل اللي محضر كل السيشن دي وعمل كل المجهود ده، لازم نقدمه ونشكره يعني. بروفيسور دكتور خالد مطراوي. And he will speak about the imaging of the crochets, pitfalls and traps to avoid.
شكرا. ثانك يو مستر تشيرمان. انا طبعا بشكر اساتذتي التشير بيرسونز، وبشكر الكوميتي على الفرصه دي ان انا اتاحت لي ان انا انظم السيشن دهيت. وطبعا بشكر زملائي السبيكرز على البرزنتيشن الهائله والتزامهم بالوقت، ودي نقطه مهمه جدا. طبعا مش it's not an easy job to speak after these nice presentations, and more difficult job to speak immediately before lunch. The lunch was postponed to 3. Don't worry, I will be in a hurry. Don't worry. As you saw, the theme that we chose, the imaging of the knee. We chose the meniscus, anterior knee pain, posterolateral, posteromedial, and bone marrow. And finally, this easy job to imaging of the cruciate, as you all know. I have nothing to disclose. To start with, and I'm a member of ISS, the International Skeletal Society. Our journal is the Skeletal Radiology. A group of researchers, they choose 115 asymptomatic volunteers, so they have 230 MR of the knee. Finally, they found this surprise. They have positive finding in 97% of their cases. So the diagnosis should be primarily based on the patient medical history and physical examination by an experienced clinician instead of solely focusing on the MRI results. But who will read the MRI? An experienced radiologist should read this MRI, because we have hidden areas even with the knee arthroscopy that are not seen except in MRI. So the message here, we should work in a team with our colleagues in clinic. This is a slide constant in my presentations. We should know that we are sure that this is the side that the patient is complaining from. Detailed history in the musculoskeletal, we have two big entities, trauma or non-trauma. Where to look for what you are looking for, you should know which sequence and which orientation. But the most important, you should look for at least two different angles, please. As my professor Ebreda taught us, you have to have a checklist, key, algorithm, whatever you want to say, but you have to have this checklist in every MRI examination you are working with. This is the normal anatomy of the MRI for the cruciate. Uniform structure, and these are the two bundles in the coronal images and in these sagittal images. My advice to my young colleagues, don't look for the ACL in the sagittal. Look for the axial and the coronal. Sometimes for the angulation, it might be not appearing like this. Like for the axial and coronal, it's not full. This is the famous Bloomington line for the ACL, and this is the actual and right angle for the PCL. For the examination, for technical purposes, we have to be perpendicular to the bicondylar line of the femur. We may go for an angle, but not more than 10%. I don't like this technique, this the axial oblique. I can't manage that, imagine that we have one sequence only for one structure only. But sometimes we need this sequence. We have this double axial oblique for the measurement of the AM bundle and PL bundle. We have the AM bundle is thicker than the PL bundle, and in male is thicker than the females. This is the two bundles in extension and flexion. One is taut and one is relaxed, so we have two clinical examination for the anterior cruciate ligament. Again, it's very thin in young people. The two bundles in the axial and two bundles in the coronal and in gross anatomy. So in these images, we can see that we have tear of the ACL, the empty notch sign. This is sure sign that the ACL is torn in the axial and coronal. Partial tear of the proximal portion of the ACL. This is a secondary sign, the kissing marrow contusion in the sagittal MRI. We can see here also the deep sulcus sign in the anterior lateral femoral condyle in the MRI, but that should not be missed in the X-ray. This is the deep sulcus sign in the X-ray. You can see the chronic tear of the ACL. Avulsion of the tibial attachment of the ACL.
Sometimes there is avulsion, the function of the ACL is lost, but the ACL is intact. Or sometimes we have this partial tear of the ACL in concomitant with this injury. This is we can see this in the PCL test. Sometimes we know that PCL is not torn. No, we have isolated cases of PCL injury, like in this case. And again, avulsion of the tibial attachment of the PCL. We can see the thickened PCL in this case. We have a concomitant injury also of the PCL. PCL is not intact in this case. We have another entity, the mucoid degeneration of the ACL, thickened, edematous, but intact and functioning. In the coronal images, this is appearance that's called celery stalk. What is the celery stalk? This celery stalk type of plant that's used for diet for people. This is the T1, and ganglion cyst of the proximal ACL. And this case of mucoid degeneration of the PCL. This is from my archive. This is a case of mucoid degeneration of the ACL. You can see the confinement of the PCL is intact, the degeneration in the PCL itself. This is the case of an arthroscopy of normal appearance of the ACL and the abnormal appearance in the mucoid degeneration, but it is intact ACL. It is not torn ACL. It's very difficult for this point is the reconstruction. We have different types of graft, from the semitendinosus, from the Achilles tendon, and PTB from patellar tendon and the tibial tuberosity. For easiest diagnosis of the tunnel of the ACL, we can see here in the left knee, this is the 2 o'clock positioning of the femoral attachment, and in the right knee, in the coronal, it is 5 o'clock in the coronal images of the right knee. This is the normal appearance of the graft after the operation. This is the direction of the tibial tunnel and the site of the attachment of the femoral attachment. This is the drawing. We can see here, this is the line of double inset. This should be immediately posterior and parallel to this line. But we can see here that a case of impingement here, the line is anterior, and this is not right tibial placement. The femoral attachment should be immediately posterior to the line drawn from the posterior aspect of the distal femoral shaft. Here we can see that it is anterior. This is wrong position of the tunnel. And we can see that the CT has a rule here in measurements of the tunnel. There's a conflict, the debate about how it should be the length of the tibial tunnel. Should we measure it in the entrance, in the terminal, in the middle? There's a lot of things like this in the literature, but the midway is the 1 centimeter, not more than 1 centimeter of the tibial tunnel should be placed. This is the cyclops lesion, fibrous tissue immediately after the ACL grafting. The big topic inside the ACL reconstruction should be had a separate lecture, the maturation of the graft. It's very difficult. This is not torn graft. This is the process of maturation of the graft after operation. You can see here the tibial tunnel is widened with the fluid and the edema around the tibial tunnel. Big problem, the separated screw after the operation. This is a failed graft. Of course, we have an anterior translation of the tibia, but you cannot judge about this because the patient is usually in the MRI is in supine position. This is not a sure sign of ACL tear. This is the normal site of the placement of the prosthesis in the femoral side, but we can see here that soft tissue interposition between the femoral shaft and the site of the prosthesis. And this is the normal site immediately after operation, but after a while, 1 year later, the ACL graft prosthesis is migrating inside the femoral shaft. This is a classical appearance of the roof impingement of the ACL after the operation. It's not common to see a case of PCL graft, but sometimes this is the appearance of the metallic screws in the tibia for the grafting of the PCL. This is the appearance when you are facing a difficult case of ACL, but this is a case I saw in last week from my practice, and I will show you in a hurry. This is a sign of ACL tear. You can follow. And in the sagittal, follow the lateral meniscus, please. Lateral meniscus is torn here, and it is a bucket handle tear, okay? This is the ACL tear. And then this is the medial meniscus. What you see? Double PCL sign in the medial meniscus. So we have here a double bucket handle. It's very, very uncommon case with ACL tear. Very unlucky patient and with this, for this diagnosis. So this person, this is not, I'm not asking about Obama, I'm asking down one. These are two persons. This is why the reason we have to have two different angles, please. So the message take home, identify cruciates in 3 planes, T2, PD, fat, sat, not in T1 or not in gradients. We have angles and line. Of course, the reconstruction is the most difficult part, but we have to follow these rules I said before to try to put this in one. We have to draw the map for our colleagues before going to the arthroscopy and should work in teamwork and put a light for them. We should put in the teamwork, but not like this, of course. And thank you for your attention.
Thank you, Dr. Khaled, for this nice presentation. And because the time is, we are late time schedule, I can allow two quick questions. Any question for the speakers? One, okay, we are allowed 2 questions only. Please, come. Please.
بصي يا دكتور، احنا خناقه في كل عيادات الاشعه دايما ما بين البيشنت او كلينيشن وما بين بتاع الاشعه بسبب الاي سي ال تير، والعيان يجي يشتكي والدكتور يتخانق معانا انتوا كتبتوا ان الاي سي ال كويس واحنا لقيناه فيه تير، او احنا كتبنا بارشال تير وهو او كتبنا نورمال وهو بيقول بارشال تير. عايزين الفاصل في الموضوع. قالوا لنا قبل كده ما تكتبوش بارشال تير، ما تكتبوش سبرين في الاي سي ال.
لا هو definite the main issue is sometimes the radiologists يكتبوا sprain. Nothing يعني مفيش حاجه اسمها sprain.
مفيش حاجه اسمها
definite we have only 3 items: normal ACL, partial tear ACL, complete tear ACL.
partial tear دي يعني
partial tear proximal attachment بتاعته that's most common. It's not usually يعني التيبيال attachment لو اتقطع غالبا بيبقى معاه avulsion. او الموست ديفيكلت بقى ان يكون one bundle اللي هو المقطوع. عشان كده we have to examine this cruciate in the axial and the coronal to check if this only one bundle. هم بيبقوا عارفين كلينيكال لان عندهم examination للانتروميديال bundle لوحده وفي examination للبوسترولاترال bundle لوحده.
يعني البارشال تير يعني partial fiber discontinuity.
وعادة بيبقى في الفيمورال اتاتشمنت، لكن ممكن يحصل one of the 2 bundles is torn والاذر بيبقى انتاج. عشان كده بيبقى ما بيبقاش التير بيبقى التست بيبقى completely positive.
طب يا دكتور في حالات التروما وبيبقى دايما شاب صغير ومعاه شويه افيوجن يجي الاي سي ال ثيكند والتر سيجنال انتنسيتي.
في entity اسمه interstitial tear. And this is very difficult for us and for them. Even after examination they don't know. Lax ACL is totally difficult for all the people in the team. ده ما بيتعرفش غير انترا ارثروسكوبي. هو بيعمل بروبنج للاي سي ال بيلاقيه ساعتها مقطوع.
طب ليه ما فيش اي سي ال سبرين؟
لا مفيش حاجه اسمها. هم حتى هم مش بيعتمدوا زمايلنا مش بيعتمدوا
يعني ما نكتبوش في الريبورت.
لا نو سبرين انتاكت بارشال تير كومبليت تير. الانترستيشال تير ده مجرد ان انت تدي نوتيفيكيشن ان الاي سي ال از نوت نورمال بس يعني هو بيبقى بيه بريزيرفد كونتينيوتي بتاعته.
يعني نكتب نورمال في التقرير حتى لو كان ثيكند والتر سيجنال.
انترستيشال تير لاكس فور كلينيكال كورليشن.
interstitial tear. شكرا يا دكتور.
Any other question? No.
السلام عليكم. اثناء الاكيوت اتاك بتاع البيشنت وجاي وسوولن واديمتس ني، احيانا كتير بنلاقي منطقه الاي سي ال اديمتس abnormal signal. Can we say acute tear for clinical correlation and follow up?
Let me tell you, in microscopy, I hate this acute term of acute. We can say recent Recent means edema is okay.
Yes.
Recent. Acute in musculoskeletal, no. It is recent or chronic.
Okay.
هو في نقطة طبعا لكن في حاجة في موضوع الاكيوت ده برضه في كومن ما اعرفش جت منين ان العيان immediately after trauma you should wait for 2 or 3 days to do the MRI to avoid trauma. This is not correct. You can do it at any time, but you can use another techniques. Instead of PD fat sat, you have to have T2 turbospin echo. T2 turbospin echo, the ligament is more evident inside the edema. But in PD fat sat, the edema is obscuring everything. You have to have T2 turbospin echo hand in hand with the PD fat sat image.
Sagittal or coronal?
Sagittal, of course. Sagittal. Thank you.
Thank you for attention. And now I got information that the lunch is ready for in the main restaurant in the hotel right now. Okay. Thank you for attending the meeting, and thank you for our colleagues in the Fluoroscopy.
Okay. Yes. Okay. Good evening, everybody. Hello. We'll start. We will start. Okay. First, I'd like to welcome you all to our conference. We're very happy to have you among us in our radiology conference. We're delighted to have many. I'm personally delighted to see many of our very dear friends from Egypt and from the UK and from Germany, or Egypt actually, Dr. Noor. I will start by giving a talk to Dr. Said Ghanem. Professor Said Ghanem is the president of our conference, and he will give you a quick welcome note. Dr. Said. Hey. تعال هنا. لا لا.
Bismillah ar-Rahman ar-Rahim. Welcome, dear colleagues and friends. On behalf of the Egyptian Society of Radiology and Nuclear Medicine, we cordially invite you to attend the 58th Scientific Conference on 10-11 March 2022 in the beautiful coastal city of Ismailia. The conference is organized in collaboration with the Royal College of Radiologists, RCR, and the Pan-Arab Association of Radiology Societies, the PARS. We have prepared a very rich scientific program with many eminent international and Egyptian speakers covering interesting topics from basic to advanced radiology. We have also designed 2 remarkable workshops by the best in their field. These workshops provide basic, advanced, as well as hand-on experience in the field of musculoskeletal and arterial duplex. Besides, 2 new sessions, nuclear medicine and Ministry of Health session. The conference is a good opportunity to network with your colleagues and the industry professionals whose partnership is vital for our practice. Finally, we hope that you will benefit from the scientific activities and enjoy the social gathering. Thank you.
Thank you, Professor Said. Now we will start the opening ceremony by honoring some of our guests. The first our first trophies will be for scientific excellence, التفوق في البحث العلمي, and it will be presented first. We will present our first prize or trophy to Professor Dr. Nuruddin Abdurrahim Nuruddin. It will be delivered by Professor Tariq Dasti, President of the Egyptian Society of Radiology and Nuclear Medicine. شرفتنا يا دكتور نور. ميرسي يا نور. Our second trophy will be to Professor Dr. Muhammad Abdul Khaliq Basha.
It will be presented by Professor Tariq Dayasti as well. Now we will honor some of our professors and colleagues whom we lost this year for various reasons, and we really miss their presence with us. We will start by honoring Professor Dr. Abdulmenam Abu Senna. Professor Abu Senna was the previous head of Radiology Department of Ain Shams University. The trophy will be given to Professor Dr. Muhammad Abu Huda on behalf of the family of Professor Abu Senna. The second one will be Professor Dr. Muhammad Farid Abdelmenam Muhammad Nouman, who also we lost this year. And it will be presented to Dr. Khalid Moghazi, Head of Radiology Department of Alexandria University. Then we'll present another one to the late Professor Mahmoud Abul Fadl Ahmed. Dr. Abul Fadl was the Head of Radiology Department at the Azhar University, and it will be presented to Professor Dr. Saad Ghanim on behalf of his family. Then again, we will present to Professor Dr. Fathi Hussein Ali from Azhar University, whom we lost as well. And again, Professor Saad Ghanim will receive it on behalf of the family. Well, the next one will be presented to the family of Professor Dr. Shadia Abu Saif Helmi. Dr. Shadia was the head of Radiology Department of Alexandria University, and we lost her this year as well. And it will be presented to Professor Dr. Khalid Moghazi. Another one will be presented to the family of Dr. Mona Ali Abdul Wahid Ali from Ain Shams University, whom again we lost this year. And it will be presented to Professor Muhammad Abul Huda. And the last honor will be to someone from our immediate family. We lost this year Professor Dr. Fathi Tantawi, the previous president for the Egyptian Society of Radiology, and a dear friend and mentor and to all of us. Dr. Fathi was very dear to all of us, and I think that his loss was something that we all will not, well, sorry, I'm a little emotional when it comes to Dr. Fathi, but we really lost him and we miss him a lot. Professor Fathi Tantawi, if you allow me, I will give a very short presentation. I prepared it. It doesn't give him a lot of Well, he deserves much more than that, but it was done on short notice. I hope that it gives him some credit. Professor Tantawi was born in 1947, and he passed away last year in November. He was born in 1947, graduated from Zagazig University, 1973. He had his master's in 1976, and his doctorate degree, 82. And he was the chairman of the radiology department from 1995 till 2006. He was the president of the Egyptian Society of Radiology and Nuclear Medicine from 2006 and until 2012. During this time, we had a lot of successes. We had the PARS conference in Alexandria in 2019 with thousands of participants, an African Society meeting in Alexandria also in 2012, and it was a very successful meeting. During his period, there was the ESR Meets Egypt session in Vienna in 2012. Professor Tantawi, after that, became president of PARS, the Pan-Arab Association of Radiological Societies, from 2011 until 2013. And he was the ISR, the International Society of Radiology, EXCOM member from 2012 until 2014. Those are some of the photos and some of the conferences for many of us with Professor Tantawi. This was during the African Society meeting in Alexandria. This was during the session, the Egyptian session in Vienna, and he was presented the award and the certificate from the president of the European Society of Radiology at that time. Again, this photo after we finished that long day and we stood tired in our booth, Professor Tantawi, Professor Dasti, and myself, and I remember that we were very happy for the success of our session. Another photo of Professor Tantawi with Dr. Ann Osborne, and he was very fond of her. She was a real nice lady, and she was very courteous. This was during RSNA. This photo was in Brazil when we were attending the ISR meeting in Brazil, in Sao Paulo, 2012. And again, this was in Brazil. And again in Rio de Janeiro. This was during the RSNA. Another photo in RSNA with some of our colleagues. This was in Kenya for the African Society of Radiology meeting. And it was a successful meeting as well. Mostly Egyptians went there in Kenya. And when we went to the safari, oh, that was fun. We had a lot of fun times together. He was a real fun person to be around. This was in Buenos Aires in Argentina and the ICR. In Scotland, and again in the US during the RSNA, and with his lovely daughters and wife, and again with Heba, his daughter, with Angie, his daughter, and finally we miss him, and it's farewell, but he'll always remain in our hearts and souls. So we'll present a simple thing to Angie and Heba. Okay, now we'll go back to honoring Okay, so now we would like to thank our international speakers and guests and we're honored to have them with us here. I will start by Dr. Nuruddin again. فين التمشي؟ شيلها خلاص مش مهم. لا 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 اقفل خلاص. ثانك يو. Our next, okay, now I have to give, yeah. Okay, enough for Noor. Now to my very, very, very dear friend, Dr. Joanna Kasnia Brown from the UK. Joanna has always been a dear friend and a partner in our conferences. We miss her for the COVID period, but she's back strongly. Come on, Joanna.
I'm just taking this opportunity to take the microphone for a minute. I'm just so honored and pleased to be again with all of you. And you've done the amazing job during the COVID. And it's just so nice to see that you are starting the conferences again. You know, the COVID is still here. It's just, you know, finishing. But it's just lovely to see all of you here. And it's fantastic that you were able to do this conference and try doing the education again. So really, really great pleasure to be here. And thank you for inviting me.
Okay. Then, it's a photo shoot. Okay. Also, I have to thank our dear friend again, Dr. Dennis Remedios. Dennis always comes to our conferences and helps, and we're very happy to have him with us this year. Well, I think now we have to conclude this opening ceremony. We have to start the Royal College of Radiology session. And we're so eager to listen to our friends from the RCR. Okay. Now we start the other session. I forgot it's me again who's presenting it. Okay, so I have to welcome our dear friends from the Royal College, Professor Joanna Kasnia Brown. Then I have to welcome again my friend Tanya Van Buren and Patrick Courtney from the offices of the Royal College, and Dr. Hassan Abd Salam. Hassan is the Royal College ambassador in Egypt. He's from Alexandria. We'll start by a short presentation by Professor Dr. Tarek Dayasti. Then after that, we'll start the session. Okay. عندك حاجة هنا؟ PowerPoint. حطها في الفلاشة؟ فين؟
انا فتحتها دي
What's your name?
So my name is Tanya. Tanya Van Buren. So is it Tanya Eva?
Tanya Eva.
Who's Eva?
That was my grandmother.
Oh.
خليه يجي اللي حاضر. ما هي المفروض حولت من هناك، ده انا شايفها هناك اصلا.
حطيتها هناك على انهي فولدر؟
على الجديد انا حطيتها على اسمي، بس هنا مش في الفولدر بتاعي اسمي.
في انهي فولدر تاني؟
هي سيشن 7 تاني كان تحت سيشن 7.
ممكن تكون حضرتك مثلا.
وكان يوزت نحط بتاع الاول. لا ما هو عشان واحد واحد بقى لما يحط لي ده عشان وخليه ممكن تنزلها لو هي لما تيجي ننزلها ساعتها. ثانية واحدة. احنا منزلينها هناك بس ما ظهرتش عندكم هنا. خلاص لا نزلتها هنا دايركت. Good afternoon. It is my pleasure to introduce this session. I would start with history and background for our cooperation, then the current situation, and end with future perspectives. So we start actual operation in 2019 at the 5th African Society of Radiology meeting organized by the Egyptian Society. And we have here a session for RCR session with first is being a radiologist in UK, then new trends in diagnostic imaging. After this session, there is also some involvement in subspecialty session like here for musculoskeletal and pediatric imaging. Dr. Joanna Brown has presentation. Then at March 2019, I have a meeting with the president of the Royal College at the ECR in Vienna. And our concern was mainly due to unacceptable numbers of overseas radiologists waiting for CR2B examination, and it was at that time over 1,000 radiologists, and waiting so long to have to get a place to sit at the examination, and they have to go through the whole waiting process if they fail, and then this affects the reputation of the RCR. Also, we have presented a desire to have all parts, but especially 2B examination in Egypt, and to hold, try to be held later this year in 2019. Also, we asked for FRCR to be training or teaching courses as pre-exam courses. I get, after this meeting in Vienna, a message from Dr. Nicola that it was a good meeting with some of the officers of the RCR and with Dr. Rami Mansour and Dr. Joanna. Then Dr. Nicola promised to do her best to try to move this forward as a priority. Then the corona pandemic has some affecting some of our procedures. Then We have also during this epidemic some webinars, and this were before this webinar we have this session in North Africa Health at April 2019, also for RCR session and some subspecialty talks like this one, Dr. Joanna Brown and Rami Mansour and Raj Chari. Then during the corona pandemic, we have some webinars like this one this one was by the Royal College of Radiologists International Committee and in cooperation with the Egyptian Society of Radiology and Nuclear Medicine and the British Society of Skeletal Radiologists. Then we have achieved to get a pilot exam, FRCR examination in Egypt, and asked for this by this letter to have it in Egypt at later time. And this was the computer lab at Ain Shams Faculty of Medicine in Egypt. And also we have the required building facilities available. Also, the hardware requirements was available, and here we have smaller rooms for oral examinations with all the examination rooms requirements available. And the exam was held in 12th of November in 2021, and this was during the 2B exam, and it was a very good exam with around 75% success. Was the highest score was from in all 2B examination all over the world was from a colleague from Alexandria. And after that we have I have signed on behalf of the Egyptian Society a memorandum of understanding between the Royal College and the Egyptian Society with Tanya. And then we have achieved a very good achievement was to have an examination dates in this year, 2022, for the first part, it's here, and for the 2A and 2B. And also here we can notice that the next week in 17th and 18th of March, we have the first CR1 in Egypt. And for this, I'd like to thank all the persons from the Royal College of Radiologists who supported the Egyptian Society and was very cooperative to achieve this achievement. And also from our team, our RCR ambassador in Egypt, Dr. Hassan Abdessalam. And there is also RCR learning groups. Many people in these learning groups helped us and give statistics about the number of radiologists, about the communication with the Royal College, and also our colleagues from Ain Shams, Dr. Wahid, Dr. Khalid Abu al-Futuh, and Dr. Karim Omar, and also the ICOM group, particularly Ghufran and Engineer Ahmed. And also, I'd like to thank all my colleagues in the ESRNM board for supporting me to achieve this. And this year we have Dr. Joanna here with us in this meeting. And also in this session, I just make an introduction and waiting for the talk from Joanna and Patrick and Tanya. And thank you so much. Also, I have just to finish, I'd like to give two more slides here about our future perspectives. We have, regarding the cooperation with the Egyptian Society, we looked forward to further aspects of arrangement between the RCR and the Egyptian Society. The Egyptian Society wished to expand the capacity of our cooperation to include educational courses for the different subspecialties not related to the examinations, and pre-exam preparatory courses as well. and to fix the RCR session in each annual meeting of the Egyptian Society of Radiology. Also, to include this issue as an addendum to our memorandum of understanding, or to make separate memorandum about these added fields of cooperation. Also, beyond the Egyptian Society, also we have to public the statements about this agreement and the introduction of examination in Egypt. And we look forward to further aspects of agreement between the RCR and the Egyptian Fellowship of Radiology, the RCR's assistance and or endorsement of the radiology curriculum of the fellowship, and the training program of the Egyptian Fellowship will be great. And also we look for accreditation of the Egyptian Fellowship graduation certificate by the Royal College of Radiologists. And in further meeting during our cooperation, I invite you to go to Aswan and to make a Nile cruise between Luxor and Aswan. And thank you very much.
Now I welcome Tanya Van Buren. Tanya will give her presentation. And Tanya or Hassan or who? Both? Okay, Tanya and Hassan Abd Salam. Dr. Hassan Abd Salam is the ambassador of the Royal College in Egypt. He's from Alexandria University, the interventional radiologist, as a lot of you know.
So first I'd like to say such a huge thank you to our friends in the Egyptian Society of Radiologists and Nuclear Medicine. It's a great honour for us to be here and joining you for your 58th Scientific Conference. On behalf of all of us, I would just like to say thank you, Professor Tariq El-Diasti, for that wonderful introduction. And I have to say I'm so excited about the future of our collaboration and cooperation on the back of that. What I'd like us to do this afternoon in the time that we've got with you is to take you through some of the initiatives that we've got ongoing at the Medical Royal College in England, but also to discuss the potential future for some of the opportunities that arise by virtue of our collaboration. We do have a stand outside, and I would urge you and encourage you to please come and have conversations with us about your experiences and what you want to do in the UK, and if we can, we're really happy to help you. I'm going to stay and push the button on the slides, but I'd like to introduce Hassan, Professor Hassan. He is our ambassador for the Royal College of Radiologists in Egypt, and your first point of call if you need anything on our behalf whilst you are here. I did put a slide in allowing us to introduce ourselves, but I feel that we probably don't need any further introduction. So I shall quickly skip over that, and I will pass on to Hassan.
Hello everybody, and thank you for the kind invitation. Thank you Professor Tariq and Professor Ahmed for the invitation and to allow us to give us the time to share our projects and collaboration between the Royal College of Radiologists and the Egyptian Society of Radiology and Nuclear Medicine. And first of all, of course, I would like to thank Professor Tariq for all his efforts to get the FRCR exams in Egypt. It wasn't easy, and he put a lot of effort to facilitate all the challenges to make it possible to get the exams here in Egypt. And this probably is one of the biggest achievements in the Society of Radiology in Egypt. So the Royal College of Radiologists is the professional body responsible for the specialty of clinical radiology and oncology in the UK. It's just one body there who regulates everything related to radiology there. Practice of radiology, the science of radiology and oncology as well. Assuring the appropriate standards of practice across the UK, hospitals, teaching hospitals, DGHs, and all practice in the UK, as well as education and exams and certification.
So I just wanted to take a bit of time to tell you about the areas of work that my team do. So we cover off a number of different areas. We develop our publications and standards. We support all trainees, both in the UK and internationally, to progress their careers in the UK healthcare system. We look at academic research and spend a lot of time working with our academic colleagues in the UK to support them in promoting radiology as a research discipline in its own right. And I'm sure the two areas of most interest to you would be our examinations, and we've obviously had a conversation earlier around the journey that we've been on to get the exam into Egypt. But also we have a comprehensive suite of online learning resources, which I would really like for everyone to have the opportunity to explore, to make use of whilst we continue to further our collaborations in Egypt. So let me start with a bit about the exam, and if I am repeating what you already know, please forgive me, but I just wanted to really give you a flavour of our exam if you aren't aware of our exam infrastructure. So our exam is split into two parts, the first part being anatomy and physics, and that's the exam that will be happening next week, and we plan to be providing in Egypt on a three times a year basis. Our second exam, the final FRCR, is split into two parts, 2A being the written component of the exam, and 2B comprising three components, our long cases, our rapid cases, and our oral examination. So you've already seen this picture in this presentation previously, but I cannot tell you how delighted we were to finally be able to offer the FRCR Final 2B exam in Egypt in November last year. It was an amazing collaboration between the exams team in the UK and Ain Shams Medicine University, and I would like to extend my sincere thanks to everyone who was involved in making that happen. From our perspective, it was a really, really, really positive first experience and pilot of the 2B exam and the opportunity that we have to broaden it out going forward. I was equally delighted to see that our Gold Award winner for that exam sitting was a doctor based in Egypt. So Dr. Tariq El Saka, congratulations if you are in the room. What a phenomenal achievement to, in our first sitting, have a Gold Award coming from Egypt. And as Professor El Diasti made reference to, Egypt surpassed our global pass rate for that exam sitting. So the global pass rate was 65%, and it was 75% in Egypt. So congratulations to you all. That was impressive. We were very, very, very impressed by that. So let me talk you through briefly our plans for 2022 and beyond. In 2022, we will be providing all of our written exams in Egypt across all of our exam sittings. Certainly our Part 1 will be delivered 3 times. Our Part 2A we will be introducing in the autumn sitting, and again we will be delivering a Part 2B sitting. But what about beyond 2022? We have great plans to take that 1,000 backlog that we heard about earlier and to take it down to 0. So anyone who wants to access our exam can do so at the time that they need it. But I cannot emphasize enough the extent of that challenge. I have an examiner in the room with me. Dr. Joanna Casnia-Brown is also a 2B examiner and has been a real champion and ambassador for our 2B.
Yeah, I just wanted to say that, so I'm one of the final examiners, so I'm doing the Viva, and preparing everything, what your society prepare, and here, it was amazing. And from the examiner's perspective, we always worry to examine the international candidates, because we know that the exam is structured for a training in UK. So we have a different pathways, we have a different clinical scenarios, we recommend different structure of the answer. So examining international candidates is always challenge and it's always worry. And I know that all of my colleagues, we were always slightly worried how we are going to do it, are we going to achieve, are we going to deliver? But from everyone that I was talking in the group, we're absolutely delighted to examine you and being with you in the rooms. So I just want to say that your candidates were incredibly well prepared. The answers were very well structured, and it was just very nice, friendly conversation. So beautiful exam and great that you all done. And this is a really good showing that education in Egypt is on the very, very high level. And yes, as we talked about this before, it's nice to put the curriculum together, that we'll be talking later, but the examination was fantastic. So I will strongly encourage everyone from Egypt to sit the exams, if you wish, because you are a very good radiologist, and it's, and it's a fantastic thing that we can help to deliver this examination and to give you this certificate. So thank you.
So yes, you have proved that we need to give more FRCR 2B opportunities in Egypt. What we now need to do is ensure that we can create the capacity that we need to be able to do so. And that involves us actually restructuring the way that we work in the UK to enable us to deliver exams more globally. And that's a fundamental project that me and my team will be working on over the next 3 years. Our dream and our vision for after 2022 would be that actually we had examiners based in Egypt who were able to deliver the exam, so we weren't reliant on a UK pool of examiners. We don't have enough examiners for everyone we need, so that's something that I'm very keen for us to be looking on. And Professor El-Diasti, as part of our ongoing plans for how we collaborate, I think that that's something I would really like for us to have a conversation about. Back to the love for us having the exam there. So another area of work that we do in the UK that I feel that we haven't spent enough time showing to you is our RCR Learning Hub. We have a number of comprehensive learning resources that are available to our members predominantly, but we have a number of resources that everyone can access. So I would encourage everyone to go and have a look at the Learning Hub and see what there is for you in terms of being able to broaden your learning horizons and access our e-learning. Over COVID, we've actually built a number of online events, and I've heard very good things from a number of different people around the global webinar scheme, and I know that a number of people have watched all of them, so that is amazing. Congratulations to those of you who have done that. But I would encourage you to keep an eye out on our website for our online events as they come up, and you're more than welcome to join in with them. And we're also hoping that in autumn-winter, we will be offering out courses based in Egypt. So our hope is to offer out an MSK course, a Pediatric course, and a Neuro course before the end of this year. So watch this space. We will provide some local training for you as and when. If I could just take you through and talk to you a bit about our Learning Hub. So I did want to put a demo on the screen, but I'm so sorry, my laptop just wasn't up to it. So I've taken some screen prints, but would invite you to go and have a look at it yourself. This represents the welcome page of our Learning Hub, and as you can see, you will have access to the latest content. You can keep a record of all of your activities should you need to demonstrate to any third party that you have undertaken continuing professional development, or CME as it might be called here. And then we have a comprehensive catalogue of everything that is searchable and will start to learn your preferences. This is an example of the trainee resources that we have available. Sorry, I can't scroll down the page, but I would encourage everyone to sign up and register as a guest or a member if you are. And you will see that we have pulled together a number of different resources that we feel will support you. Again, these aren't the only 3, there are more than that, but we feel will support trainees as they're learning and developing within their careers. And then if I was a breast radiologist and I put in a search for breast radiology resources, it would bring up everything that's breast related. So it's very easy to navigate, very intuitive, and it has comprehensive content amongst all of our special interest areas. We've also got a lot on the hub around clinical audit, quality improvement, and elements of practice which in the UK are quite fundamentally covered off through our exams, and therefore would be of benefit for you to be familiar with if you are indeed thinking about taking the FRCR 2B exam, or any of them indeed. I'm now going to pass back to Dr. Hassan, who is going to talk about working in the UK and how we can help.
Hello again. GMC registration is one of your first challenges. And you have 2 ways of getting your GMC registration, either doing the PLAB test or as a radiologist passing your FRCR and then doing the English test and then apply for the GMC, which is just some paperwork and everything should be smoothly done. So these are the two ways, a PLAB test or FRCR plus English test. Once you've got your GMC registration, you've got different routes to go through. You can get a substantive consultant post, and to get a substantive consultant post, you either complete your training with a CCT certificate, so certificate of completion of training, or you can certify your training, overseas training, through CSER, which is the certificate of equivalence for specialist registration. This is if you are going to apply for a substantive consultant post. If you are applying for a registrar post or a specialist doctor post, then there are two ways, the global radiologist scheme, and my colleague Joanna will talk to us about the global radiologist scheme, which has been introduced a couple of years ago through the RCR. And then, or you pass your FRCR or PLAB and apply for a specialist post if you want to do some training before being a consultant in the UK, which I advise you to do so. Joanna?
So you heard about the Global Fellow Program before, but it's really important now, I think, to revisit it again, because we have the examination here in Cairo, and the number of people who will have the full FRCR qualification will be increasing. So the Global Fellow Program or Global Learning Program is a cooperation between the Egyptian Society of Radiology and Nuclear Medicine and the Royal College and Radiology. Because why? We have many radiologists who have the FRCR examination already in your country, and hopefully the list will be growing. And we have the highest number of overseas RCR members here after India. And many Egyptian radiologists working as a consultants in UK and in the other countries in Europe. But this is not only about the working, this is about the education. Because I know that everyone wants to complete, apart from the general radiology education, you like to do the subspecialty. Maybe this will be your first subspecialty, or develop it on the higher level, or develop the second subspecialty. And this is a very, very good opportunity to do it. So what we call it earn, learn, and the return scheme. So it means that you will be coming to the UK, learning subspecialty, but working and earning money at the same time. So it means it's not the burden on you and the family, because you will be able to support the family by working. This is a pathway for independently competent radiologists to work within the NHS. So you need to have the full FRCR examination to take this post, and in goal of develop a special interest. The same time when working, it will be a full-time paid job, and we envisage that the 3 years will be the maximum benefit that you can achieve. Of course, it depends on your circumstances. You can do it 1 year, 2 or 3 years, but up to the 3 years, this is what we recommend. And this will be the agreement between the Egyptian Society of Radiology, Royal College of Radiologists, and the hospitals in UK, in England, Wales, Scotland, and Northern Ireland. Until now, we were placing the global fellows in these 3 countries, but now it will be in England as well. And the most important, that it's open to all of the radiologists. So if you have any radiologists from Libya or any other countries in the region in North Africa or in Middle East, it will be also, if they are working here, will be open. And as I said, it's between 1 and 3 year fixed term contract. Employment level will be on the level of the specialty or associate specialty doctor. So you will be working independently, but until you completed your CSER pathway, you won't be called a consultant in UK, but it's the independent working job. It's a full-time appointment which we call it 10 professional activities. One professional activity is 4 hours, so it's half a day. So you will be in the full employment from Monday to Friday. But what is really important that in this job, we give you 6 PAs of independent work. So it means that 3 days a week you will be working as a radiologist, but 2 days a week will be allocated to developing your professional interest. So during this time, you will be attending the meetings, MDT, doing subspecialty training, what you want. And then you will have a lot of support during this reason. So we thought that it's a really, really nice balance between the working normally and developing the special interest. So this pathway, it's open, and hopefully soon we will be advertising more jobs. Over the last years, we have several jobs in UK, and together with Professor Tarek and Dr. Hassan, we interview people from the Egyptian Society. What is really good for this, that you don't need to travel to UK to find a job. You can apply for the Global Fellow, for the positions from here, and all of the interviews will be conducted by Zoom. So it will be the pre-interview by us, by the college, and then the final interview, and we will recommend the candidate to the trust. So the good thing is that you don't need to have any financial burden before you will go to UK, and if you accept the job, then you will be having all of the paperwork organized by the trust as a offer of the job to applying for the visa. So it's good because it's moving back everything here to Egypt and can be organized this way. And also we will give you the full support from the RCA with all of the paperwork, how to work through your CV, and how to develop the subspecialty. You will also have the access to all of the RCA learning, educational material, and being employed by NHS to all of the other REITs and the other portals. So it's a good opportunity, and if you can do it from the personal and the family perspective, I think it's quite good if you can take this step further in your professional way. And so I will encourage you to look into it. It won't be any definite deadline to applying for the jobs. The jobs will be coming on the basis. So just look at the website and register your interest if this is the pathway for you. But it's definitely a very good pathway to develop your subspecialty and improve your education. And I will pass it to Dr. Hassan to tell you how it is to work in UK.
Thanks, Joanna. So as we said before, you have to decide which route you want to go through. So either you want to apply for a consultant post or a training post or the Global Fellow post, which is, I think, very, very beneficial for someone who went through this journey. 18 years ago, when I first moved to the UK, I didn't have all these options, but if it was my choice, I would probably choose the Global Fellow scheme. I had something similar to it when I first started in the UK in 2004. So we have to first decide which route you want to go through, prepare your CV, prepare for the interview, and I guess preparing for there are some websites and how to prepare for your interview for a consultant, for a radiology post in the UK, some very common questions that you are definitely going to be asked or very, very likely to be asked in your interview. Once you get your job there, it is different than working as a radiologist in the UK is different than working as a radiologist in Egypt. And the moving to the society there, you have to think about schools, GPs, there are different issues that you have to be aware about. I might even talk in Arabic about these, if you can allow me. لما تبتدي شغلك هناك لازم الدنيا هتبقى مختلفة، التعامل مختلف. Don't expect to be called Dr. Hassan or Dr. Muhammad or whatever. you will be called by your first name, which is not, I mean, this is normal there. From your juniors or from your seniors, from your colleague radiographers, nurses. I know here it is different. Everybody is called doctor, but there you won't be called doctor, so don't get offended or anything. موضوع الجي بي والمدارس، طبعا الناس اللي هتنقل معاها اطفال، انا لما رحت كان ولادي لسه صغيرين وفي سن مدارس، او بنتي الكبيره يعني كانت في سن مدارس، فطبعا you have to think about schools and good schools. Schools are free there, but there are different schools in different levels with the Ofsted reports and all this. So think about good schools, and you have to live in the catchment area of the school to be able to get your children in this nice school. So لازم تفكر هتسكن فين علشان تعرف تدخل ولادك مدارس كويسة. أول ما رحت كانت بنتي لسه داخلة ابتدائي دير هناك، دلوقتي دكتورة امتياز الحمد لله يعني. So it is different, but it is easy, and you can get your way through easily. The people will be advising you, and everything will be fine. You won't get stressed out. With your patients, you have to treat your patients with dignity at all times. Explain the procedure clearly. Sometimes here in Egypt, you don't explain everything in details, but as a radiologist in the UK, you have to explain everything in details and make sure that your patient understands every single step in the procedure. Consent, of course. Nothing is done without a consent. Make use of interpreters because it's a very cosmopolitan country there in the UK with different languages of being spoken there. So make use of the facilities in the NHS. It's always available there if you want to have an interpreter between you and your patient. It's normal there to address the patient with a surname rather than his first name, unless he wants to be called with his first name. Again, confidentiality is very, very, very essential. Even USB with patient details are not allowed. It has to be encrypted USBs. In case it's lost, the patient confidentiality is maintained. Communication skills with your computer. There's a RIS system, a PACS system, and all of us are now used to RIS and PACS. When I first moved there 18 years ago, I wasn't aware of all this, but it's now been used in Egypt, so it's not a problem for you anymore, I think. There's a speech recognition software now that you can dictate your software to the computer directly and amend your reports and verify them before you go. Letters and emails are the official way of communication between doctors, GPs, consultants, and everyone else, your administration team, your nurses, radiographers. MDTs is a very, 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 very important part of your practice there in the UK. Interaction with clinicians and GPs is very essential. Every patient is discussed thoroughly. You have different meetings within your department. So you'll have your MDT, the multidisciplinary team meeting, and depending on your subspecialty, you might have one or more meeting a week. The clinical governance meeting, again, it's not that frequent, but you have one of them at least. You can have the morbidity meeting, whatever. And then there is the consultant meeting, which is equivalent to مجلس القسم عندنا يعني في مصر. And if you get an educational supervisor post, then there is the educational supervising meeting. As an educational supervisor, you supervise a number of registrars throughout their 5 years of radiology or 6 years, depending on the subspecialty. So you take them through their journey as registrars, advise them, and do their appraisals. يعني زي موجه العلمي بتاع كل هناك كل نايب له موجه علمي. بيقول له انت ايه اللي ناقصك وايه اللي المفروض تعمله وايه اللي مش المفروض تعمله وايه اللي انت ناقص تكمله. لما كنت شغال هناك في جامعة ليفربول كنت one of the educational supervisors there. So as a consultant there you have, or even as a registrar, you have to have somehow an educational role. So training your junior doctors, if you are a clinical or education supervisor, or even at the deanery level. The deanery is, the UK is divided into different deaneries, يعني متقسمة أجزاء وكل جزء الدينري هو المسؤول عن التريننج في المنطقة دي والريجسترارز في المنطقة دي، فمتقسمة لدينريز كلهم في الآخر under the hub of the Royal College of they all report to the Royal College of Radiologists, and you can be in the educational board on the RCR or at a higher level. Management rules, again everybody's there is somehow has got a management role, so you can be a subspecialty lead of MSK, of intervention or whatever, or a clinical director of the department اللي هو زي رئيس القسم عندنا يعني. That's it. Patrick. I'm introducing Patrick, the global coordinator for the RCR.
Thank you, Dr. Hassan. Assalamu alaikum. The following is what I've learnt from working for a number of UK leading professional membership bodies over the last 20 years. I know I don't look that old. To answer the question, why join the RCR? So the first is community. I think it's human nature that we all want to belong to a family, a clan, a tribe. It's just something that we're driven to do. And I have to say a great thank you to Professor Emad and everybody here who has come and said hello, to really welcoming us today to the Egyptian family. It's really felt really special. We want to be in a family of like-minded people who share common values and goals. In the UK, we say birds of a feather flock together. I think that's very much true. The RCR is a global professional membership organisation based in London, which is part of a wider academy of medical royal colleges. Again, another family, another tribe, another clan. We're developing deep partnerships with a constellation of major colleges and societies around the world, including our esteemed colleagues at the Egyptian Society of Radiology and Nuclear Medicine. Our professional network of doctors spans the globe. We have 12,347, that was easy to remember, 1, 2, 3, 4, 7, 12,347 members in 49 countries, including 58 radiologists with a primary address in Egypt, although I suspect there may be a few more. So if you haven't updated your address, please do so after the meeting today. We want to welcome you to the home of radiology, the RCR. The next point is external validation, and again, I think it's human nature that most of us, I think, want to be recognized for our achievements. I always think it's lovely if our mothers or our friends say, "You are a great doctor." But I think what really counts is having your knowledge, skills, and experience certified to a global quality standard, and your expertise celebrated by an international awarding body. We were all so happy right across the staff at the RCR when the results came in, and we shared them. There was an internal email went round, and the Egyptian results were in red, saying, "Look how well the Egyptians have done." So we were all extremely pleased for you and the Egyptian family of radiologists. Differentiation. We all must work hard to set ourselves apart in such a crowded and competitive marketplace, to make our business cards, our LinkedIn profiles, and our resumes stand out, and distinguish ourselves from the herd. And what I'm really talking about there is letters after your name. I've noticed in the last few days in the region how much you guys like logos and having badges on things. So why should it be any different for individuals? Why should it be any different for individual doctors? Career structure. This is largely something which has been identified through market research in the UK, that younger professionals, the thing that they want most from their professional membership organisations is career structure. They want to know what they're going to do in 2 years' time, 5 years' time, 10 years' time, which qualification they should take, which course, which direction they should take their CPD in, who do they get it certified by, what position within an organisation should they be. We all want that peace of mind that our careers are on the right track, that we are heading in the right direction, but how to judge? RCR membership can give you clarity on career options available to you and the tools you need to enhance and advance your career, as Tanya was saying earlier. Mentoring is another one for the younger generation, but not necessarily. And I wonder if you've heard about reverse mentoring, which is actually about more senior professionals and experts learning from the younger generations. Something we've really picked up on from our conversations with other societies and colleges around the world is how much things are changing so much, how much the profession is changing with technology, and how experienced doctors who've been working away need support to understand how things like artificial intelligence are going to change the way that they're going to be doing their jobs. And I think we can all learn from the younger ones if we can understand what they're talking about. Joining our global forums and committees will allow you to access expert opinions and guidance, helping you to better understand contemporary perspectives on your speciality and gain insights on where healthcare is heading. Last one is really something. So Tanya and I have spent 3 days in Dubai this week. It's a real whistle-stop tour. So we had 3 days in Dubai, 2 very short days in Egypt, but we'll definitely be back. And something that we're certainly hearing from lots of people that we're talking about is this importance of portability, the importance that you have a professional passport. So I'm not going to say what is Egypt's #1 export, because we all know that that's Mohammed Salah. And a close second is radiologists. Everywhere I go, I hear about an Egyptian radiologist and that they want to come to the UK and that they're traveling, they're in Dubai, they're everywhere. They're a really amazing export. In our globalized world, geography is shrinking, and a 21st century professional qualification has to be portable. Okay, so that's what I think the benefits of membership are. I'm not sure our marketing team would agree, but this is what they would say. So the membership benefits are largely around facilities, publications, and discounts. So for Egyptian doctors, that would be discount on the latest publications, books, medical titles, reduced fees for college events, and I know a lot of you do like to come over to the UK, and we've also got our congress in Dubai, which Joanna's going to talk about a little bit more later. And as strange as it seems, we do have a members' room which our members from wherever they are in the world have access to. I know when you're in London and you maybe just want to have a bit of a break, we've got a beautiful location. It's really peaceful. I think it's the largest public square in London, is it? Lincoln's Inn Fields? Okay, you can quote me on that if you like. And there's a members' room which you can access. And we also have meeting rooms, so if you need to go and meet with anybody, then there's preferential fees for access for members. I've put free in the blue box because obviously you're paying an annual fee, so they're not really free, but it's just to distinguish between that and if you're having to pay additional things. So I think the most important thing about these things in the blue box is this is about pushing information and pushing knowledge in your direction. So it isn't about you having to necessarily work so hard to find it and research and look where it is. It's that you will be getting the Clinical Radiology Journal. You'll be getting a quarterly membership publication. Newsletters, you'll be getting to member-only referral guidelines and monthly email updates. My aim is that our members outside the UK become sick of us, because I don't want members just to hear from us when it's time to pay their annual subscription. So that's a bit of an odd ambition. And lastly, one of my favourite things is to bust myths. So there's lots of myths, and people have lots of misconceptions out there in the world. And I think that one of them is how expensive it is to be a member of the RCR. So we've just put, there are a number of tiers and a number of categories that you can join. But essentially what we're saying here is for a very reasonable amount of about £40 or 833 Egyptian pounds per year, If you're a member in training, a trainee, then that's the membership for a year, £40. If you're a member but you're qualified with another organisation or another qualification, then it's £122. And if you've passed your final FRCR exam for members in Egypt for fellows, it's 2,665 Egyptian pound. So hopefully that's good news, and it's made a few of you sit up. And now I think I'm going to pass back to Joanna to continue to talk. Thank you very much. Shukran.
You know what? Looking at this, I would like to be member of the Egyptian Society and be a fellow from Egypt, because we pay 5 times this money. But anyway, that's fine. Thank you. I will accept the membership. And anyway, what else we can offer and what we can do is the RCR can give all of the educational resources that Tanya mentioned. If you go, it's kind of the misconception, because some of the resources are completely free and you can access them without any problems. The other resources, you need to register for them. So it's mainly to put your name and your email address, only for us to know who is using it. But if you do it, it still doesn't mean that you need to pay. So registration doesn't mean that you need to pay. It still can be free. I know that a lot of people stop at the level of the registration and didn't go any further. So go the step further and access the registration. Yes, that's true. That's true. Some of the lectures and some of the webinars are for the nominal fee, but you can always ask and find information for free. We also have a lot of recordings of the lectures from our previous congresses, which I found it really extremely useful, and also a good training program for the trainees. And something that you are not doing in your subspecialty, sometimes it's really useful as a general radiologist to revisit. So this is very good. Apart from educational resources, it will be courses. And as it was mentioned before, we will try to also do the courses here in Egypt, because we know how expensive it is to travel to UK. So Global Radiology Scheme is another one. CSER, that we haven't mentioned before. Global Radiology Scheme is the scheme for learning. So the idea is to go to UK and learn for 3 years. But then you have your decision. You can come back here with the new subspecialty, or you can go through the CSER pathway during these 3 years and become the fully qualified or fully recognized consultant in UK. CSER is the pathway that we talked before of the completion or recognition of your training here with according to the criteria in the UK. The other important thing that I would like you to visit is the audit library, because I know how difficult it is for people who don't do regular audits try to find the topic. In our audit library, we have over 100 different audits and different forms of the audits. So if you want to check something in your department or do any audit, which is really important, especially in the training, you will have all of the information there. And it's very easy to follow, especially in your first project. The other option is the iRefer, so we all know about the guidelines. And if you attended the radiation protection session, you notice that with a password and registration, you will have all of the guidelines open up to, I think, that Sunday night as part of this conference. The other guidelines, as the pediatric guidelines, they are open for everyone. But that's a way that we need to take it and talk about the guidelines later. And quality standard for the imaging. That's another thing big. We have our professional standards, and I know that every university, every hospital would like to go and find this information. So it's another way that it can help in your practice. And this is what I would like to encourage you to attend, that we really try to be global and cooperate with as many societies as possible, and especially with a Pan-Arab Society of Radiology. And this is the first RCR Global Congress, which will take place later this year in Dubai between 29th of September and 1st of October. And it will be a 3-day conference. But what is really important for us, that this is a cooperation and this is a partnership between our college and PARS. And this is the first Congress really that we're organizing together. And it will take place in the Intercontinental Hotel in the Festival City in Dubai. What we try to achieve is a state-of-art and the high-level lectures, all of the modern radiology. It will be a hybrid style with live streaming and on-demand access, which will be limited. So the full program will be as a face-to-face meeting. We will have the interactive conference app, but also we will have a pre- and post-conference RCR courses attached to the meeting. But what is really important and what we try to achieve is the partnership with PARS. So with preparation of the meeting, we have a joint faculty. We have a faculty from RCR and faculty from PARS. We have, for each module, we have 2 leads, one from our college and one from the Middle East. And from the session moderators, again, we have one from the region and one from the RCR. And I'm very pleased to say that Egyptian radiologists, they have a big numbers and they are very, very active in our scientific committee and as a module leads. So I hope that this will be a first global congress that we organize together. So please make the dates in your diary, and this is what we are going to do. So in the Congress, we will have streams. We will have 5 streams. Stream 1 to 3 will be a main lectures, and the stream 4 and 5 will be interactive sessions, smaller rooms. We will be having a PACS cloud, so if you have your iPads or the laptops, you can come and scroll through the cases. Then we will be working, discussing the cases together. And also we will have a selected workshops with the ultrasound biopsies, interventional techniques that you can register. And the important, I think, for everyone, not only for trainees, that we are calling for abstracts, calling for abstracts for a short scientific presentation, and also for a poster presentation. The deadline is 1st of April, so it's not much time to complete and submit the projects, but I think that it will be really, really useful to have as many presentations and posters to submit to us. So if you like to have any more information about the Congress, we have a lot of information on our stand. We also have the information about all of the learning possibility, learning hubs, and other possibilities that college can offer. And also, after the session and also tomorrow morning, we will have our great team sitting there and being on the stand. So if you have any questions, or if you like to discuss any topics or any ideas for the further cooperation, please come and see us. And I'm really pleased this time because you know that we organized, that we've done these previous RCR sessions with you, and it was a really, really great pleasure. But this time we have with us Tanya, who is our chief exec, and she's a medical director within the college. And also we have Patrick with us, who is the global manager for all of the global international project in the college. And this is really nice to have them with us here, because it means that we are just working together and we can push and progress any ideas or project that we can do it together. So please use them when they are here. So this is the invitation to the Global Congress and Radiology Driving Innovation. So we try to be really, really high level of the lectures. And this is the connection. Thank you.
Thank you so much. Thank you, Joanna. Thank you, Patrick. Thank you, Tanya. And for concluding the session, I'd like to accept some small gifts from the Egyptian Society.
First, this is for Joanna. Come back, Joanna. Come back. هذا هيصور حاجة؟
Tanya.
Well, you got a nice one, Patrick. Thank you very much. Thank you very much for attending the session. And please, you can visit the RCR booth next to the registration area. You'll find Patrick and Joanna and Tanya. They'll be waiting for any inquiries that you need. Thank you again, and thank you for the Royal College guys. We love you, and we're very happy to have you here.
دكتور تليفون الاثنين دايره منه العمده ما عرفش غير كلمه This picture. Thank you. مين هنا؟
ماجدة شادي فين؟
على شمال.
ماجدة شادي هنا؟ دي صح. يفتكك على الشمال؟ طب ما انت كده هتبقى بيقول على اليمين.
على شمالي انا بس شمالك تمام يا دكتور. تمام هو لسه
لا ما جاتش الدكتوره صح.
هم ما تجوش. طب وحضرتك فين؟
مش سحر مش جاي انا جاي.
بس خلاص تمام كده.
لو حد جه بقى اتفضل يا باشا.
انا اللي ابتدي. حاضر يا باشا. بسم الله الرحمن الرحيم. اهلا. لا دي سبيكر، دي سبيكر شديده دي سبيكر شديده قوي 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 دي قوي اوسع يعني. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. مرحب بيكم في جلسة الويمن ايميجينج سيشن. احنا طبعا متأخرين يعني ساعة وربع تقريبا، ساعة وربع. معلش، ما انتوا هتروحوا فين؟ ما احنا قاعدين يعني، ما وراناش حاجة يعني. فنرحب بيكم جميعا، ونرحب بالاخواتي الشير بيرسونز معانا هنا، والسبيكرز الفيري اميننت. وهنبتدي اول سبيكر الدكتورة نيفين شلبي، بروفيسور اوف راديولوجي عين شمس يونيفرسيتي، وهي طبعا من الناس يعني ويل نون ومشهورة بالبريست ايميجينج في عين شمس، وهتتكلم لنا على التريبل نيجاتيف بريست كانسر MRI features in comparison to other breast cancer subtypes with correlation to prognostic factors. طبعا كلنا we are eager to listen to Professor Niveen، وإن شاء الله بس أتمنى من كل السبيكرز to stick to the time. Thank you.
مساء الخير. Thank you Dr. Ashraf for the introduction. Chairpersons. هنتكلم النهارده عن ال triple negative breast cancer, the MRI features in comparison to other breast cancer subtypes, and the correlation to prognostic pathological factors. Triple negative breast cancer is actually a specific subtype of breast cancer that does not express estrogen receptors, progesterone receptors, or human epidermal growth factor receptor 2. It most commonly occurs in premenopausal young women under 40 years of age, and it accounts for approximately 15 to 20% of all breast cancers. It has special clinical features which are not really nice features. It is highly invasive with a short survival time. The mortality rate is 40% in the first 5 years after diagnosis. The time to relapse may usually in the non-triple negative, it can relapse after 5 years. But in triple negative breast cancer patients, it can occur in as early as 18 or 19 months. The mortality rate of triple negative cancer patients is within 3 months after recurrence, which is as high as 75%. It has a high metastatic potential, reaching about 46%. They have distant metastasis with a survival rate after mets only around a year or something. The distant metastases usually occur in the 3rd year after diagnosis, reaching the brain and the visceral organs, and it is prone to relapse, as we just said, that the recurrence rate is about 25% after surgery with a poor prognosis. A bit of a hint on the TNBC pathology. More than 90% of the basal-like breast cancers and triple negative present as invasive duct carcinoma with a high grade and a central necrotic region with obvious lymphocytic infiltration. The status of each receptor is considered to be negative if the expression is less than 10% and positive if it is 10% or greater. As for the HER2 expression, there is a semi-quantitative assessment method, 0 for no membranous staining, going through +1, +2, and +3, which is the strongest positive, where there is complete membrane staining in almost all of the tumor cells. Most of you know the molecular and immunohistochemical subtypes of breast cancer. There is a way of categorizing the breast cancer subtypes molecular-wise by the analysis of gene expression profiles by the complementary DNA microarray technology into luminal A and B. They are both ER positive. The basal-like and the HER2 positive all are ER negative, and 70% of the triple negative breast cancers are basal-like tumors. By immune histochemistry, they are divided into triple negative, ER negative, PR negative, HER2 negative, which is quite the basal-like in the molecular subtypes. The HER2 positive, which is HER2 positive, it might be ER and PR positive or negative, which are the HER2 positive molecular subtypes, and the ER positive, which are HER2 negative, and the PR may be positive or negative. This is the kindest type of cancers, which is the luminal one. Thank you. As for the imaging, I'll give an overview of the different modalities. In ultrasound, the most frequent manifestation is a unifocal mass with rather ill-defined and sometimes well-circumscribed margin. Might be hypoechoic, sometimes heterogeneous, but the most peculiar imaging feature is the posterior acoustic shadowing, and this occurs because of the intralesional necrosis that is very common in triple-negative cancer. In mammography, and actually this is one of our patients in the Mirdash hospital, she was a 30-year-old female with a palpable lump and a right upper outer quadrant mass that is rather rounded with obscured margin. Calcification is not so common in triple negative. It occurs in around 12 to 30% of the cases. This is the CC view. And the ultrasound, it was an oval, well-circumscribed mass. It was hypoechoic. And the biopsy was taken twice. The first biopsy was inconclusive, and the second biopsy came back with an invasive duct carcinoma grade 2, and it was triple negative. And I meant to put this case because I wanted to hint that the biopsy sometimes is not conclusive because of the heterogeneity of the mass and the heterogeneous look sometimes on the ultrasound. As for the dynamic contrast enhanced MRI, and this is a case from the literature, it is usually a unifocal. In this case, it is multifocal, but the usual is a unifocal mass intensely enhancing ring enhancement, and it is usually restricted in DWI. Because of this important type of cancers that we find in Egypt actually very commonly, we made a study a couple of years ago, and it was presented in the ECR about triple negative cancer, the MRI features. And we were aiming at determining the MRI predictors as well in the dynamic contrast enhanced and on DWI. We recruited about 185 female patients. We collected them retrospectively with 206 pathologically confirmed invasive breast cancers. And the MRI features that we studied were the tumor size, the shape, the margin, the internal enhancement, intratumoral, signal intensity on T2 weighted images, and the detectability by DWI. And we compared them to the other breast cancer subtypes. Out of the 206 invasive cancers, we had 20% triple negative, 47% ER positive, and 32% HER2 positive. They were all high grade. It was grade 3 in most of the grade 3 were triple negative breast cancer, and we had 3 mucinous cancers, and that explained the high signal intensity in the tumor in cancers other than triple negative. It was the triple negative were larger in size, reaching 25 millimeters, and most of the tumor in the 3 subtypes were unifocal. The majority of the lesions showed mass-like enhancement with no non-mass enhancement, And that was interpreted because DCIS is not common in triple negative cancers. The mass shape and margin in the triple negative was rounded shape with a rather smooth margin. And the internal enhancement, most of the cases, in about 61%, was rim enhancement in triple negative breast cancer. This is a bar chart just to show the different features. However, I just put it here to highlight the ADC value. The ADC value in triple negative breast cancer is higher than the other subtypes. They are all low. However, in triple negative, it is higher, and this is, of course, justified by the central necrosis and the decreased packing of cells in this type of cancer. In our study, we found type 1 curve more frequently than type 2 and type 3. We were expecting to see type 3. And this was not actually a technical problem. It might have been considered a technical problem if we did not put the ROI on the most enhancing part or on the ring enhancing part, but we made sure that it was there. However, the curve type was most of the time type 1. And this was explained by the heterogeneous biology of the tumor. This is one of the cases that was included. It's a 33-year-old female diagnosed with triple negative breast cancer. As you can see in the T2 weighted images, there is central increased signal intensity owing to intratumoral necrosis. The contrast enhanced axial T1 showed a ring enhancement, and it was a type 1 persistent rising curve. The diffusion, the DWI showed a restricted diffusion with an ADC value of 1.1. In the pathology, in the hematoxylin eosine, there was infiltrating masses of malignant cells, and there was a negative ER immunostaining. Another case, 53-year-old, however, this was an ER positive case. It was a recurrence after conserving breast surgery, showing homogeneous enhancement in the axial T1 with contrast and a washout curve. It was restricted in DWI with a lower ADC value, and this is just to hint that the ADC value in triple negative is higher than the other subtypes. In the hematoxylin eosine, it shows the malignant cells and a negative immune staining for the HER2. A 53-year-old woman who presented with a palpable mass in the left breast. This is a case from the literature showing the mammogram, rather rounded to oval mass with well-circumscribed margin, hypoechoic in ultrasound, and the very characteristic posterior enhancement with a peripheral vascularity, ring enhancing in T1, axial T1 with contrast, and the central high signal intensity with a metastatic ipsilateral lymph node. Another case from the literature, 62-year-old woman presented with a palpable lump in the left breast. It was lobulated with a posterior enhancement, heterogeneous in the T2 and homogeneously enhancing in the post-contrast axial T1. However, it showed very early and rapid washout in the subsequent dynamic sequence. So in conclusion to our study and the literature, the predictors of triple negative breast cancer on dynamic contrast enhanced MRI were to find a unifocal. They're usually unifocal. They are enhancing masses, and the pattern of enhancement is a rim enhancement. They are round, oval, or lobulated in shape. They have a well-circumscribed margin most of the time with a central high signal intensity on fat-suppressed T2 weighted images. They are relatively large in size. They take time, not take time, but they increase in size, and they are associated with a high incidence of necrosis with higher ADC values on DWI. So these features are beneficial in identifying triple negative breast cancer from ER and HER2 positive breast cancer subtypes. Why do we care so much to diagnose these types from the others? Because of the treatment. TNBC is particularly characterized by the lack of effective targeted therapy and hence unfavorable prognosis. As we all know, the HER2 positive breast cancer is not really doesn't really have a good prognosis. However, having a targeted therapy with Herceptin gives it some good, a good look. It is associated with the development of therapeutic resistance. And as a result, hormonal or trastuzumab-based treatments are ineffective in triple-negative breast cancer patients. Chemotherapy is currently the mainstay of systemic medical treatment. However, they have a worse outcome after chemotherapy than the other breast cancer subtypes. In one of the first slides, I highlighted tumor-infiltrating lymphocytes, that in the pathology, there are a lot of tumor-infiltrating lymphocytes in triple-negative breast cancer. Again, why is this important? Because there is a future for immunotherapy for those ladies with triple-negative breast cancer. And there is an increasing evidence of the role of tumor lymphocytic infiltrates in triple-negative with improved disease-free and overall survival rates with or without treatment. And it correlates with increased pathological complete responses. The PCR here stands for pathological complete response and not COVID PCR. The presence of tumor-infiltrating lymphocytes in the microenvironment of the tumor predict responses not only to neoadjuvant but also to adjuvant chemotherapy treatments, which gives a very big hope to those patients. A high number of TILs are prognostic and predictive of response to standard therapy. The immune system appears to play an active role in this subgroup, so directly targeting the immune system is one of the mainstays in therapy, including immune checkpoints inhibitors. I wouldn't go further in the details. Let's leave this for our oncology colleagues. However, the hope is rising high in the future of treatment of triple-negative breast cancer. And as long as we start a treatment, we look for the response to monitor the response of this treatment. Monitoring the response by mammography and ultrasound is there. It is easily doable and low cost. However, it has a low sensitivity. MRI with multiparametric and functional is the standard of care and should be the standard of care in monitoring treatment in neoadjuvant and adjuvant chemotherapy, and the metabolic activity by PET-CT as well. We had an event in Ain Shams University a couple of, like a month ago, about new targeted therapies for triple-negative breast cancer, and it seems very encouraging. As for the monitoring of neoadjuvant chemotherapy, pre-treatment MRI features, there are specific features even in the pre-treatment MRI that would give us a hint on the prognosis of this therapy. So I'll give you two examples from the literature, one in a 51-year-old woman who underwent pathological complete response, and in the pre-treatment MRI there was no increase T1, there was no high T1, T2 signal in the center of intratumoral necrosis, and it was not ring enhancing. Another case in a 36-year-old female who had intratumoral high signal intensity in T2 with a perilesional edema, which is the perifocal edema already is one of the bad prognostic factors in any cancer in the MRI, especially if it's a triple negative, and it was ring enhancing, and actually this lady did not go to PCR, and she had local regional recurrence and even liver metastasis. Are there future imaging tools? Yes, there are. There are multiple studies. A pilot study was done in the assessment of early response to neoadjuvant therapy in triple-negative breast cancer using amide protein transfer weighted chemical exchange saturation transfer MRI. And the reason for which I brought these two articles is that one of our young colleagues in Ain Shams University, now in MD Anderson, is sharing in this study and sharing in another study, monitoring the response to treatment in those cases where the pathology colleagues are responding with a tumor infiltrating lymphocyte, a robust number to predict response to neoadjuvant chemotherapy by MRI radiomic model. And as a conclusion, a predictive model combining pre-treatment MRI radiomic features with tumor infiltrating lymphocyte level on pre-treatment core biopsy improved accuracy in predicting PCR to neoadjuvant systemic therapy in triple-negative breast cancer. Thank you very much for your attention.
Thank you, Professor Naveen, for your outstanding presentation as you used to do.
You're most welcome, Dr. Magda.
Thank you so much. For shortage of time, we're gonna postpone questions to the end of the session. And now it's time for Dr. Aya Rawi, Canal University. Her presentation is correlation of histochemical biomarkers with imaging features of breast cancer.
Correlation of histochemical biomarkers and imaging features of breast cancer. The most common breast cancer molecular markers includes hormonal receptor, estrogen and progesterone receptors, HER2 receptors, which is a proton gene, and Ki67, which is a monoclonal antibody and can represent as indicator for the cell proliferation. According to the expression of these markers, we can divide the molecular subtypes into luminal subtypes, HER2-enriched subtypes, and triple-negative cancers. Luminal A are of the best prognosis. Luminal A cancers is positive for hormonal receptors, negative for HER2 receptors, and with low levels of Ki67. Luminal B also positive for hormonal receptors. It is either positive or negative for HER2 receptors with a higher levels of Ki67 and a higher grade than luminal A tumors. The luminal subtypes usually treated by the endocrinal therapy, which is a selective ER antagonist. Regarding HER2-enriched subtypes, it shows an amplification of the HER2 receptors and negative for hormonal receptors, and it shows faster growth than the luminal types and respond to a specific therapy, which is the Herceptin. Triple-negative tumors, as Dr. Naveen said, it is the worst for the worst prognosis, and it is the most aggressive. It is show negative for estrogen receptors and HER2 receptors, with the highest association of the BRCA mutations and treatment usually by the neoadjuvant chemotherapy. These differences in clinical behavior and the treatment response between the molecular subtypes require personalized management of breast cancer patients. Many recent published studies investigated the correlation between the imaging feature and the molecular subtypes of breast cancer. The imaging features of luminal subtypes include that is usually presented by irregular shaped mass lesion as shown here in the mammography with a speculated margin. The ultrasound of another patient also showing the same features with the presence of the posterior acoustic shadowing. MRI have the same features with irregular shaped mass lesions with a speculated margin. This speculated margin is usually explained by the presence of the desmoplastic reaction of the host against these slowly growing tumors. Regarding the HER2 positive cancers, it is usually presented with a calcification in the mammography. Here we can see in the mammography a cluster of coarse heterogeneous microcalcifications. Also, the same patient, MRI post-contrast showed and a non-mass enhancement. These features can be explained by the presence of the DCIS component in 60% of the patients. Also, the HER2 positive cancers usually presented by a multifocal or multicentric tumor, as we see here in the post-contrast of the right breast. And also, many studies revealed that the perilesional edema is more common in the breast cancer with HER2 positive receptors than negative for HER2 receptors. Triple negative subtypes include, usually presented by, it is a regular shaped mass lesion with a circumscribed margin and posterior acoustic enhancement. In MRI, it is usually presented by a high signal intensity in the T2 with peripheral rim of enhancement as shown here in the MRI post-contrast and higher grades of ADC values. These imaging features can be described by the presence of a central tumoral necrosis. About the role of the epigenetic markers, several studies indicated that the long non-coding RNAs plays an important role in the cancer progression. So these molecules can be considered as a potential biomarkers and therapeutic targets. One of the well-known RNAs is the ITGB1 that was reported to promote the cell proliferation and metastasis and may represent a valuable independent prognostic indicator for breast cancer. Here in South Carolina University, we investigate the MRI features correlation with the molecular subtypes and the epigenetic marker ITGB1 in 115 subjects. Our cases include a 65-year-old patient which presented with a left breast lump. Ultrasound revealed a hypoechoic subcutaneous mass lesion with indistinct margins and posterior acoustic enhancement as shown here. In the T2 MRI, it showed a rather isoechoic iso-intense signal intensity. And in the post-contrast subtracted images, there was a peripheral rim of enhancement. This patient was pathologically proven to have invasive ductal carcinoma grade 3, and the immunohistochemical biomarkers were in keeping with the triple negative subtype. ITGB fold change was 10.4, and of the imaging feature, the posterior acoustic enhancement in the ultrasound and the post-contrast rim enhancement with a possible skin invasion of the lesion, all of these features were in keeping of the triple negative subtype. Another patient which presented by hyperdense mass lesion in the mammography, in the ultrasound it showed a microablated margin and posterior acoustic shadowing enhancement. In MRI, there were two nearby smaller lesion which may represent satellites of the lesion, and in the T2 FAT-SAT images, there were mild perilesional edema. Also, in the post-contrast images, there was a rather heterogeneous enhancement of the lesion with the presence of the non-mass, linear non-mass enhancement component, also with a lower EDC values. This patient was pathologically proven to have invasive ductal carcinoma grade 3, and the immunohistochemical markers were in keeping with the HER2 enriched subtype. Epigenetic marker fold change was 8.5. Of the imaging features of the HER2 enriched cancer, the multifocality of the lesion and the linear non-mass enhancement and the perilesional edema were highly suggestive of the HER2 enriched subtype. This is another patient presented with a left breast lump. The mammography revealed an irregular mass lesion with the presence of the speculated margin as shown here. In the ultrasound, the same features. It was an irregular mass lesion with a speculated margin and posterior acoustic shadowing. MRI was done, and there was an irregular mass lesion with a speculated margin at the axillary tail. And after the post-contrast, in the post-contrast images, there was a heterogeneous enhancement. This mass was in keeping with invasive ductal carcinoma, and the immunohistochemical markers revealed luminal B HER2 negative subtype. Epigenetic markers was very high. Of the imaging features, the irregular shape, the speculated margin, the posterior acoustic shadowing, and the heterogeneous enhancement were all in keeping with the luminal AB subtype. Another patient presented with a right nipple discharge, and after the pathological examination, it reveals a malignant cells. The ultrasound reveals altered parenchymal echogenicity with the presence of the microcalcifications. MRI was done, and the post-contrast images and MIB images revealed a large regional area of non-mass enhancement with internal clumped pattern of enhancement. This patient was pathologically proven to be a ductal in situ mammary carcinoma, and the immunohistochemical markers were in keeping with the luminal B HER2 positive subtype. Epigenetic marker was 2.8. The microcalcifications and non-mass enhancement in the case may be explained by the presence of HER2 high expression of the HER2 receptors. Another patient presented with a large hyperdense mass lesion with a speculated margin in the mammography, and the same features were seen in the ultrasound with posterior acoustic shadowing. And after the MRI, there was a retroalular mass lesion with a speculated margin, and there was an evidence of nipple retraction. After the post-contrast subtracted images reveal a heterogeneous enhancement with the presence of the segmental non-mass component. This patient was in keeping with the invasive ductal carcinoma grade 2, and the immunohistochemical markers was in keeping with the luminal A subtype, epigenetic marker fold change with 0.9. Of the imaging feature, the irregular shape of the lesion and the speculated margin, posterior acoustic shadowing, and heterogeneous enhancement were in keeping with the luminal A subtype. Non-mass enhancement is represent an overlapping between the imaging features. Another patient with a left breast lump, it showed an ultrasound. It was rounded with rather circumscribed margins and posterior acoustic enhancement. In MRI, T1 images, it was a hypointense signal, and in the T2 images, it showed a high signal intensity. Post-contrast images reveal a peripheral rim of enhancement. It seems to look like that of the triple negative, but this patient is an exception. It is a mucinous mammary adenocarcinoma of luminal A type, and the fold change was 0.05. This exception of regular shaped mass lesion, circumscribed margin, and posterior enhancement with high T2 weighted image signal in MRI and rim of enhancement may be explained by the presence of the water content in the mucin. So we can consider the MRI is a reliable predictor of the molecular subtypes, especially triple negative cancers. However, till now, it cannot replace the molecular markers because of the overlapping of the imaging features. Also, despite of the significant correlation of the ITGB gene expression fold change in the malignant lesion when we compared it with the benign controls, our data couldn't prove a correlation between a specific MRI features of breast cancer and the ITGB gene expression. Thank you.
Thank you, Dr. Aya, for a very highly informative presentation. And now we will go to the next speaker, Dr. Shaima Hussein, Montefiore University. She will talk about the abbreviated MRI protocol for the breast.
السلام عليكم ورحمة الله وبركاته. النهارده شرفني إن شاء الله هتكلم عن abbreviated breast MRI protocols. Where are we? طبعا احنا breast cancer is second to lung cancer as the leading cause of death among women. Over 40,000 women were estimated to die of breast cancer in 2016. Early detection is the key to improved survival, and overall prognosis is directly linked to the stage of the disease at the time of the diagnosis. Breast magnetic resonance imaging offers a high sensitivity for breast cancer detection, and it has traditionally been used as a second-line imaging method to solve diagnostic problems in patients with equivocal findings on either mammography or ultrasound. With the use of breast MRI for screening has been increased in the past decade. According to the American Cancer Guidelines for breast screening for those with dense mammography, the role of MRI in breast cancer, as many papers are discussing this nowadays. The American Cancer Society recommends MR screening every year in addition to annual screening mammography for women who have a lifetime risk of breast cancer of 20 to 25% or greater, those with BRCA1 or BRCA2 genes, and those with positive family history. These are recommended to do an annual MRI. However, it was limited to screening high-risk patients. Its application in more general screening hindered by the high cost. And the high cost comes from the high fixed cost of the equipment acquisition, operation maintenance, and relatively throughout the examination duration. Another reason for the high cost is the fact that current breast MRI protocols are both time-consuming to acquire and to read. Typical MRI study occupies the MRI system for up to 40 minutes and generates several hundred images. The classic MR study is usually composed of a scout image or localizer, followed by a pre-contrast, including T1 weighted with no fat suppression for the fat and the glandular morphology, T2 weighted with fat suppression for detection of any bright fluid or cyst. High resolution 3D T1 weighted fat suppressed gradient echosequence, pre-contrast baseline image for identifying enhancing lesion, followed by the post-contrast 3 to 5 volume acquisition dynamic multi-phase in this sequence. The pre-contrast and post-contrast imaging must have identical image parameters to allow subtraction. Which sequence do we use for screening of all these sequences? MRI pulse sequence protocols used in different MRI screening trials conducted so far have varied widely. However, all mirrored the MRI acquisition protocols used for diagnostic purposes and at their respective study institutions, and hence hindered its use in general screening. The need for limited acquisition have been proposed for the development of such abbreviated MRI, both cost and time efficient without sacrificing the accuracy of the scan capabilities of detecting breast cancer. The first presentation of this idea was done by Cole in 2014 for abbreviated breast MRI, was using the first post-contrasted subtracted image maximum intensity projection. Abbreviated MRI increasingly being more performed and investigated for screening purposes, giving similar cancer detection as compared with the conventional full-length MRI in multiple recent studies, as you can see in this table. From 2014 till 2019, we have seen that the sensitivity is nearly comparable between the full protocol MRI and the abbreviated. Example of the abbreviated protocol includes an axial T2 with fat suppression, axial pre-contrast T1 with fat suppression, axial post-contrast T1 weighted with fat suppression, and axial post-contrast subtraction. Compared to the standard MRI protocols, we can see how many sequences there are, and the time is the conclusion. The total acquisition time is 4 minutes without the T2 weighted in the abbreviated protocol. With the T2 weighted image, it is 8 minutes in comparison to a total acquisition of 30 minutes of the full protocol. This is a small study I have done in 2019 for the abbreviated MRI protocol. Our objective of the study was for assessment of an abbreviated MRI protocol in comparison to the traditional. We done a retrospective review of 143 MRI examinations performed at our institution in this period by 2 radiologists. 2 sets of images were reviewed separately and blindly. The first set consisted of the proposed abbreviated protocol, consisted of the first post-contrast subtracted image and its MIB image. The second set was consisted of the full diagnostic protocol at our institution. Data were collected from each revision separately, including the findings and the time of the analysis. Significant reduction in the scan acquisition time was noted when using the abbreviated protocol, about 83% reduction. Detection of lesions on the abbreviated protocol took about 25 seconds in comparison to about 15 minutes when reviewing the full protocol. Of the reviewed 143 patients, 15 were malignant and 68 showed benign lesions and 60 were normal scan. Abbreviated protocol was able to detect all the 15 malignant lesions with a positive predictive value of 100%, and 66 out of the benign lesions with a 97% with a negative predictive value of malignancy reaching 100%. This is an example of our cases of female 52 years old presented by right breast lump. Here we can see the irregular shaped breast mass in the first subtracted image. Also, we can find that the left breast has 2 other masses. Another female patient, 44 years old, with positive family history, presented for screening purposes. Here we can see a clumped mass enhancement presented at the right breast. A biopsy proved fibroadenosis with no atypia. However, we can able to reassure the patient. Female patient, 47-year-old, with mammographically dense breast, presented for another screening. Here we can see an irregular lesion at the right breast. That is segmental non-mass enhancement in the MIB image. Conclusions: the abbreviated protocol consisted of the first post-contrast subtracted image and its MIB is raising grades of protocol, particularly for screening purposes, since it showed marked reduction in scan time as well as the reading time with nearly equal detection rates of different breast lesions. How about a new term? It's been also considered a good negative scan that can be used for screening of high-risk patients. Another term that has been introduced recently is the ultra-fast. What it differs from the abbreviated. Ultra-fast is not necessarily a component of the fast MRI or what is called the abbreviated MRI, but is a novel sequence developed to capture early contrast material wash-in at a high temporal resolution, typically of less than 6 to 7 seconds. An ultra-fast sequence allows rapid sequential imaging within the first 2 minutes after contrast material injection to render an early wash-in kinetic curve. We usually depended on the meter. However, newer terminology was introduced by the ultra-fast MRI, which is time to enhancement, maximum slope, initial enhancement rate, and arterial venous interval. Time of enhancement is measured from the time of the aortic enhancement and reflects how early a lesion enhances. This is defined here by the 0 seconds time where the aorta enhances, and we can see the enhancement of the lesion at this 5 seconds and 15 seconds. This what draws the early wash-in curve. Maximum slope is the upslope of the time intensity curve, or the slope of the relative enhancement versus time curve expressed in percent per second, and reflects how rapidly a lesion enhances. This is an example of two highly enhancing mass lesions that were malignant, and we can see the upslope of the curve is by percentage. This is another example comparing the malignant curve and the benign lesion curve with the maximum slope. Another term is initial enhancement rate, which is defined as the early post-contrast signal intensity divided by the pre-contrast signal intensity, and reflects the level of the lesion enhancement or how avidly the lesion enhances. It represents the enhancement as a percentage, as we can see against the time point. The last one is the arteriovenous interval, which is the interval between the arterial and the venous visualization of the supplying the breast. The shorter AVI is associated with a disordered vascular network prone to shunting, especially the leaky vessels for tumor angiogenesis. This is an example for the timing. The artery, the visualization of the artery is earlier than the visualization of the vein, and then the timing of the vein minus the timing of the artery depicts the conspicuity of the lesion. Thank you.
Thank you, Dr. Shaimaa Hussein, for your very nicely elaborated presentation. And now we'll call for the next speaker, Dr. Rania Farouk. She's a dear colleague from Cairo University, and she is one of the pioneer, if not the real pioneer in pelvic floor imaging. And she will be discussing with us the advances in anorectal dysfunction, imaging, and reporting. Dr. Rania, ready?
Yes, I'm
okay.
مش عارفة مش واصلة ليه.
اوكي. مساء الخير. طبعا احنا كلنا تعبانين، بس خلينا نفصل بقى من البريست ونخش على ناخد ريست كده من البلفيك، من البريست نخش على البلفيك فلور. هي دي فرصه ان احنا الفيرست بارت من البرزنتيشن هي بيزكس، وبعد كده هقول لكم على الادفانسمنت اكوردنج للنيو جايد لاينز، فصحصحوا معايا كده دي هنقلبها بسرعه ونروح. اوكي. اول حاجه انا لما ببتدي بفضل الاساتذه بتوعي في القصر العيني واللي فتحوا لي المجال ان انا اشتغل في الام ار اي بلفيك فلور من سنه 98، وعلى راسهم دكتور يحيى متعالي الله يرحمه اللي علمنا اول حاجه كونفنشنال ديفيكوجرافي. I fell in love exclusively مع MRI من 98 وعملت as a staff in Cairo University. I was contributing to one of the diagnostic imaging، واهم حاجه من اللي انا بفخر بيها انه on behalf of Cairo University we put the guidelines, the European guidelines of MR imaging of the pelvic floor، وكنت فخوره جدا ان احنا صممنا ان احنا نكتب from one Egyptian and 7 European institution، ودي تعتبر حاجه لكل ايجيبت وكايرو يونيفرسيتي as الاند مارك. طيب الليرنينج اوبجكتيف بتاعتي النهارده ان انا اوصل لكم معلومه عن الراديولوجيست رول، ان احنا لازم نديفلوب كونستراكتد سمبل لانجويج ثرو ويتش ذا راديولوجيست كان افكتفلي كوميونيكيت ايمجينج فايندينجز. يعني لو انتوا عايزين تبتدوا تشتغلوا في البلفيك فلور لازم تفهموا تكلموا الكلينيشن ازاي، وقبل كده تو انتربريتيت البيشنت كومبلين. بمعنى ايه؟ بمعنى ان لما هتبتدي تشتغل في الانوركتال ديسفانكشن، لما يجي لك عيان يقول لك انا عندي امساك اللي هو الكونستيبيشن اتس نوت ايكوال تو اوبستراكتد ديفيكيشن. امال ايه الفرق؟ الكونستيبيشن ده infrequent defecation ومعاه ان هي less than 3 bowel movement per week. ده من الهيستوري تبعته في الموتيليتي ديس اوردر، ما يخشلكش ام ار اي pelvic floor. مين اللي هيخش لك بقى الام ار اي pelvic floor؟ هو ده اللي عنده obstructed defecation، الاوتلت obstruction disorder resulting in difficulty evacuating stool from the rectum. يعني تقول للبيشنت انت لما حضرتك بيجي لك الارج لما بتخش التويلت بتبقى obstructed، هيقول لك obstructed. This is for MRI. دي اول حاجه تعرفوا منها العيان اللي هتاخدوه عشان تعملوا له ام ار اي بلفيك فلور. نمبر 2 هتقولي طب دكتوره رانيا ده posterior compartment، فليه احنا عندنا 1 compartment هنعمل ليه بلفيك اورجن، هنعمل ليه ام ار اي 3 compartment ليه؟ عشان احنا دلوقتي اتبنينا فكره ان البلفيك سي كومبارتمنت بيورك از 1 يونت. ده الاندوبلفيك فاشيا، ده الانال سفنكتر، بعد كده هتظهر البيوبوريكتاليس، وبعد كده هتظهر الإليكوكسيجياس ماسل. always remember انه كل دول بيشتغلوا as 1 unit، ويوجولي بيبقى 1 compartment associated with middle او posterior، والموست كومن بيبقى الانتيريور والبوستيريور. تمام؟ فكده احنا حلينا مشكله ليه هنعمل ام ار اي لو العيان جايب 1 كومبلين. بعد كده هنعمل ريفيو صغير على البلفيك فلور. pelvic floor term is not equal للبيوبوريكتاليس ماسل. امال ايه هو البلفيك فلور؟ البلفيك فلور ده متكون من السفنكتر ميكانيزم بتاع اللور يورينري تراكت، الابر واللور فاجينال سبورت سيستم، والانترنال والاكسترنال انال سفنكتر. ده كل ده الكومبوننت اوف البلفيك فلور. لما تبتدي تشتغل في البلفيك فلور عندك 3 ماسل رئيسيين هم دول اللي انت تبص عليهم. اول واحده البيوبوريكتاليس ماسل، وبعد كده البيوبوكسيجياس ماسل، والإليكوكسيجياس ماسل. دول الثلاثه اللي انا عايزاك تفتكرهم لما تيجي تشتغل في البلفيك فلور. هنبص عليهم في الاكزيال وبعدين هوريهم لكم في الام ار اي. دولت البيوبوريكتاليس، بيوبوكسيجياس، والإليكوكسيجياس. ما يهمنا احنا هم بيبانوا ازاي في الام ار اي. عشان تشوف البيوبوريكتاليس ماسل هتروح في الاكزيال وتبص على الماسل اللي هي اليو شيبت اللي بتلف حوالين اليوريثرا فاجينا اند ريكتم. طب البيوبوكسيجياس اعرفها ازاي يا دكتوره رانيا؟ هتروح ات لور ليفل ولاند مارك عندك انها هيبقى ليها اتاتشمنت ورا على الكوكسكس، فده يفرق لك البيوبوريكتاليس من البيوبوكسيجياس. لو عايز تلاقي الإليكوكسيجياس ماسل هتطلع فوق مور كرينيال وتبص على الإليو على الاوبتريتور انترنس، ده الليفل بتاع الإليكوكسيجياس ماسل. كويس؟ كده احنا عملنا البيزكس على الاناتومي. هديكوا بقى بعد كده على الام ار اي بروتوكول. اول حاجه احنا عندنا ستاتيك بارت، ده بنشوف فيه الاستراكشر، وفي الدايناميك بارت متكون من جزئين اللي هو الام ار ديفيكوجرافي والسيني ام ار اي. بنشوف ايه في كل واحد؟ في الاكزيال ستاتيك بنشوف الانال سفنكتر، كويس؟ وده مش هناخده النهارده، مالناش دعوه بيه. الدايناميك ايمجز اللي هي هنا دي، الجزء ده بنشوف فيه الماسلز اللي هم الثلاثه اللي انا قلت لكم عليهم، بنشوفهم هل هم سترونج ولا فيهم ويكنس، ودول برضو مش هنشوفهم النهارده. امال هنشوف ايه؟ هنشوف الديفيكوجرافي. اوكي ليتس جو. طيب الديفيكوجرافي اول حاجه عشان تعرف ان انت عامل ديفيكوجرافي حلو لازم تعرف ان العيان بيعمل ماكسيمم ستريننج، لازم تشوف الانال كانال اوبن وتبقى شايف الثلاثه كومبارتمنت ان وان سيكشن. خلاص؟ طيب هل ينفع نعمل ام ار اي ديفيكوجرافي بلفيك فلور من غير ايفاكيويشن؟ نوت اني مور. لا تقدر تسجست ولا تقدر تقترح ان هو يبقى ستريننج بس. ليه؟ اول حاجه ده ديورنج الستريننج لو لقينا هنا البي سي ال لاين هتلاقي ان العيانه ستريننج ومفيش اي حاجه عندها. لكن لما عملت ايفاكيويشن ايه اللي حصل؟ في سيستوسيل، في ريكتوسيل، في الانوريكتور جانكشن ديسنت ماركدلي داون. طيب هل احنا سكتنا على كده؟ لا، عملنا فيرذر ريسيرش واثبتنا ان حاله زي هنا العيانه هنا عندها سيستوسيل during maximum straining، وفوجئنا ان في during الايفاكيويشن ايه اللي ورا ده منظر الريكتال برولابس. لما تبتدوا تشتغلوا هتشوفوا ان ده ريكتال برولابس، توتال ريكتال برولابس. فطبعا هنا لهنا complete different story for the surgical repair. الكلام ده بقى دوكيومنتد باهم 3 بيبرز اتعملوا في الجايد لاينز 2017 و2019 والكونسورشيوم اللي هقول لكم عليهم دلوقتي. خلاص it is not choice anymore تقول اعمل ستريننج ولا ايفاكيويشن، not accepted. تمام؟ ومحدش من السيرجن هيقبل منك فحص في اي مركز لو مش عامل ايفاكيويشن. طيب all in all الديفيكوجرافي بنبتدي بنعمل بيه الديسنت بتاع البلفيك اورجن، تمام؟ وبنبص على الانوريكتال ديسفانكشن اللي هقول لكم عليهم دلوقتي. احنا من اول حاجه بناخد البي سي ال وبنقيس الديسنت اوف البلفيك اورجن من اول البلادر واليوترس وبعد كده الانوريكتال جانكشن، ونروح نملاها في تمبليت زي ده. وده اتنشر في 2020 في الكلينكس اوف نورث امريكا، اللي هو البيبر دي اخر بيبر ليا في 2020، ممكن تجيبوا منها التمبليت ده. نروح بقى نملى التمبليت بتاعنا ونشتغل على الحته دي. احنا النهارده هنقول الانوريكتال ديسفانكشن دي، تمام؟ اوكي ليتس جو. الام ار ايمجنج في بلفيك فلور هو بيانسر كلينيشنز نيد، والاحلى بقى منه ان هو بقى يدينا ديتيلز على البوستيريور كومبارتمنت جميله جدا، فرقت معاهم قوي.
according للfunctional defecatory disorder spectrum of abnormalities احنا قسمنا الموضوع ده ل يعني جروبس كده، واكوردنج للجايد لاينز دي الحمد لله القصر العيني كان بارت في الثلاثه جايد لاينز، وممكن تاخدوا سكرين شوت اللي عايز يبتدي يشتغل pelvic floor في اي مستشفى. الثلاثه دول اهم ثلاثه بيبر جايد لاينز اتنشروا لغايه دلوقتي. خلينا نشوف بقى الكونستيبيشن. احنا بنقسم الكونستيبيشن لسيمبل او سكندري كونستيبيشن، واللي يهمني هنا الاوتلت اوبستراكشن اللي شرحت لكم اهميته. نعمل زوم بقى على الاوتلت اوبستراكشن ونشوف هو سببه ايه. ده بيكون سببه يا حاجه ستراكشرال يا فانكشنال يا بوث. بمعنى ايه؟ ان الاستراكشرال ده بتكون زي الحاجه اللي بنشوفها ريكتوسيل او الريكتال انترسبشن وبقيه الليسته. الفانكشنال ده هو اللي جديد قوي، اللي هو السباستيك بيوبوريكتاليس، واللي اجدد منه السباستيك انال سفنكتر. هنشوف دلوقتي هنشوفهم ولا لا. او حاجه بتجمع الفانكشنال والاستراكشرال، حاجه اسمها سوليتري ريكتال ألسر سندروم، ودي مش موجوده النهارده ما تقلقوش. نيجي نشوف الحاله دي مع بعض ونشوف العيان ده بيشتكي من ايه. دلوقتي ده during الايفاكيويشن، واحنا قلنا ان احنا لازم نشوف الايفاكيويشن بتاعنا عامل ازاي ونبص على الانال كانال during opening. انا كنت بقول في مؤتمر في الجهاز الهضمي والناس والجراحه انبسطوا قوي ان انا حطيت الهيستوري بتاع العيان، وقالوا لي اتعلمت منهم يعني ان اكتر علامه ان العيان ده عنده ترو اوبستراكتد ديفيكيشن لما يقول لك ان انا عندي اوبستراكشن ايفن وذ سوفت ستول. دكاتره الجراحه اكدوا قوي على النقطه دي، ان ده معناه ان هو از ريلي اوبستراكتد مع السوفت ستول. لما جينا عملنا اناليسيز للعيان ده في الاوبستراكتد ديفيكيشن، بنعمل اناليسيز اوف الانوريكتال انجل، البوستيريور انوريكتال انجل، اكيد كلكم سمعتوا عنها تمام. المفروض النورمال انها تبقى اكتر من تبقى كومبليتلي مور اوبتيوس في الايفاكيويشن. العيان بقى ده اللي هو اوبستراكتد ايفن فور سوفت ستول، لو جينا شفنا البوستيريور انوريكتال انجل بتاعته اخبارها ايه؟ دي اوبتيوس ولا اكيوت؟ اكيوت. يبقى الدايجنوز بتاعكم ايه؟ دكتوره ماجده حضرتك بتشتغلي كونفنشنال ديفيكوجرافي، فاستني عشان نقول لهم هم. واتس يور دايجنوزز؟ سباستيك بيوبوريكتاليس. خلاص تمام. طيب الجديد بقى ان انتوا ما فيش داعي تدعبوا نفسكم بالميجرمنت، لان اكوردنج للجايد لاينز هو قال لك ان الباترن اوف التشينج هي اللي مهمه مش الابسوليوت فاليو. يعني الانجل بتفتح وبتقفل يبقى ده نورمال، لو هي بيرزيستنتلي اكيوت يبقى ده سباستيك بيوبوريكتاليس، ولا من 90 ل 100 ولا من 110 ل 50. اوكي. طيب بعد كده الحاله الثانيه اللي معانا النهارده هنبص عليها، هنبص على البوستيريور انوريكتال انجل. لقينا تغير غريب جدا، مش بقت موضوع انها بقت اكيوت او اوبتيوس، لا ده الانجل بلجنج صح؟ يعني بتخش لجوه. فده اسمه ايه بقى؟ تفتكروا ده بارادوكسال كونتراكشن للبيوبوريكتاليس ماسل. يبقى الاولاني كان سباستيك ودوت بارادوكسال. بعد كده الحاجه الجديده او اجدد حاجه في الكلاسيفيكيشن اللي هي المنظر ده. بصوا على الارو اللي هيطلع دلوقتي. شايفين الانال كانال قد ايه ضيقه؟ طيب يبقى الدايجنوز بتاعكم ايه؟ ثانك يو. سباستيك انال سفنكتر، او الاسم الجديد بقى سفنكتر اكيليزيا. هتلاقي دي اول مره تعرفوها النهارده. تمام. اوكي خلصنا الفانكشن وخلصنا مش هنقول السوليتري ريكتال، فاضل لنا اخر حاجه الانترسبشن. هقول لكم الانترسبشن بنقسمه لريكتو ريكتال يا اما ريكس. الخبر الجديد ان البلفيك فلور كونسورشيوم قال ما تقولوش اي حاجه اكتر من ان الريكتال انترسبشن بريزنت ولا ابسنت والتايب بتاعه. الناس بتسهل على نفسها جدا والسيرجن وافقوا على هذا الكلام، وهقول لكم الخلاصه. ده الاكزامبل، رايكم ايه؟ هل المنظر ده ايكويفالنت للي انتوا شفتوه فوق؟ ده ريكتال برولابس؟ ده سوري ده انترسبشن؟ لا، امال ده ايه بقى؟ ده ريكتال برولابس صح؟ لو مش يعني في الساجيتال مش باين قوي، روح للكورونال هتلاقي ان ده الإليكوكسيجياس والبيوبوريكتاليس، ودول التو دبل وول بتاع الانترسبتم والانترسبينت. فده الكونكلوجن اوف ريكتال برولابس. يبقى الام ار اف بلفيك فلور تو سم اب ده ستاتيك ام ار ايمج بسوفر ستراكشر، والكايناتيك بكل الجايد لاينز الجديده سهلت قوي علينا البوستيريور انوريكتال ديسفانكشن. الكومبايند اناليسيس اوف ام ار اي هو اناليتيك ابروتش دايما بيخلي الراديولوجيست يكريتيكلي شير ان ذا ديسيجن ميكينج، وعمرك ما هتقدر تشير في الديسيجن ميكينج غير لما تادرس الكلينيشن نيدز. It's my pleasure من هنا في الجمعيه المصريه للاشعه ان انا اعلن ان كايرو يونيفرسيتي عملت سنتر اوف اكسلنسي اوف البلفيك فلور، وانا I'm honored ان انا ابقى الهيد بتاعته في 15 في 2020 في سبتمبر 2020. وده عشان الانترناشونال اورز اللي احنا اخدناها من اول 2003 لغايه 2020. It's my pleasure to announce for all of you ان احنا نزلنا الاديشن الجديده بتاع Diagnostic Imaging. And as I started with 1989, this was me in a resident. We built a unit in pelvic floor with a new crew, and from 2003 to 2020, I have been traveling through all the continent to be part in the most important guidelines of the MRI pelvic floor in behalf of Cairo University. And as I started my lecture بالأساتذة أفضل اللي هم كان ليهم أفضل عليا في البداية، دايما بنهيها بشكر لأساتذتي في القصر العيني في كايرو University because they always have been helping me to establish this and to reach my goal to have the pelvic floor center of excellency research lab في كايرو University، وتشرفونا في أي وقت for أي research أو teaching. Thank you.
Thank you, dear Dr. Rania, for the excellent presentation as usual. Next speaker, before introducing the next speaker, I would like to welcome you all in my little nice city. Welcome. And next speaker is Dr. Yumna Reda, one of our young colleagues in the Suez Canal University. She will give us a talk about the International Endometrial Tumor Analysis Guidelines in Endometrial Assessment.
Today, we will talk about the sonographic assessment of the endometrial pathology using the International Endometrial Tumor Analysis (IETA) guidelines. I'd like to extend my appreciation and everlasting thankfulness to my supervisor for their support, valuable suggestion, and guidance during the conduction of this work. First of all, we have to know what is meant by the IETA. The International Endometrial Tumor Analysis Group was established in 2008 at the World Congress of Ultrasound in Obstetric and Gynecology in Chicago, and aimed to agree on nomenclature that describes the sonographic features of the endometrium and the intrauterine cavity, and to formulate a standardized technique for the assessment of the endometrial thickness and the intracavitary lesions. The IETA statement includes standardized terms, definition, and measurement that have a general approval, and it utilizes the grayscale, color Doppler, and sonohysterography. The grayscale assessment includes qualitative assessment and the quantitative one. At the qualitative assessment, we assess the endometrial pattern and echogenicity, the endometrial midline, and the endomyometrial junction. But at the quantitative one, we assess the endometrial thickness, the endometrial and the intrauterine lesions, and the intracavitary fluid assessment. First of all, the qualitative assessment. The endometrial pattern may be uniform or non-uniform. The uniform endometrium, or in other words, the three-layer pattern, may be hypoechoic, hyperechoic, or isoechoic. The non-uniform endometrium، احنا نقصد بالنون يونيفورم اندوميتريوم اللي هو الاندوميتريوم اللي هو ليكينج 3 لاير باترن او 3 لينير باترن المعروف بتاع الاندوميتريال ميدلاين والتو انترفيسز بتوع الاندوميوميتريال جانكشن. The non-uniform endometrium is further subdivided into homogeneous non-uniform endometrium and heterogeneous non-uniform endometrium. The homogeneous non-uniform endometrium may be without cystic spaces, with regular cystic spaces, or with irregular cystic spaces. The heterogeneous non-uniform endometrium may be without cystic areas or with cystic areas. The endometrial midline may be linear and regular, irregular, or not defined. The endometrial midline, the endomyometrial junction or the junctional zone may be regular, irregular, interrupted by the presence of endocavitary lesion, or not defined. At the quantitative assessment, we assess the thickness of the endometrium, whether it is measurable or not. If we can measure the endometrium, we measure it at the maximum EP diameter and report it in millimeter. If the endometrium is extremely heterogeneous and the endomyometrial junction is ill-defined, we can report it as not measurable according to the AITA descriptor. بمعنى بسيط ان انا لو عارفه اقيس الاندوميتريوم وفي well-defined endometrium او homogeneous والاندومyometrial junction well-defined وقادره اقيسه ممكن اقيسه. طب افرض ان انا مش عارفه اقيس الاندوميتريوم والاندومyometrial junction ill-defined وفي نفس الوقت الاندوميتريوم heterogeneous هعمل ايه؟ فريبورت it as not measurable according to the AITA descriptors. We also have to comment on the bright edge, whether it is present or absent. And the bright edge means that the interface between the presence of endocavitary lesion and the endometrial surface. بمعنى لو في endocavitary lesion سواء كانت مايوما أو بوليب وعاملة bright edge مع endometrial surface دي بنسميها bright edge ولازم نقيس الليجن في 3 dimension وريبورت برضو في بالمليمتر. The intracavitary fluid assessment, whether it is present or absent. And if there is endocavitary fluid, we have to measure it at the maximum EP diameter and report it in millimeter also. Here the endometrial thickness will be the sum of the thickness of the two endometrial strips separated by the endocavitary fluid. يعني أنا لما يكون العيانة عندها endocavitary fluid لازم أريبورت الثيكنس بتاع الاندوكافيتري fluid ده لوحده وأريبورت الثيكنس بتاع الاندوميتريال لوحده بإن أنا بجمع التو thickness بتاع الاندوميتريال strip separated by endocavitary fluid. We also have to comment on the echogenicity of the intracavitary fluid, whether it is anechoic or ground glass. The color and power Doppler assessment include color Doppler scoring system and the vascular pattern assessment. The color Doppler scoring system depends upon the amount of the color flow. If there is no color flow, the score will be 1. If there is minimal flow, the score will be 2. If there is moderate flow, the score will be 3. And if there is abundant flow, the score will be 4. The vascular pattern depends upon the type of the crossing myometrial blood vessels into the endometrium. Single crossing blood vessel without branching, or in other terms, the pedicular artery. Single crossing myometrial blood vessel with branching. Multiple crossing myometrial blood vessel with a single focal origin within the myometrium. Or multiple crossing myometrial blood vessels with a multiple focal origin within the myometrium. Scattered blood vessels with no definite myometrial origin and circular flow as in cases of myomas. The sonohysterography is a qualitative assessment of the endometrial morphology and the intracavitary lesions, and the assessment of the endometrial morphological feature and the intracavitary lesion is done using the same technique as described before regarding the grayscale and the color Doppler. The sonohysterography descriptor include the endometrial thickness, the endometrial outline, and the presence or the absence of intracavitary lesion. وأنا بعمل assessment لو لقيت endocavitary lesion, I have to determine the origin of the lesion, whether it is endometrial or myometrial. The endometrial outline at the sonohysterography may be smooth, polypoidal, multiple endometrial folds or finger-like projection within the myometrium, irregular, and the irregularity may be focal or diffuse. The intracavitary lesion at the sonohysterography, as we illustrated before, may be of endometrial origin or myometrial origin. At the endometrial one, we assess the extent of the lesion, the type of the localized lesion, the echogenicity, and the outline. At the myometrial lesion, we assess the echogenicity of the lesion, the grading of the lesion, and the measurement of the lesion. The extent of the endometrial lesion at the saline sonohysterography depends upon if the base of the lesion involves less than 25% of the endometrial surface, this is called a localized lesion. And if the base of the lesion involves more than 25% of the endometrial surface, this is called an extended lesion. The localized lesion is further subdivided into pedunculated and sessile lesion, and this is dependent upon the AP ratio. The A is the maximum transverse diameter at the base of the lesion, and B is the maximum transverse diameter at the apex of the lesion. If we divide A by B, if the ratio is less than 1, this is called a pedunculated lesion. And if the ratio is more than 1, this is called a sessile lesion. The outline of the lesion at the sonohysterography, or when there is a pre-existing fluid in the uterine cavity, may be smooth or irregular. The grading of the myometrial lesion at the sonohysterography depends upon the degree of the protrusion of the myometrial lesion within the endometrial cavity. If it is 100%, this gives grade 0, more than 50% grade 1, and less than 50% grade 2. All cases were carried out at our institutes at South Canal University hospitals. 45-year-old premenopausal multiparous women presented with perimenopausal bleeding for 3 months. At the grayscale assessment, here we found that the endometrium is thickened, the endometrial midline is not defined, and the endomyometrial junction is well defined. After the saline sonohysterography, we found that there is endometrial lesion which is extended according to the AITA descriptor, as it involved more than 25% of the endometrial surface. The outline of the lesion is smooth, and the outline of the endometrial cavity is also smooth. The color Doppler assessment revealed minimal blood flow, giving score 2. And the vascular pattern is single crossing myometrial blood vessel without branching, or in other terms, the pedicular artery. All of the previously described features were in keeping with endometrial polyp, and the histodiagnosis was in keeping also with endometrial polyp. 59-year-old post-menopausal multiparous women presented with heavy vaginal bleeding for 7 months. Here, the uterus is seen bulky with distorted uterine architecture by multiple uterine lesion or myomas. Here, the endomyometrial junction is interrupted by the presence of endocavitary lesion or the bright edge. Here, the endometrial midline is interrupted there and maybe well defined there. After the saline sonohysterography, we found that there is a protruding myometrial lesion within the endometrial cavity, which is extended according to the AITA descriptor, as it involves more than 25% of the endometrial surface. The outline of the lesion is smooth, and the grading is more than 50% protrusion, giving grade 1. By the color Doppler assessment, there is moderate blood flow, giving score 3, and the vascular pattern is single crossing myometrial blood vessel with branching. And although this is atypical for the submucous fibroid, the histodiagnosis was in keeping with submucous fibroid. 64-year-old postmenopausal multiparous women or hormonal replacement therapy. Here we found that the endometrium is thickened, echogenic, homogeneous, uniform with regular cystic spaces. The endomyometrial junction is well defined, but the endometrial midline is not defined. At the saline sonohysterography, this is the palon of the castor, and here we found a focal protrusion within the endometrial cavity. The lesion, according to the AITA descriptor, is a localized lesion, as the base of the lesion involves less than 25% of the endometrial surface. The outline of the lesion is irregular, and the outline of the endometrial cavity is irregular also. By the color Doppler assessment, there is minimal flow, giving score 2, and the vascular pattern was multiple scattered myometrial blood vessels with no definite origin. Histodiagnosis was simple endometrial hyperplasia with cystic dilatation without atypia. 64-year-old postmenopausal multiparous women presented with heavy vaginal bleeding. Here, we found that the endometrium is homogeneous, uniform, without cystic spaces, the endometrial midline is not defined, and the endomyometrial junction is not defined also. After the saline sonohysterography, we found that there is endometrial lesion which is extended, as the base of the lesion involves more than 25% of the endometrial surface according to the AITA descriptors. The color Doppler assessment show abundant flow, giving score 4, and the vascular pattern was multiple crossing myometrial blood vessels with multiple focal origin within the myometrium. Histodiagnosis was endometrial adenocarcinoma. In our experience, terms to describe the endometrium sonographic features previously reported by the AITA group is clinically valuable and reasonable regarding grayscale and sonohysterography. The endometrial color flow scoring had an equivocal clinical value, طبعا لأنه هو completely subjective and they need to be revised. Sonohysterography appeared to be more valuable than the grayscale in the diagnosis of intracavitary masses, especially polyps والمyoma. Sonohysterography is also helpful if there is a disparity between the finding on the transvaginal ultrasound and the endometrial biopsy in cases with focal endometrial pathologies. بمعنى لو العيانة أخذت biopsy وطلع فيها endometrial polyp بس أنا عملت بالجراي سكيل العادي جدا الالتراساوند وما كنتش شايفه اي فوكال ليجنز، ساعتها ممكن نعمل السونوهيستروجرافي فهنشوف البروترودنج بوليب ونحل الازمه او الكونفليكت ما بين الترانسفاجينال التراساوند وما بين الهيستودايجنوزس ريزلت. We are planning to develop risk stratification model to see if any of the AITA ultrasound feature help in predicting the endometrial malignancies. Thank you for your attention.
Thank you, Dr. Yomna, for your very informative presentation. And now any question for the speakers? Any question? No more question. Dr. Ashraf here.
Okay. Start with our first speaker, Professor Naveen. I would like to ask about, you talked about the MRI features, cancer subtypes and so on. And do you use how frequently you use it, the MRI for the diffusion imaging as well as the spectroscopy? I'm raising this question because I've been asked many times about the usefulness of the diffusion weighted imaging and the spectroscopy in assessing different forms of breast cancer subtypes. Dr. Naveen.
Thank you, Dr. Ashraf, for your question. For the diffusion weighted images, we have it. We have the sequence in the routine MRI protocol in our institution. For the spectroscopy, we do not use it except in research purposes.
So you consider it, the diffusion is an integral part of the study?
Yes.
Okay.
Yes.
Thank you. This
You're
was
welcome.
the first question,
Thank
Dr. Naveen. Thank you. You have time? I will ask one question for each of our speakers so that, you know, just to enrich the discussions. Dr. Aya, histological biomarkers with imaging features of breast cancer. As you know, Dr. Aya, the BIRADS 5th edition talked about the calcifications, and we don't use anymore the descriptor microcalcifications. Instead of, we use the suspicious morphology. And I would like just to raise this issue because I've seen many of our speakers talking about microcalcifications. This was in the old era, yes, I agree. But now they are talking about calcifications, morphologically suspicious. And as you know, the amorphous, the fine pleomorphic, and the heterogeneous, and the fine linear branching, as well as the distribution. So just to remind you that we use these. For the HER2 positive cancer, you outlined that it is well known for the calcifications. Do you have any idea what type is prevalent with the calcifications in the HER2 positive cancers? It's just for discussion.
Fine linear or fine linear branching is more common with the DCIS components usually. I think it might be more common with HER2, as HER2 usually associated with an DCIS component.
Yes, that's true. Of course, this is descriptions, but all are suspicious. But the coarse heterogeneous is one of the very famous with the HER2 positive types of cancer. Okay, thank you. Dr. Shayma Hussein. She left? Okay, no problem. Dr. Rania Farouk موجودة؟ طبعا أنا as usual one of the يعني people who are fascinated with your presentations as usual. يعني you are a leader and a pioneer in the pelvic floor imaging. أنا بس النهارده كنت بسرعة قوي سريعة جدا يعني عشان التايم طبعا limited والموضوع اللي بتتكلمي فيه يعني delicate إنما أيوة نقطة في بحر. احنا طبعا عايزين نبقى نتمتع أكتر وأكتر بين المحاضرات بتاعتك يا رانيا، بتبقى جميلة جدا وأنا شخصيا بستفيد بيها جدا جدا جدا. أنا بس عايز أسأل هل في associations ما بين الريكتال برولابس او والانترسبشن وما بين الانتيريور كومبارتمنت برضه برولابس او سيستوسيل او وات ايفر، هل في اسوشيشنز يعني قويه بينهم ولا this is a totally separate entity عندها؟
لا هو حقيقة سؤال حضرتك جميل جدا لان هو فعلا اكتر تو كومبارتمنت لقينا فيهم اسوسيشن هما الانتيريور والبوستيريور، وهم قالوا دلوقتي في نظريه واحد اسمه بابا بيتروس عاملها انها ريليتد باليوتروسيكرال ليجمنت، وبالدراسات والستاتستكس لقينا ان الاسوسيشن موست كومن ما بين الانتيريور سيستوسيل او الانتيريور كومبارتمنت عموما وات ايفر بقى سواء انكونترنس او سيستوسيل والبوستيريور كومبارتمنت، فايت از ا فيري سترونج كورليشن يس.
Very strong.
فايت واز ا سمارت كويستشن.
اوكي طيب ثانك يو. لا لا لا. اتفضل يا فندم، اتفضل. استنى بس عشان نسمع كده، ومعاك المايك اهو.
دكتور احمد بدير، استاذ مساعد اشعه طب الازهر. بالنسبه لحضرتك يعني انا مهتم شويه بالانوريكتال، وكان ليا سابقه يعني ككومبليكيشن، انا نفسي تعبان من الموضوع ده. حضرتك بالنسبه لحالات الانال انكونتيننس، سواء الكونجينيتال في الاطفال او البوست اوبراتيف اللي كتير جدا موجوده مع حالات البايل فيشرز، حضرتك الرول بتاعكم اقوى ولا الرول بتاع الموتيليتي ديس اوردر اقوى؟ واي منهم في بلان للتريتمنت، سواء سفنكتروبلاستي او سفنكتروفي، من اللي احنا نفيده اكتر من الاثنين؟ وكبوست اوبراتيف فولو اب برضه مين الاقوى؟ وانا قريت كتير في ابحاث دلوقتي ان في بعض الاماكن في مصر، ما اعرفش، بس بره في المانيا كنت متواصل مع ناس بيزرعوا ستيم سيل ترانسبلانتيشن في حالات الانال وكده. فممكن حضرتك توضح النقطه دي لو سمحتي؟
طيب هو حاجه الانال انكونتيننس موست كومن في الميل، عشان الفيشر والفيستولا موست كومن بيبقى مور كومن في الميل. تمام.
الستات عندهم برضه
بس ده يعني بالكومنستي بيبقى اكتر في الميلز. بالنسبه للام ار اي، هو في سيكونس مخصوص بيبقى للانال سفنكتر اكومبانيد مع الدايناميك عشان نشوف اللايرز بتاعه الانال سفنكتر. كرول بنشتغل الاثنين مع بعض، الانال مانومتري مع